dinner probably. We hope we'll start a little late. The primary first talk is primary THA, main the fundamentals and implant choices. This is the first session. This first talk is by Dr. Veda Prakash, the hip biomechanics. I'll invite Dr. Veda Prakash.
Good morning, everyone. Thank you, Chairperson.
We are here to listen to you, sir.
Thank you, sir. Thank you.
We are very keen.
Thanks to the Chairpersons and the organizing committee of Tosa Oasiscon for allowing me to give this talk on biomechanics of THR. Can I have the PowerPoint loaded, please? And is there any control from here? So I think we are a little late, so I'll try to finish it on time. So it's 8 minutes, sir. So 5 to 6 minutes, I'll try to finish it off, sir. So the conventional biomechanics variables of center of rotation, what we look at is the offset, the leg length, neck shaft angles, version, and the head size. However, these are usually traditionally measured on a static anatomy based on the plane X-rays, AP view and lateral views. However, the hip behaves dynamically. So now the latest methods that we are trying to evaluate these hip biomechanics are using the sitting X-rays, standing X-rays, lumbar flexion and spinopelvic association with the hip. So I would like to touch upon these things which are more important. Hip is not just a bearing surface, it's a lever. So as we all know, there is abductor force and the body weight, and the fulcrum is at the hip joint. So when the abductor lever arm is short, there is requirement for the greater force from the muscle and effectively increasing the joint reaction force. So what we are trying to pointer, laser pointer. So anyway, when the lever arm is short, the hip abductors need to act much harder to maintain the balance, and which effectively means that the joint reaction force increases quite significantly. So this is a geometry problem because the way the hip joint is eccentrically placed within the pelvis, that actually affects the joint reaction force whenever the lever arm is shortened. Next slide, please. So the femoral offset, again, very important. If you put in too little offset, the abductor mechanism will not function effectively, and there is a possibility of instability, impingement and all other things. Within an optimal functional zone, there is a good leverage and the tension is appropriate in the abductors. When the offset is too much, there is excessive soft tissue tension and altered mechanics, and more often than not, patients will have some lateral thigh pain and stuff. So offset restores the leverage, whereas length restores the height of the patient. So the next concept is what is called as the global offset, so which is not equivalent to femoral offset. More often than not, we try to recreate the femoral anatomy by trying to put the center of the femoral head with the prosthetic head with the native head. However, what we sometimes do not realize is that the center of rotation is also based on where we keep the acetabular shell. So the acetabular offset is also equally important. Too much medialization, superiorization or lateralization of the acetabular center can also affect the global offset. So the cuff position also affects the offset as much as the femoral stem, because when we talk about offset, the first thing that comes to the mind is femoral neck angle and how much lateralization you have done in the femur. So the neck shaft angles are very important to understand how the column, the diaphyseal and core angle changes from extreme values around 140 to 127. So whenever there is change in the varus, we need to choose an implant that can recreate the native offset, femoral offset of the hip. Next slide, please. So, no, the one before, yeah. So, if you look at two patients, sometimes there is a patient with slight length gain, but the offset is very well maintained and their abductor lever arm is functioning well. Sometimes the lengths are equal, but the offset is low, and in those cases, the abductor lever arm may not function very well. So, the important aspect is that although sometimes the patients, we assume that the lengths are equal, but they may feel weak or unstable and they continue to limp. And most of the times we look at abductor power and also the leg lengths, and then we do not understand why this is happening. That could be due to altered offset. Next slide, please. Slide. Anteversion again is very important. Traditionally, we try to look at the cup anteversion much more diligently than the femoral anteversion. However, the combined anteversion, which is the cup anteversion and the femoral version combined, is very important to assess. The functional version envelope, which is the combined anteversion angle, is very important for us to assess when we are trying to place the components in total hip replacement. So nowadays, most image-based robotic systems have come up in knee replacement surgery, and that's the way it is going to go in hip replacement as well. And CT scan will definitely add much more value in complex cases, especially to look at the acetabular version as well as femoral version, because that can vary significantly, and a CT scan can give you a better idea of these versions for you to recreate them on the table. Next, please. So, this is very important for us to understand the newer concept that has been there for the last decade now. So, an implant that you feel is safe when the patient is lying on lateral position in a supine table could be unsafe when the patient is actually sitting because of the changes in the pelvic plane as well as the sacral inclination. And depending on how stiff or how lax the lumbar spine is, these variables can affect the stability of the hip joint. So, this is something that is important for us to understand, not just looking at the hip isolated. So, the static view is something like this, where you are just looking at one static picture on the plane X-ray and think that version is fine, the cup inclination is fine, whereas in the functional view, you need to look at how the relationship between the head, the femoral stem and the acetabulum changes in standing, sitting and walking. Next slide, please. So, someone with a stiff back or stuck in standing with a fused spine or stuck in sitting, all these patients are at a very high risk of instability if you do not look at the lumbar spine evaluation before you do the total hip replacement. So, impingement is something that is very important for us to understand. Malorientation leads to impingement, and that leads to levering of the implant, and then it ends up in a dislocation. So, dislocation is not the initial event, that's a final event. We need to understand from the orientation level, and if there is any impingement happening, whether there is any leverage of the femoral head out of the cup, and then ultimately resulting in dislocation. Next slide, please. Next, please. Again, the head, the big head, will it always impart stability and better range of movement? This is a point of debate for a long time. However, the sweet spot is somewhere between 32 to 36 millimeters, where the jump distance is optimal and increase in the range of motion is clinically more relevant. Beyond 36, any higher size, actually the arm advantage plateaus, and then there is another risk of increased frictional torque at the joint level, and that can actually adversely affect the outcome. Next slide, please. So, as I was mentioning earlier, the leg lengths look equal, but the patient still limps. That is because we haven't restored the femoral offset very well. Next slide, please. Next. So, we need to look into all of these: the center of rotation, offset, length and tension in the soft tissues. Next, please. Dual mobility is a newer concept that is come up in the last decade or so. Because the effective head size becomes much larger because of the dual mobility, the jump distance and effective range of movement are high. Next slide, please. And edge loading is another important concept for us to understand. When the cup is placed in significantly vertical position, then there is a micro separation with every step that we take, and which increases the local contact stress, and that can actually lead to excessive wear or instability over the period. Next please. So this is again classic example where they have actually medialized the acetabulum. However, there is significant lateralization of the femoral stem and leading to excessive soft tissue tension and lateral hip pain. Next slide please. So excessive offset can increase the jump distance. This is very common situation during surgery. When the hip is dislocating, we continue to increase the offset, but initial stability may be achieved on the table, but because of excessive tension, the patient can continue to limp, and then tissues may stretch over a period of time and then can lead to late instability. So optimization is the key. Next please. So the 6 biomechanical targets that we need to look at is, where is the center of rotation, what is the combined offset of femoral stem and acetabulum, length, whether we can optimize the length, the combined anteversion, spinopelvic association, and soft tissue envelope. And the radiographs measure only part of this story, and we need to be cognizant of the dynamics of the biomechanics of the hip. Thank you very much.
Thank you, Dr. Ved Prakash. It was a very great insight into the hip biomechanics, and of late you have shown that the global thinking, that both the acetabulum side and femoral side we have to look into, and the orientation and the offsets, each will have its own effect on the hip biomechanics. Thanks for that great talk. And next I would like to invite Dr. V. Jaganmohan Reddy for his talk on dual mobility constructs in total orthoplasty. Questions we'll have after the session. Good morning, Jagan. Everything
Good
going
morning,
green?
Sir?
Everything going green.
Yes, sir. Green.
Yeah.
Yeah, full screen order. Brother, full screen. That's the thing. Antena? Yes. Good morning, sir. Thanks, sir. Dr. Alwaladi, sir. After seeing you, I got more confidence, and my heart rate was 140 to 160. After seeing you, it has come to 60, sir. Because of tension, I forgot to take propranolol in the morning. I have a few talks today, but I will deliver my lecture, sir. Time starts now. Yeah. Dual mobility, as my previous colleague Dr. Ved has highlighted the point of dual mobility. It is a new concept, came for last 2 decades, and last 1 decade it is more using in primary and revision hip replacements. Dual mobility. I will give a brief current concepts, design evaluation, evidence, and clinical decision making. My name is Jagan. I work at Hyderabad Sindhu Hospital. I'm trained in UK and Osmania Medical College. I'm a former consultant at NHS and did few fellowships and research with Oxford and Warwick University. As you all know that instability is one of the main component in the total hip replacement. We discuss about the problem, design, evidence and application, and few cases I will demonstrate. As you all know that total hip replacement is one of the most successful operation in the century, 20th century, in the medical history. It is reproducible, it gives a good pain relief, but instability is the major concerns for the total hip replacement, especially early designs with the small heads of 22.2 heads, where the lot of dislocations if we don't do the surgery well. Dual mobility is a new thing. It is a rescue for hip replacements. As you all know that total hip replacement instability is a multifactorial surgeon's factors. If we put cup in too vertical, there will be dislocation. Too horizontal, there's impingement and it will cause dislocation. And implant factors like small heads and skirt heads, they're more risk of dislocation. Patient factors like Parkinson's and neuromuscular disorders, they will cause the dislocation. What is the stability in dual mobility? You have a small head, larger head. Larger head will give, that is a modular polyethylene liner, which increases the jump distance, so that you will have more range of motion and the jump distance will increase, the dislocation rate will decreases. A dual mobility construct will have a stabler shell, polyethylene liner and the smaller head. So head in head, you have two articulations that will help in the better range and larger heads. There are designs by the Sir John Charnley has first designed low friction orthoplasty in 1960, and slowly Rambert has designed the dual mobility. The first generation have some flaws in the design. It causes intraprosthetic dislocations, wears and failure rates are more. Second generation, third generation design has improved, highly cross-linked polyethylene and hydroxyapatite coated shells that will give a good rigid fixation, less wear. First generation, the problem is with the metals and the polyliners, and intraprosthetic dislocation is more common. Why? There is no locking system in first generation. And modern will have a good material, stabler shell is coated with hydroxyapatite, and polyethylene liner contains highly cross-linked polyethylene and vitamin E, and necks have improved with highly polished and elliptical shape will decrease the tunionosis, decrease the wear, and fixation and coating has improved a lot. And if you compare the graph, first generation we have a good anatomic versus modular one. Most of the modern DMs are modular ones, like a stabler shell, we have a metal liner, polyethylene bigger head and smaller head. It may be ceramic or a metal head, depends upon the size. It may be 22, 28, 32. And where the DM adds more value in high risk primary total hip replacement and femoral neck fractures, revision for instability, stiff spine and oncological reconstruction and complex THRs, dual mobility has a role. A practical decision is a risk profile. You have to assess the risk profile, you have to assess the anatomy and mechanics of the patient, and you should choose the implant strategies and you should execute, and post-operative you should be vigilant for expecting any complications. In a spinopelvic alignments, if you do a normal THR, there is a very high risk of dislocation, but in DM, because of large jump distance, dislocation rates is almost zero. And femoral neck, we have a lot of instability and fall risk, poor soft tissue and variable bone qualities, and patient will have cognitive problems, abductor insufficiency. In that case, you have a good dual mobility will give a good stability. And revision for instabilities, if you are already dislocated, this will help. And you have to evaluate the failure module, reconstruct the bone and soft tissue, and select the bearing strategies. And complex reconstruction where the soft tissue are damaged, the dual mobility will help in preventing the dislocation. Cost effective wise, initially the DM may be more expensive when compared with the primary total hip replacement, but if you take the risk stratification like a dislocation, if you manage the dislocation, it will be more costly than the initial implant. And why not use the DM for every patient? So why? Because one is a cost. Second one is we don't have a long-term data whether this will give a 30 or 40 years of follow-up. And you have an intraprosthetic dislocation because of the articulation of the small head, bigger head and head and neck junction. There is a possibility of three sides you may have where particles will be more, cobalt chromium levels may be increased, and modular interface and malposition. And intraprosthetic dislocations you should recognize early, but in modern designs it is not possible because the small head will lock into the bigger head. But if it's a failure in the design, there may be a possibility of intraprosthetic dislocation. First, type 1 is the dislocation, type 2 is the inner liner breakage, and type 3 is a cup loosening. And the third articulation design determines the wear behavior. You have more cobalt and chromium levels in dual mobility hips. And survival rates are very good at 5 years, less than 55 years, we have very good survival. And evidence is good, strong signal, and removing the gaps and design dependency, and practically it is useful and best indication, and economic wise it is okay. We'll show few cases. The neck of femur fractures where the soft tissue, osteoporosis problems, abductor weakness, dual mobility will help you in restoring the stability, and it is not a substitute for malposition. Even if the surgeon may think that if I put two vertical about 120 degrees, you may bail out. No. Ved Prakash has asked this morning, can I put the cup in a wrong position? No, no, sir. It has to be a correct position. You should follow the fundamentals of the hip replacement, and DM is not a substitute of malpractice of the surgeon. It helps increase the jump distance, and stability will be more. And these are the few cases with the comminuted subtrochanteric fractures, failed cases, failed Austin moves, and failed Charlie processes. What are this one? The cup position should be as like a primary, and restore the mechanics, check the compatibility, trial the dynamic, and know the complications. Common pitfalls should be avoided, and take home is identify the risk, restore the anatomy, choose the DM wisely, and monitor the outcomes. DM constantly reduce the instability risk, and modern designs have changed the risk profile. Best indicators are selective. You have to select the right patient, choose the right construct, exude orthoplasty wisely. Sir, on time, sir.
Thank you. That's a great.
Yes. Thank you, sir. And we welcome Dr. Alvareddy, sir, who was a chairman for the next TosaCon 2027 we are going to conduct in Hyderabad. Please attend for the next TosaCon 2027 at Hyderabad. Thank you, sir.
I invite Dr. Praveen Meridi, sir. The next talk is on THA in post-traumatic hips, failed DHS, PFN, or hemiarthroplasty. Welcome, sir.
Good morning. At the outset, I would like to thank the organizing committee for giving me this opportunity. If you ask me as a hip surgeon, is this a relatively simple or a complex or a really complicated problem? I would say not just in my experience, and even literature is suggestive that this could be the most challenging arthroplasty for any surgeon, because there is distorted anatomy, and then your landmarks are obviously not going to be very easy to find out, especially for your version when you do a total hip replacement. So I think that is the crux of the whole thing, and your abductors are not functional in most of these IT fractures, especially when you do a DHS or a PFN. They would have a trochanter which is non-functioning. So let's start. So as I mentioned, the fracture pattern, the reduction quality, your lag screw position, these three are
Slides, please.
So fracture pattern, the lag screw position, and the bone quality are something which is not under your control as far as bone quality is concerned, but your main fracture pattern and bone quality are not under your control. Fracture reduction, lag screw position, and your surgeon control factors are under your control. So we should be able to achieve an excellent result in every single time, and so better to get it right first time, especially in hip fractures, because I mentioned the comorbidities and the failure rate is much higher. So let's move on to what are the failure mechanisms. So screw can pull out, like in this case, it's not a controlled collapse, and then lag screw can cut out like that, and another one. So there are many of them. So again, multiple reasons in this for failure, but we just think about, is it just the poor reduction or is it the poor bone quality? So you can always blame the patient, but always try to look at why did it fail from your perspective. And if the reduction also is slightly in varus, it can fail. And like in this particular case, you can see both varus and the implant has obviously failed. So what are the treatment options? You can either revise the fixation, you can go for a bipolar hemiarthroplasty if the windscreen wiper effect has not caused damage to the femoral head or the acetabulum, or you go for a total hip replacement, or do a dual mobility THR as mentioned by Jagan before, that this is one bailout option, especially with the poor abductors. So screw cutout in this case was, again, you can see this in this particular case where there is windscreen wiper effect. So I mentioned this before, distorted anatomy, bone stock, which is very poor, and osteoporosis with the distorted blood supply and disturbed blood supply and poor muscle bulk. And removal of broken screws from a shaft can be a nightmare sometimes if they cold weld, especially when you use a locking type of DHS. Some examples in the DHS situation, comminuted fracture, this was treated elsewhere, and you can see somebody used a long DHS. Obviously, the number of screws don't help you if your reduction or the fracture pattern was not. Then again, they went ahead and did another redo fixation. Obviously, it failed, and then this was revised to a PFNA, and again that failed. So essentially, it went on for a total hip replacement, as mentioned. This patient was doing well at the last follow-up. This is another one, as you can see, screw cutout, this was revised, and this is another one where you can see multiple procedures were already done. Patient came to us with Klebsiella pneumoniae, and we did 2-stage. She was doing well for 1 year, but then again she developed infection secondary to UTI. So these are challenging ones. As I mentioned, you can see conversion to THA following prior failed DHS tends to be associated with poorer clinical and radiological outcomes, especially in osteoporotic bones. So to conclude, as far as DHS failure or PFN failure is concerned, pre-op counseling is the key. You want to get your first attempt right, and we have to overcome technical difficulties which I mentioned before. And post-operative rehabilitation is again has a significant role because patient loses confidence in weight bearing and ambulation. So you need to remember that. Now coming to the hemiarthroplasty, we all know we see these very frequently, and most of the time it could be protrusio or the stem which is toggling in an uncemented stem which was meant to be put as a cemented one. So goals, yes, you want to control the pain, you want to achieve mobility, and the 1-year mortality after any femoral neck or the IT fracture is reported to be somewhere around 30%. So you need to be very wary about that. And then the standard of care is you want to revise them to a modular THA. Various locations for the pain, I think this is very obvious, and then you always rule out infection in any failed, whether it is a fixation or bipolar hemi. So instability is another issue. If you haven't balanced the hip well, that is something which you need to keep about, and intraoperative or postoperative periprosthetic fractures are issues when you take out these stems or put a new one. Always do the thorough clinical examination for the looking for specific alarm bells, and make sure distal neurovascular status is assessed and documented, especially if somebody did a posterior approach before and if they had a postoperative sciatic nerve palsy. And then look for infection, as I mentioned before, appropriate x-rays, and then you have to plan before you go in. You have to be prepared for all the armamentarium. As I said, these are the most challenging ones as a hip surgeon you would face. And let's move on. So what are the intraoperative challenges? I think we mentioned about the abductor dysfunction, poor soft tissue quality, acetabular bone loss, and removal of cemented femoral stem. These can be tricky. So you may need to do a extended trochanteric osteotomy if it was a cemented one. Sometimes the cement mantle can be so distal and thick that you may have to do this. There is an algorithm which is clearly giving you all the options, and conversion has high complication rates and loosening. So you need to keep that in the background, and we all know about the possible complications. And my thoughts are, why do these fail? Your first choice of implant, cemented versus uncemented, modular versus non-modular. You want to use cemented whenever possible in an elderly person. If it is possible to do an uncemented, I don't have a problem with that, but you should get a good fixation and you should not cause an intraoperative fracture. Then coming to poly wear and cartilage wear in bipolar hemi, you need to keep that in mind. And then subsidence of an Austin Moore and bone loss. These are the common ones, and suboptimal surgical technique is another issue which you have to improve. So you can see various examples how they present to you. Cemented bipolar hemi, then protrusio, then uncemented, which is not having any fixation, so it will start toggling on day 1. So these are the examples, and I just wanted to show you a few cases what we have done. This 12 months post-op persistent pain. it's obviously loose, and this was a hybrid THR, cemented stem and uncemented cup. And this is another one, keep going. 3 years post cemented bipolar, again they start failing. I mean, they should at least last 7 to 8 years or 10 years at least. If they start failing in 2 to 3 years, that's not a good result, is it? Again, another one, you can see, we have seen many broken stems actually. If you notice in this presentation, you will see how many broken stems were there. If you just keep seeing, that is a differential loading of a well fixed distal part and a poorly fixed proximal part and a poor quality of the implant. These are the reasons for that failure. And again, another one, so you will have a collection of these when you see. This is another one where somebody did this uncemented one and then it broke. Even a good quality implant can break when you have differential loading. So this needed a long plate as well, and the patient did well. So to summarize, basically, yes, there are problems. You need to sort them out. You need to get it right first time. And infection, always keep it in the back of the mind that is it a possible infection. So to take home THR after failed hemiarthroplasty is challenging, and it requires thorough preoperative planning. Good outcomes can be achieved with meticulous surgical technique, and you have to get it right first time and do not compromise on the quality of process. Even if you don't charge surgeon fees, it's fine. Longevity is the key. Higher complication rate should be noted and counseled with the patient. Thank you.
Thank you, sir. It was a very enlightening talk.
Thank you.
I next invite Dr. Shiva Chella, sir, on enhanced recovery after THA. Welcome, Dr. Shiva, sir.
Thank you, sir. At the outset, I would like to thank the organizers and Tosa and obviously Warangal for hosting us and giving us an opportunity. Connect directly. So I've learned a lot while preparing for this topic itself, because I was not aware of many of things which I'm about to talk right now. So ERAS is nothing but enhanced recovery after surgery, which has been adapted to total hip arthroplasty itself. And what exactly does it entail is, and why should we adopt is the objective of my talk, obviously. What does the evidence say right now? What are the preoperative imperatives? What are the intraoperative imperatives? Post-op, and also the anesthesia and analgesia changes that we need to bring into our practice. So what does the evidence say? Lee and Kim in 2025 were the first people to have done at the largest study, which involved 21 studies and 2,163 patients in a landmark meta-analysis, which actually has brought in an inference that the length of stay was reduced by 30 to 50% in patients who actually have been brought onto the ERAS protocol. And the readmission rates, not much of a difference post ERAS protocol implementation, but it was significant difference was seen in when it comes to the blood loss, where Aldosari et al. Had published a study on 7,200 patients and observed that the intra-blood loss decreased significantly after adopting ERAS. The other surgical branches are adopting ERAS now, but orthopedics itself has picked up beyond 2020. And it was a Denmark orthopedic surgeon himself, Dr. Henrik Kellett, who actually introduced this term. So an extension of this particular study, we do the forest plot analysis. What exactly was the inference from this study was the VAS score was actually very low when at the PACU level, 3 hours post-op and also 6 hours post-op. There was a reduction in the medical complications, and the post-op transfusion rates have significantly decreased both statistically and clinically. And surgical complications unfortunately fall on the surgeon, and it's not ERAS, and so there was not much of a change which is attributable to the ERAS. So Switzerland was the first country which adopted it in full scale, and it just a decade ago. And what they actually observed was they've actually started it in a stepwise integration where the surgeons, anesthetists, and the post-op discharge team were actually in alignment. And what they've observed is there is obviously 10 days less length of stay has been reduced to 5 days over a decade, which is again a 50% reduction, which is a significant achievement when it comes to the Western communities, where the patients are directly discharged to their home and not in institutional or rehabs. And the secondary gains obviously were reduced urinary catheter use, reduced opioid administration, and lower hemoglobin drop and fewer blood transfusions post-THF. So what does ERAS entail? We are going to talk about the pre-op optimization, which is building up the physiological reserve of the patient before the knife actually falls on the patient. So how do we do this? Prehabilitation involves exercise and nutritional education for the patient, where exercise prescription, especially 4 to 6 weeks before the surgery, it's recommended that aerobic exercises or resistance exercises are supposed to be, especially concentrating on the hip abductors and the quadriceps strengthening, should be prioritized. BMI optimization, which is quite difficult, obviously when it's more than 40 kilograms per meter square, the complication rates are 3 times higher, so that should be concentrated on. Smoking and alcohol cessation for more than 4 weeks has reduced the complications by more than 50%, which is a modifiable factor, so we should be concentrating more in the pre-op time. What exactly are we doing on the nutritional aspect? The preoperative carbohydrate loading, which is about 200 ml of carbohydrate drink, should be given 2 hours before surgery, which reduces the catabolic response post-operatively. This is difficult to implement with the anesthetic. So what do we do? IV 1 gram. The Association of Hip and Knee Surgeons has guidelines recommend that TXA is given 1 gram preoperatively and 1 gram during wound closure, which actually gives both these effects together. So what are the anesthetic and the analgesic, not general anesthesia, because the post-op recovery and the morbidity and also the nausea vomiting factors have to be accounted for. What does spinal anesthesia do? It obviously gives lesser blood loss reduction because of hypotension being maintained intraoperatively, and there is a faster PACU discharge, lower opioid requirement, which was published last month. In fact, it was a prospect study which by the anesthesia colleagues, who actually are now recommended this suprafacial iliaca block to be given preoperatively 12 to 18 hours before the surgery, which actually reduces the postoperative motor deficits which can be seen post spinal anesthesia. And also if trained enough, you can give the pericapsular nerve group blocks, which actually help in maintaining the motor capabilities post-op. Prospect also informed what exactly, has also published what exactly not to be given to the patient. The last 3 are the most important ones, where we generally do gabapentinoids, infrainguinal fascial iliaca block, and patients, as previously mentioned, on the length of stay of the patient. It has been proven that the blood transfusion rates post-op, gluteus minimus damage, and also Harris-Hip score have a femoral fracture and lateral femoral cutaneous nerve are at risk. What are the bearing surfaces? Ceramic and protocol. And drain use not recommended usually, and it should be removed if at all applied within 6 hours. The post-op recovery is the most important part of ERAS, where prophylaxis, urinary catheter, the most important part of ERAS, where prophylaxis, urinary catheter, more or less in the discharge and also the pain control.
Please conclude.
It's very insightful. Apart from THA, we can include all these protocols in many. Thank you.
Thank you, sir.
I would like to invite Dr. Adarsh for his talk on robotics, DHA, the robotic man we have here. He has got all the robots with him, so he has got a great orientation about. So he has got a great orientation about robotics and hip. Robotics and hip. We'll hope we'll.
I think a robot owns us now. We don't own the robot.
Hope we'll.
I think a robot owns us now. We don't own the robot. So very good morning to everyone. I'd like to thank Tosacon and Oasiscon for inviting me here today. Great to see familiar faces and all my gurus. So I'm going to be speaking about robot-assisted THR. As the previous speakers have all spoken about the biomechanics, very beautifully elaborated by everyone. I'm just going to show how this technology can make all these things a little easier to achieve. So first of all, the particular robot I'm speaking about is the Stryker Mako. So as of now, the only robot which has true robotics for the hip is the Mako. Other companies are trying to come up with it, but more of navigation. But right now I'm speaking about the Stryker Mako robot. So first of all, the question you may ask is, why do we need it? Because when THR is the forgotten joint, has uniformly great results, good forgotten joint scores, the hip surgeon usually feels like a Superman. He feels that he can't do anything wrong. But then you start thinking about so many things that can go wrong, the cup antiversion, inclination, sizing, femur sizing. And then when you realize that small bits of malpositioning, like have been spoken by the previous speakers, can cause so many issues. So then you start to feel a little nervous. And then you think even more into depth, the cup depth, height, the bone stock, limb length discrepancies is such an important thing now. And then you realize that there are so many variables which can potentially go wrong. And then the hip surgeon gets brought back down to earth. He's no longer feeling like a Superman. So when you have so many issues that can happen because of cup positioning, like impingement, restricted range of motion, wear and loosening, dislocation, which is one of the most dreaded things, so then you start feeling a little nervous. So what if we can address all of these things at once? So the robot can help with all of these different variables in hip replacement surgery in one single go. So first of all, in robotic hip replacement, you need to get a CT scan, and this is all segmented to form a 3D model. So this is what it looks like. All the slices are made and the 3D model is made. So each patient's anatomy is always there with us before the surgery even starts. And we actually plan out the surgery before the surgery even starts. This is the OT layout. Yes, it's a little bulky. It's just like another assistant. So instead of having your favorite assistant, you can have this guy in place of it. So I'm just talking about the lateral position, posterior approach. The robot comes in from the contralateral side, and the camera lies next to the anesthetist chair. So if you just look at the workflow in brief, you have pre-op planning, then you have to place your landmarks, you have to place your pelvic arrays, you have to start something called as registration, which is the most important step in, and the cup impaction as well, planned or not. So let's talk about the implant planning step. Earlier we were doing 2D manual planning for a 3D joint. So now it shifted towards the 3D planning of the same. So that's where the functional cup placement, the whole concept comes into play. So you get a 3D reconstruction and a pre-op limb length assessment. So you can always know beforehand exactly how much shorter or longer you are. So this particular case, you're 3 millimeters longer versus the opposite hip. And you can also see what you're going to look like after putting your trial implants. And this is all virtual implants. You can see by putting these particular implants, I'm able to get almost equal length to the opposite side. It also helps in the acetabular component placement. So you can see the sizing and the angle in all the three planes, transverse, sagittal and the coronal. You can see the 3D view as well. And you can see whether your size is good, you can see whether your position is good, you can see whether your angle is good for that particular patient. You can also restore the center of rotation. The green is the center of rotation of the new hip, and the purple is the center of rotation of the native hip. So you can try to match it as close as possible as well. So next, now as I was mentioned earlier, the pelvic tilt and sacral slope is something very important. The hip is not going to be the same when you're sitting and when you're standing, and it's even more compounding when you have a stiff spine and a stiff hip. Sacral slope values into the robot, and this data helps the robot to help you decide what the actual cup placement will be right for this particular patient. So I'll just show you an example of this. In this particular incident, let's say that we were planning 40 degrees of inclination and 25 degrees of anteversion. And when we took this through the virtual range of motion, let's say 25 degrees or 30 degrees of extension and external rotation, it was impinging posteriorly. You can see the red dot over here, right? So then what we do is we can change our virtual cup position to make sure that impingement goes away. So I'll reduce that 25 degrees down to around 23, and you can see that impingement is gone. So this is how this virtual range of motion helps us to tailor make the anteversion angles and inclination angles for each patient. Then you can also plan the femoral component sizing and the offset adjustment, and you get a beautiful pre-op visualization of the post-op x-ray. So most of the time your post-op x-ray will be exactly the same as this. You can also use the digital ruler and a neck resection view to determine the exactly level of the neck cut and the anteversion of your stem which you have put in. So this gives us even more additional information. Again, as I said earlier, reaming, we no longer have to do serial reaming. We've already planned everything out. Once you've planned it, you put your reamer in, you can look at the screen and just take out the green portion of the bone. Single ream now. We've also published that this has led to less blood loss and less bone loss as well. And this also saves a lot of time because you're not guessing now. You can just go in, directly go and take out that green bone, and you finished your reaming procedure. After that, the impaction is also helped by the robot. It locks into the angle that you've planned. Planned is 40-20. You put in your cup and then you lock it. It goes to the 40-20 angle that you've planned. Then you start to impact, and you can see that it tells you how much proud you are. So your 2, you have to bring it down to 1 or 0, and then you stop there and take out your impactor. So it actually locks it into the position that you have planned and to the depth that you planned. It gives you the reduction results as well after you're done to make sure you have actually achieved what you've planned as well. Okay, and we already know what the x-rays are going to look like. So this, as I said, always will be replicating what exactly the pre-op visualization of the post-op x-rays. What about procedure time? Everybody, obviously the first few cases, maybe first 25 to 30 cases, you're going to take longer, and also the registration takes a little longer. But as we went forward, we realized we're saving time in the reaming and impaction. We don't trial anymore, so we are actually saving time there. So at the end of maybe 30 to 40 cases, you become time neutral. What does it mean for the patient? Reduced surgical time and blood loss, unparalleled accuracy. We restored the limb length to pre-pathological state. Reduced tissue trauma. Never promise the patient reduced incisions. It is not a reduced incision, but the amount of tissue trauma inside is going to be less. Reduced trial and error and subjective feel is now gone out of the window. So as I said earlier, few case examples. You can always know what the x-rays are going to look like. You just replicate them. Dysplastic hips, I think, is one of the most important uses of robotic hip because you know exactly where your bone stock is going to be. You can plan it out and you can make sure that you get your cup in with the minimum bone loss. Then you have cases where you have hardware in situ, where you can actually adjust your cup position to not hit your plates. You can actually manage to avoid taking out the plates as well, in this case as well as this case. And protrusio cases also, you can manage to go without going for too much of a hardware there. This kind of a case, I'll just show you. This is a case which has the stem was in 20 degrees of version and it was impinging posteriorly like this, okay, at 40 degrees, 20 degrees of the normal cup position. So what we did is we brought that down to 12 degrees of version and you can see that the impingement has reduced quite a bit. So the combined anteversion of 20 degrees of the stem plus 12 degrees of the cup was 32, which is right in the middle of the range for males, and we got away with a very beautiful hip replacement. Some literature on this. This is one of the famous papers by Richard Ilgen, where he followed up his last 100 conventional cases, his first robotic 100 cases and his next 100 robotic cases, and he found that even from the beginning the robotic hips are much more accurate than his last 100 conventional cases. I just have two more papers to show. This is a paper that we've published where we showed that the radiological outcomes in robotic hips are much more accurate than conventional. We've also found blood loss is less in the robotic cohort, and this paper also showed that the amount of bone loss, the volumetric bone loss, is also less in the robotic cohort. Thank you so much for the patient listening.
Thank you, Dr. Adarsh, for the great analysis and insight of how a robot helps in great precision and probably in the long term will have great results.
Thank you, sir.
Thank you. So I would like to, there is a little change. I would like to invite Dr. Balraj Naidu for his talk on robotics in complex TKR with retained TKR with retained hardware, because he has got some urgent work, so there is a little change. Please kindly note. Dr. Balraj Naidu. Slides, please.
Very good morning to everyone. Thank you so much, Maheshwar sir, Tosa and Oasis organizing team, and chairpersons Dr. Abhiram, who is my classmate, and senior surgeons Alwal Reddy sir and Vishwanath sir. Thank you so much, sir. Today's topic, the robotics in complex TKR. Many doctors have asked me, like, one question, whether robotics is a marketing tool or surgeon friend. After watching, Adar's video, it's a surgeon friend. I always say it is a surgeon friend. It will be definitely helping us. In the coming years, it will be like Siam, maybe 2030 or 2035. And this case is like, bilateral left side TKR done 2025 January, and then patient had unfortunately fall and underwent PFN surgery, and a significant history of pain. Patient want to undergo surgery. 6 months back PFN done. They don't want to wait for another 4 months to get implant removed. So they did a lot of research in ChatGPT, and then found out that robotics will definitely help not to remove the implant and go ahead with a total knee replacement. And this is the J-Planner software. Usually whenever there is a metal, it definitely creates a lot of artifacts. So using latest software upgrade, we can remove all the artifacts. there is inside the femur, you can see the implant. However, you can get a beautiful final 3D plan in less than 2 minutes. In 2016, this planning, you need to send a CT scan to Singapore or USA. It takes almost 1 week time to get it planned. So the designers have reduced 6 weeks time or 4 weeks time or 2 weeks time to 2 minutes. Imagine how much development it's going in back end. In this JPlanner software, they use a lot of artificial intelligence, and you'll get a 3D plan like this in less than 2 minutes. And the accuracy of the robotics, many people ask, it is sub-millimeter accuracy. Once you plan it, definitely it will, as per plan, it will go. This is the final plan. I do automated robotic surgery, like QVs and meso. And as it is automated, the tibia implant little anterior, I keep it. And in this Tosa Oasis conference also, many surgeons ask me, what are the complications you are going to get? So the complications are associated with robotics. Is one of these, like more of pin related complications. Most of the time while you are removing the pins, the assistant surgeon, if little careful, the pins may break and periprosthetic fractures may happen. If sometimes trackers or sensor doesn't work, then robot will be working in a different pace. So always you should be little cautious while performing the robotic surgery. I request anyone, because many company people are trying to approach a surgeon, you do 15 cases a month, you would buy this robot. So always believe you do first 100 knee replacement surgery with conventional technique, then only you proceed for robotics. Robotics is the tool which will help the surgeon to fine tune it and improve more accuracy. Robot is like more of surgeon friend assistant rather than it is a automated surgery. And this is like registration, standard registration. Registration will take less than 2 minutes. So many people ask whether robots make a mistake. Usually the designers have designed in such a way that RMSE value. This is a CT based robot. Before surgery we take a preoperative CT scan. And again I need to map intraoperatively whether the bony landmarks like medial femoral condyle, lateral femoral condyle, medial epicondyle, and then distal femur, proximal tibia, everything should be matched. The RMSE value should be less than 1. So preoperatively, intraoperatively, if there is something wrong, then robot will not allow further to move forward. All these steps will take less than 2 minutes if you are doing daily on case basis. Almost 3 times it takes calibration intraoperatively. And this is the final picture. So more of robotics, I do lateral balancing. So I keep around 7 mm to 8 mm on the lateral side. Medial side I do soft tissue release. I don't want to, my patients are really happy with this technique. I am switching to that rather than keeping tibia in varus or 3 degrees varus or 2 degrees varus. I do balance on the lateral side. Then remaining medial side I do soft tissue release. Sometimes if required I do osteotomy of the medial reduction osteotomy. So this patient I kept 7 and 9 mm is the maximum gaps, and captured gaps are 7 mm on the lateral side. Medial side, if you look at it, 5 mm. So this is like why I like this QS robot is fully automation. Once the gap balancing is done, you need to hand out to the robot. This is a fully till date did not commit even 0.1% mistake. Only once the technician moved the navigation marker which is attached to the robot, then it was not able to sense it. It is cutting in the middle of the femur. That happened only because the technician moved the navigation marker. And if everything goes well, tibia cuts and femur cuts can be done in less than 10 minutes. And many people ask, robotic surgery is time little lag. No, if you do monthly 15 to 20 cases, you can reduce to less than 55 minutes skin to skin. And this is seamless surgery. surgeon really can stand outside and no need to ask for whether it is cutting proper or not. Definitely it is almost 100% accurate. Always once you cut the femur and tibia, once you are coming to the tibia, again it will ask for calibration, because is there anything change in the placement of the markers or not. So in this case we did not remove implant, and this is the final X-ray. If you look at gaps on the post-operative, like once the cuts are done, the gaps are around 11 mm on the lateral side and 12 mm on the femur side, flexion and extension gap. So I kept 11 mm poly. I always keep 1 mm little lax, so that post-operative patient gets neutral knee. And thank you so much. Future is going to be like artificial intelligence, robotics, augmented reality, virtual reality. This is the 4th time we are conducting ONUS RoboCon 4.0. There will be a lot of live surgeries. We are planning cadaver workshop, relive surgeries. It will be on 29th of November. We warmly welcome you all to the ONUS RoboCon. Thank you so much for your valuable time.
Thank you, Dr. Balaraj Naidu.
Special thanks to Alwal Reddy sir, Abhiram and Vishwanath sir and Maheshwar sir for allowing me. I am traveling to China, that's why I presented a little earlier, sir. Thank you.
Thank you. You wait for the question answer section. So we'll invite all the speakers come on to the dais for the question answer session. Dr. Veda Prakash, Dr. V. Jaganmohan Reddy, Dr. Praveen Mereddy, Dr. Shiva Challa. 10 minutes. So this question answer time is only 10 minutes because already we are running late. Today we started late. So we'll restrict to only 10 minutes. So please somebody hand over the mics to the delegates. Any questions? So, Dr. Praveen Mereddy, I will have long. Okay.
So one question, sir, to the robotic panel. So basically, if you take a summary of the robotics, is it going to be image-based, imageless? Is it going to be handheld, or is it going to be machine-operated? What would be the super robot that will happen in the next 10 years, perhaps, or 5 years?
Yeah, great question. So, as Dr. Balaj said, things are really moving rapidly. So, I think the ideal robot in the future will be a reduced size, a pinless, handheld if possible, and imageless if possible. If you can get the imageless to as accurate as an image-based. At the moment, image-based has a slight edge in terms of accuracy. So, yeah, the ideal robot would be small profile, no pins, maybe handheld and imageless if possible. And probably AI integrated as well, as he mentioned.
So, like robot companies are doing a lot of research, because some surgeons want CT based like Stryker Mako, and some surgeons want like Zimmer based, like where only jig should come and the tip you need to cut it, and then some surgeons like me want fully automated. So the MISO is coming with all 3 options. So because some surgeons want to feel, they want to cut the bone feel. That's where they are integrating. Future will be combination of all this, but it takes another 1-2 years.
Sir?
Yes, Mithun.
So basically, we have seen robots have come in large numbers into knee joints, hip joints, UKRs. Where do you see robots coming into the next joints, like the shoulders, or maybe?
Yeah, already the shoulder is in pipeline. It is tested in the Western countries, US and European countries. They are all testing about the shoulder replacements by robotics. But robotics will soon introduce into the trauma system also, like a fracture management, especially smaller joints like a CMC joint, MCP joint. You want to replace the MCP joint replacement or first CMC joint replacement. Robots will help. where you will get robo for all. Even if you want to do smaller things like ingrowing toenail excision, robo will help. Precision cut.
I think that's more. I mean, my take is that in spite of robots being in use for more than 15 years now, 20 years now, you know what percentage of robotic TKs are done as a proportion of total number of TKs in USA? Any guesses?
30%?
Sorry?
30%?
No, sir. Less than that, 15%. So, in a country like USA, where robo has been in place for more than 2 decades now, the adaptation rate is about 15%, 15 to 16%. In continental Europe, where public funded health systems are in vogue, it's much less, maybe in single digits. I'm sure it is in single digits actually. In UK, probably it is less than 5% or whatever. And so, I mean, there should be a balanced view. I mean, I use robo myself, but there should be a balanced view. Robo is certainly useful in arthroplasty, but not in every case. And robo cannot replace a surgeon's idea of soft tissue handling and many other things that go, during surgery, especially in knee replacement surgery, essentially soft tissue surgery. Bony cuts are always secondary. So as long as you know, I mean, whatever 1 degree, 2 degree variation that you can make with a robo, you could as well do with any good implant system yourself manually. So it's not that robo would actually take over orthopedic surgery in the future, but the actual real usage of robo will be where if you are doing osteotomies, if you are doing HTO and DFO, where you cannot actually get the limb length axis accurately with a C-arm imaging, you put a long line and then you keep on changing it multiple times. In osteotomies, it will be much more useful, if I may say. In difficult fractures, actually, it can be much more useful, not to get into too much of valgus, varus or whatever. I think, but because of market forces, it is predominantly used in TKRs and THRs. But my guess is that in joint replacement surgery, still the conventional will hold good, even after 20 years in India, as we have seen in USA. That's my take on it.
And that was a great insight, Dr. Veda. So my opinion will be, suppose there is an implant inside, that's a definite indication. That is a dysplasia, that's a definite indication.
Even with implant inside, we've been doing TKRs and THRs without
so
robo.
Intramedullary nail is there.
Absolutely, we can use it. We can use a C-arm. We can use a C-arm.
C-arm, yeah.
I did many cases before robo was in India. You can just use a C-arm. You can get where the hip center is, where the knee center is, and that's all you needed. Nothing more than that actually.
Yeah.
And robo doesn't add any value to more than what you can do with a C-arm. Even to get a tibial cut right, you can just get a C-arm in, get where the center of ankle is, which is much more accurate than actually putting your tracker on the medial and lateral soft tissue envelope, because you do not know how much thick the soft tissue is beyond the ankle. So I think, I'm not against robo, certainly not, but I am not for saying that this is the only way to do it or this is the future. Not even to say that that's the future. It has its own limitations, it has its added value in some cases certainly, but certainly the surgeon and the surgeon's understanding of the whole process is much more important, I believe.
That's what Dr. Adarsh has told. It's only a tool. It should not rule us. We use it as a tool and definitely to get a better result for the patient. And,
Very intelligent assistant, which can also make mistakes.
Yeah, definitely. And
Intelligence can also make mistakes.
Suddenly
An intelligent assistant which can make mistakes, and surgeon should be good enough to understand when it is making a mistake.
So if there is anything going wrong grossly, the surgeon should be competent, as Dr. Adarsh has told. Minimum, we should do minimum 100 THRs before embarking onto any robo. So because we should have that primary skill and understanding of the surgery. So probably it's only a tool and a great assistant.
One last question, sir.
Yes, sir.
So I think all of you have proved that inculcation of robotics in heavy numbers is very much possible in India, knowing the work that all of you do, such amazing work. I feel that the next problem with robotics might be where AI comes into it. Because what will happen is there might be a situation where a robot with an AI will say, perhaps this is the best way to manage the patient. And maybe your experience might be something different. So how are you going to wed that into patient care.
Yeah. So as long as the robot only suggests, you're okay. Like wife suggesting is different from robot suggesting. When wife suggests, you have to accept it. So this is not like that. If it suggests, you should be able to override it. It is only giving you an idea that this is one way to do it. But as sir said, you need to be able to handle it. You need to be able to think, no, I don't think this is better. I would rather do this way. And no robotic system will thrive if it's going to supersede the surgeon's thought process.
Mithun, you should understand the tagline, bottom line. ChatGPT makes mistake. You should know that.
And regarding the indication in USA, 30% what sir is saying is true. And India also, most of the insurance companies are mailing to hospital also. Robotic knee replacement surgery is not indicated by GAC. GAC is also formed by the insurance companies. That's the one thing. But robot companies are very smart and they reduce the cost. If it is look at 2016, around cost is around 16 crores. Now it's 2.2. They will make sure that it will be like Siam. So we are offering initially 2 lakhs, now come down to 1 lakh. The second thing Ved Prakash sir told, I want to ask you, retained hardware in the femur. How exactly you are going to decide valgus of the femur, or there is an implant inside the femur, like what I presented.
I mean, you take a long leg alignment view, as you always did, and as I always do for every case, and then you know what your DFA value is. Actually, you are cutting perpendicular to the mechanical axis, irrespective of whatever it is doing. So your mechanical axis is center of femur and center of knee, which you can get with an external, jig. I mean, which we used to do even before intermedullary arrived. I mean, when I was training in NIMS, we had only extramedullary jig.
Yeah, we used
Never
to put
had,
some ECG leads
on the hip.
ASIS
3 ECG
center
leads
with
and
a
then
cautery cable.
get a cautery cable, and then that's how we learned. So, and that's why I did even before Jobo came in. So,
I think the conversation is going more into robotics. I'll ask a question to Dr. Shiva. The ERAS very beautiful talk. Have you tried it yet? I think you said you'd seen it for the first time when preparing for it. But are you planning to implement it? It looks very promising.
Implementation is the most difficult part because it's, first of all, it's an MDT thing which actually makes it more difficult because we have to involve our anesthetic team, our physiotherapy team. Most of the physiotherapists are freelancers in our country. So having an alignment where you are trying to ambulate the patient within 4 to 6 hours post THA is quite challenging because we make sure that the patient is resting for 24 hours. That's common practice. I'm not saying it's only mine, or maybe I'm generalizing the statement, but 4 to 6 hours post-op ambulation is a challenge still, and that's something which the anesthetists, ourselves, and the physiotherapists need to consider.
Shiva, so if we are giving blocks nowadays, of late we have most depending on the blocks. It's very tough to ambulate immediately before the block wears off.
That's the reason why the Prospect study came up last month, which actually suggests we give a suprainguinal fascia iliaca block or a pericapsular nerve group block, which includes
Local.
The motor function is still preserved.
I mean, even in TCAR, that's the same thing. So the IPAC blocks and all these, they spare the quads. So I mean, in ERAS, that's the main thing. Selective blocking of the periarticular nerves.
Even after giving all the data to the robo, is it committing mistakes?
Yeah, it will. It's as good as ChatGPT. I mean, it's as good as ChatGPT. I mean, what else you can expect from it? It can hallucinate, it can do mistakes, and it does. I mean, I'm open here. It does. If someone says that it doesn't, probably they didn't understand that it did.
Surgeons should be extra vigilant while doing these TKRs. They should not,
Thank you. We are running short of time. We have started late. That was a great discussion, and thanks to all the organizers. And wait a minute, sir. So, yes, sir.
Excellent session. I thank Alwal Reddy sir for chairing this session. I request all the speakers along with the chairmen to be felicitated. In the meantime, hostage of time, we are starting the next session. That's on primary TKR technology, and I request Dr. Bhunesh Garu, Dr. K. Mahendra Kumar Reddy, Dr. Kancharla Sudhir to chair this session, please.
Oh, photo.
Yeah. Yeah, no problem. We are
Kunaldeep next. Thank you, everyone. Request all the speakers and this thing, let us stick to the time and see that we go on schedule. Thank you.
Yeah, I welcome Dr. Kunaldeep. Good morning, and please go ahead with your presentation.
Good morning, one and all. And at the outset, I would like to thank the organizers for this wonderful organization and inviting me over and making me a part of this wonderful conference. So today I have come here to talk about understanding native knee biomechanics, which is such a basic subject, but still advanced. The scientific basis for knee alignments in TKR. I am Dr. Kunaldeep, consultant orthopedic surgeon from Madurai. So basic understanding of knee biomechanics takes us to flexion and extension, which are not the only movements that happen in the knee, and it is a complex multiplanar movement, and it is not a simple hinge joint. So there are three more movements that happen in the knee, that is varus valgus rotation, that happens while mostly climbing up and down the stairs, and there are two more movements which are screw home movement and rollback phenomenon, which make the knee joint far more complex than a simple hinge joint. So the screw home movement is the movement that locks the joint in extension, the external rotation of the tibia over the femur during full extension, which gives a complete stability of the knee to stand for long times. So this is the basis of standing for long times. And the other one is the rollback phenomenon. So rollback phenomenon, the basis of rollback phenomenon stems from the disparity of the medial and lateral condyle of the tibia. So the medial condyle is more a ball and socket type of a joint, and the lateral condyle is more a planar type of a joint. And this is the basis of many medial stabilized inserts or medial pivot inserts that are coming up right now. So now coming into the Asian population and the Caucasian difference. So the Caucasian population has most of their knees in mechanical axis type of alignment, in which the most of the knees are aligned to 0 degrees. So this bell curve shifts to the left in Asian populations, where more varus knees are seen in our population, and it has been said by Arun Mullaji as 5 degrees. So this 5 degrees of varus alignment gives us an early medial compartment stress and strain, and this causes early medial compartment wear. So these are the few things I would like to reiterate. So there is a mechanical axis deviation, according to Arun Mullaji, it's 5.12 degrees varus, and there is a tibial femoral joint load more on the medial side, which predisposes us to early medial condylar wear, and also there is a lot of lateral laxity in our Indian population, especially because of crossed leg sitting. So this also has to be taken into account in our TKS. So CPAC classification by McDessie et al. Is a landmark paper which brought in the idea of the various variations in all the knee joints, and this is the basis of today's robotics. As my previous speakers have already spoken about robotics in detail, this is something that is the basis of everything. So the most of the people are, this takes into the count of joint line obliquity and the arithmetic hip knee axis, and both these are neutral, then the hip knee axis is 0, which gives you the normal 0 degree mechanical alignment, and this is very, very rare. Less than 5% of the global population come into this particular group. So most of the Asian populations, we come into this group of apex distal varus, which is CPAC type 1. So this is the alignment evolution that has been happening over time. So you would see the timeline very commonly. Insol et al. From 1985, when they started off with all the knee replacements, it started with the mechanical alignment, which then forwarded by Dorset et al. With a radically different alignment, that was kinematic alignment in 2012. Way back in 2012, this kinematic alignment came into being. And then after technology entered our spaces, we started the restricted kinematic alignment and inverse kinematic alignment somewhere around 2021. And then now we are getting a lot of noise about functional alignment, which is more commonly used by our surgeons here with technology. So mechanical alignment is the dogmatic standard which has been there for time immemorial from of TKA, but this usually places the knee joint into changes the native joint line obliquity, and then they bring the CPAC 1 patients to CPAC 5, so which artificially elevates the joint line and fundamentally changes the ligament tensioning, leading to unnatural feeling joints and those 20% who are not happy. So then came in the kinematic alignment, which was equal resection of the femur in the distal as well as posterior condyles, which aimed at resurfacing the femur. So this particular alignment was in vogue for a very long time, but there were a lot of against this particular voice against this particular alignment. That unrestricted kinematic alignment gives implant positions which are very extreme, and these implant positions cause a lot of stress concerns and potential long-term tibial migration issues. So these are the certain x-rays in which we see kinematic alignment. Sometimes the medial stress is quite too much, and especially in Indian populations where you see x-rays like this, kinematic alignment is going to give you extreme implant positions which are going to be very difficult in long term. So then came in this restricted kinematic alignment. So to make all the kinematic alignment right, once technology came in, we could bring in the control of how much of varus we can keep on using our machines. And so this came into being, and this gave a bony cut restricted to plus or minus 5 degrees and HKA safe zone of plus or minus 3 degrees. This inverse kinematic alignment also prioritizes a pre-arthritic alignment, which tries to restore the pretibial resection with borders. But then now this took into account the femoral condylar remodeling during arthritis. Functional alignment is more of a gap balancing technique in which the cuts are taken according to the gap balancing, which preserves the soft tissue most of the times. And these are the X-ray. These are the photos that you can see that the medial and the lateral sleeve are preserved in most of our robotic knee replacements nowadays. You see that the ligament tensioning is the most priority given here. So this is a taxonomy of alignment strategies. I think this you can take a photograph of, which will give you in a nutshell about what we have spoken so far. The clinical outcomes obviously improved with kinematic alignment, with a 15% increase in knee society scores at 2 years, functional alignment causing 22% of reduction in 5-year revision rates, and kinematic alignment giving better walking and the gait. So kinematic alignment with restrictions, mostly this restricted kinematic alignment gives you good results. Functional alignment is almost the same philosophy, which also gives you good results. And this is a question: what is the alignment that you will choose on these patients, such difficult patients in Indian patients today? And this is the main thing that I would rather go in for a functional alignment in this particular case, and the other alignments usually are quite radical in this particular case. So technology as a catalyst, we go in for personalized alignment, which is the newest one, which gives us a kinematic strategy, functional alignment strategy, together bringing a matching pre-operative alignment. These are the x-rays of personalized alignment, which are recently coming up in a big way. And this is an end of the era of one size fits all. So to sum up, this is going to be personalized alignment will be the future for which every patient will be taken into account, and it has to be personalized for each patient. Thank you so much. Thank you so much for the opportunity.
Thank you, Dr. Kunal. Now I invite Dr. Gautam Chaudhary to present his talk on pain management protocols in TKR. Okay, as Dr. Gautam is not present here, Dr. Haricharan will present his the same talk.
Go ahead.
So Gautam sir would like to convey his apologies for not able to make it, because we had a NABH inspection going on in our hospital. So sir had to be present there. The topic given to sir is pain management in total knee replacement. So total knee arthroplasty, as we know, is one of the most common surgeries being done for a grade 4 osteoarthritis or painful rheumatoid arthritis knee. However, it is followed by moderate to severe pain that affects post-operative rehabilitation and patient satisfaction and the overall outcome for the patient. Historically, opioids have been widely used for post-operative pain in the management of TKR. However, opioids are known for undesirable side effects like nausea, vomiting, urinary retention, and that limits the application of opioids. So what do surgeon wants in post-operative management? It's early mobilization, enhanced recovery, maintained muscle power, and minimal to nil complications. So consequences of poorly managed post-op pain in TKR leads to psychological consequences like anxiety, depression, sleep deprivation, low morale, prolonged hospital stay, and increased opioid usage, arthrofibrosis, and CVS related like tachycardias and DVTs. So plan for post-operative analgesia should be made preoperatively. This slide just depicts the site of action of various analgesics. As we can see, opioids act at the dorsal root horns and on the central nervous system. Alpha agonists and non-opioid analgesics are acting at the site of receptors. The traditional modes of analgesia in TKR include preemptive analgesia, intrathecal, epidural, patient-controlled analgesias, peripheral nerve blocks, multimodal analgesia, and local infiltration analgesia. So preemptive analgesia is administration of analgesia prior to a surgery where we restrict the hypersensitivity of receptors post-op, which helps in reduced dosage of analgesics. Usually the research paper says rifacoxib given 24 hours prior to surgery and followed by 1 hour prior to surgery has better control on pain post-operatively. Patient-controlled analgesic pumps, these are given in hand to the patients. They have a control button that restricts their use from 8 to 10 times in an hour. And advantage is the pump is directly connected to IV, so there is faster action of analgesia. Disadvantages include opioid being sedative. They don't allow the patient to participate in post-op rehabilitation. Other disadvantages of opioid include nausea, vomiting, urinary retention, and as most of the patient-controlled analgesics are opioids. So, as contrary to the belief, patient-controlled analgesia doesn't make the patient get addicted to opioids, as it is always used under controlled environment. So other analgesia is peripheral nerve blocks. Here are various nerve blocks that are given for TKR. The advantages and disadvantages as mentioned, femoral nerve block one of the earliest and easiest to perform. It has good efficacy, less side effects and faster rehab. Disadvantages include neurovascular injury and localization of the nerve. Sciatic nerve block combined with femoral nerve block has adequate analgesia and less side effects. Disadvantage include its time consuming, high chances of sciatic nerve injury like praxia, or and isolated block is not adequate and localization difficulty in sciatic nerve block. Obturator nerve block, adding obturator nerve block to sciatic block and femoral block improves analgesia, but localization is difficult. Inadequate analgesia if performed alone. Lumbosacral block better than femoral nerve block as it blocks femoral obturator and lateral femoral cutaneous nerve more reliably, facilitate earlier mobilization, and disadvantages as it is difficult to perform by an orthopedic surgeon. Multimodal analgesia, as the name suggests, it involves more than one type of analgesia in controlling the pain. With each utilization, there is lower dose of the single drug if used alone. The drugs that have additive or synergistic effects are used, lesser side effects as compared to single drugs. For example, pre-op gabapentin and celecoxib as preemptive analgesia, intra-op spinal anesthesia plus local infiltration analgesia, and post-operative nerve block plus oral analgesia plus if required patient controlled analgesia. So local infiltration analgesia, it's performed intraoperatively by the surgeon. It has without any specialized equipment, commonly at the conclusion of the procedure. It has become an alternative for the analgesic regimen to femoral nerve blocks because as it doesn't impair the function of quadriceps muscle strength. Nevertheless, there is still no consensus on the optimal composition and infiltration technique of local infiltration analgesia. This shows the common sites for local infiltration analgesia being posterior capsule, collateral ligaments, capsular incision and quadriceps tendon and the subcutaneous tissues. These are some of the regimens across time that have been proposed by Wall et al. It's 150 mg of 0.25% levobupivacaine, 10 mg of morphine, 30 mg of ketorolac and 0.25 mg of adrenaline diluted with saline to a volume of 150 ml and given at the sites. And Tong et al. 150 mg of ropivacaine, 30 mg ketorolac, 10 mg morphine and 200 microgram of adrenaline in total volume of 75 ml. Mont-May et al. 266 mg per 20 ml liposomal bupivacaine mixed with bupivacaine hydrochloride 0.5% and 20 ml diluted with saline to a volume of 120 ml. And McCarthy D et al. Gave 2 mg per kg levobupivacaine and 0.5 mg adrenaline diluted with saline to a total volume of 100 ml. And Konuchi et al. 30 mg ketorolac, 80 microgram clonidine, 0.5 milligram epinephrine, weight-based dosing of ropivacaine, 270 gram, for example 270 gram for a patient weighing 80 kgs or more. These are some of the commonly used local infiltration analgesia regimens in our hospital. One being ketorolac 60 mg plus Trenexa 1 gram plus ropin 0.2%, 2 vials, that is 80 milligram, and depomedrol 80 milligram plus clonidine half vial, that is 75 milligram, and ropin 0.2%, 3 vials, that is 120 milligram plus ketorolac 2 ml 60 milligram, methylprednisolone 1 ml, that is 40 milligram, adrenaline 0.5 ml, as we can see 1:1000 dilution, plus normal saline 36.5 ml, which makes it up to 100 ml. Some of the non-invasive modalities in management of pain include cryotherapy and oral analgesics. Cryotherapy has been shown in the recent trends. The application of cryo to the patient reduces edema, which in turn reduces the pain. Cryotherapy, when applied along with compression bandage, it prevents edema to develop, which is being claimed as one of the most common cause of pain post-op. Recent studies have suggested that cryotherapy has enhanced uses in post-op pain management. So this is what we follow in AAG. Intraop tourniquet pressure is reduced to 265 mm of Hg, and time interval of surgery is maintained between 60 to 110 minutes. Strict homeostasis. Epidural analgesia on POD 1 we give 8 ml per hour, and on POD 3 4 ml per hour, then we remove epidural. No compression bandage. Immediate post-op we apply Convatec Aquacel AG plus cryotherapy on POD 0. Then injection tramadol 50 mg in 100 ml NS IV BD plus PCM 1 gram IV TID. So this is our intra-op procedure. As soon as we finish surgery, we apply the dressing. On it, we apply cryotherapy, and patients have been doing well with it. Thank you. If the pain still persists, we use tramadol, fentanyl transdermal patch. Thank you, sir.
Thank you.
Now I invite Dr. Shivakumar to deliver his lecture on unhappy TKR.
Good morning, respected chairpersons, senior members, and my dear colleagues. Thanks for the invitation for TOSACon and Oasiscon 2026. So you all know TKR is a very successful surgery and many patients have a good relief of pain. That's good. But however, 10 to 20% of the patients are not happy following the total knee replacement. And many people feel that pain is a failure, and it's not a failure. And some people who are good in robotics aim for the precision, and the satisfaction rate will be much better, they think, but that may not be right also. So what is the clinical gap is our concern is not the infected or the loose knee that is producing the pain, but the patient with persistent symptoms and apparently acceptable radiographs with the normal x-rays, with a normal knee, no major identifiable cause. So that is the clinical gap. And is the implant failing, is the knee failing, or is the implant patient interaction failing? It's better we understand the phenotypes of a painful knee following a TKR. The pain alone is the predominant symptom. Whether a stiff knee is there and unstable knee is there, any feeling of insecurity, extension insecurity or flexion, and any dissatisfaction. So the patient's expectations may be much better, much more than the perception itself. So it's better to identify these phenotypes, and then you may have to proceed with the unsatisfied knee. So here is the algorithm: confirm the phenotype, exclude the PJI, it's the worst one which you cannot take any risk, define the mechanics, and this is where we focus in this talk as the alignment, rotation, fixation, gap balance, and patellofemoral mechanics. And can I name the failure? Can I reproduce it? Can revision correct it? Can I explain the prognosis? These will be the questions whenever you see a unsatisfied TKR. And that when you come to the pain, the timing of pain is very important. Whether it is early, that is within a month, or within 6 weeks, intermediate, and late, maybe after 1 year or so. So in that situation, you may have to assess what could be the causes for this, and you may have to proceed. And whenever the patient has come in your regular OPD follow-up, when the patient says that there is a night pain or a wrist pain, it could be due to infection, effusion, or a neuropathic pain. When the patient says, I have a startup pain, then it could be a loosening or a fixation problem. When the patient says on full extension there is pain, it could be an anterior impingement, posterior tightness and gap mismatch. If the patient has a full flexion pain, it could be a patellar impingement, tightness or malrotation. When the patient says, as I go downstairs, then it could be a flexion instability. If the patient says, if I am going upstairs, the patient is having pain, rotation, patellofemoral overload or instability could be a cause. So you have to take an X-ray for a well-fixed prosthesis, whatever it may be, as a routine one. Standing AP, long leg view, true lateral, skyline view, serial comparison X-rays also has to be studied, and you may have to assess for the joint line, posterior femoral offset, patellar height, component overhang. Whenever you find that the rotation is a problem which cannot be seen in the X-rays, in that scenario you may have to go for a CT, and in the CT you may have to go for identifying the malrotation. Now we use the robos with the real-time virtual imaging, and here I will be able to do the alignment of the rotation of the component exactly over the along the native trochlea, so that the patellar movement is unaltered. So that is the thing. So when you come to the posterior femoral offset or the condylar offset, that's much more important. If there is a decrease in the posterior condylar offset, it results in flexion instability. If there is an increase in the posterior condylar offset, then it results in the tight flexion gap, that is loss of flexion. And this is what we should remember. And this is just a picture showing the posterior condylar offset, the importance of it, and in the postoperative X-ray you must be able to see whether the exact PCO is being restored or not. And coming to the alignment philosophy and unhappy TKA, where what Gunal has told, our primary intent is to get into these axes, whether we restore the mechanical axis, whether to restore the native joint surfaces, or the phenotype restorations within the limits, or we go for the robo-enabled soft tissue balancing. So that's what the functional balance, functional alignment. So we go more with the functional alignment with the robotics, and the technology, of course, it aims at precision, and precision is not the same as satisfaction. We will not do a perfect surgery with the robotics. We aim at precision, and precision is not the satisfaction. So this is an example to show a functional alignment where the HK is somewhere around varus of 16 degrees and the post-op is around 2 degrees. So this is what we aim at, functional alignment. And this is the kinematic alignment which we have done. And again, the pre-op is 3 degrees and the post-op we are doing a 2 degrees of varus alignment. So this is, we always undercorrect the varus, and this is our own study where we have done 510 cases, and we have optimized the alignment, ligament balancing and native kinematics, and we have achieved a precision within 2 degrees of target. So what is important is we achieve with the robotics a good consistent results, and the post-operative gal balancing will be much better within 2 millimeters of what is required. So this again is one of the very important factors to be assessed in an unhappy post-TKR patellofemoral causes. These are the various causes of which I would like to mention overstuffing. So overstuffing is one thing which anybody should be focusing on, where we have increased the femoral component size, where we have anteriorized the femoral component, where we have increased the patellar thickness in patellar replacement, and a thicker implant has been put. Even understuffing, that is decreased overstuffing. In that situation also, you may have a increased joint reaction force, and that can lead on to a pain. So this is the picture showing a conventional TKA and the robotic TKA, where we will be able to validate, where we will be able to control the flexion of the femoral component and take a normal patellar alignment. So this is the advantage of the robotics. And whenever we see the implant in the X-rays, we have to look for, in the femoral component, we have to look for oversizing, excessive flexion, and internal rotation, loss of posterior condylar offset, joint line elevation. Again, tibial component, we have to see excessive posterior slope, insufficient slope, internal rotation, mediolateral overhang, varus or valgus position. The instability, whenever we come to the instability, in extension, most of the cases will be having extension instability. Flexion instability is very rare, but still you can have full flexion or a mid flexion instability or a global instability. And stiffness, of course, many cases come to us even after 6 weeks with some pain and stiffness, with the restriction of the improvement of, in spite of the improvement of the range of motion. Again, they come with the restriction of the range of motion. That is the stiffness. So never call it arthrofibrosis unless mechanical and infective causes are excluded, and then you may have to treat accordingly. And soft tissue pain generators are not so uncommon. You have to look for IT band friction. Patient will be telling pain over the lateral aspect of the suprapatellar region, and popliteus impingement, pes anserin irritation, MCL irritation, cutaneous neuroma or ADD, and synovial or cement impingement. That also should be taken in mind. Always rule out the extrinsic causes in an unhappy TKR, that is osteoarthritis of the hip, lumbar radiculopathy, peripheral neuropathy, vascular claudication, CRPS, tendinopathy, and central sensitization. I think I am completing this. So the patient's expectations would have been much higher. That also you must understand that. And the patient biology and the expectations should be properly addressed. So the decision making is whenever you see an unhappy TKR patient, you must know when not to revise and when to revise. You should have a clear indications for it, and this will be the algorithm. Whenever you know the exact thing, what is exactly wrong, whether you can demonstrate or reproduce it, how will your revision correct that mechanism? In that scenario, you can go for a revision. Otherwise, you don't attempt it. Of course, we also have happy patients. They also do the regular activities. They do squatting. But still, you must know how to address an unhappy patient. And you may have to go along with all the mechanical aspects which I discussed in the X-rays, and you may have to treat accordingly. Thank you very much. With this, I invite you all for the Oasiscon 2027 in Madurai, where we are combining with the state mid-year con, and it will be almost a 4 days program. And we have a pre-conference workshop, cadaveric sawbone workshop, including live surgeries, and we also have the Oasiscon for the next 2 days, Saturday and Sunday. We all invite you to Madurai.
Thank you, sir.
Thank you.
Thank you, sir, Sivakumar, sir. Thank you for your talk. Now I invite Dr. Sai Lakshman, sir. Is he available in the hall? Dr. Sai Lakshman Garu.
Unfortunately, he is unable to.
And Dr. Raghunathan. Is he available in the hall?
He is also not there.
Okay, thank you, sir. So I invite all the panelists to come onto the stage for to take some question and answers.
Sir, you are presenting?
Yeah. Sivakumar, sir, please stay on the stage.
And Dr. Kunal, please come up on the stage.
Yeah, on behalf of Gautam Chaudhary, Dr. Gautam Chaudhary, please come on to the stage.
Thank you, Chairman.
Yeah, any questions from the audience, delegates, please.
Hello. Yeah, this question to
Shivakumar sir, congratulations sir.
Thank you, sir.
For your next Oasiscon, you can keep unhappy TKR is a one-day conference, sir.
Yes.
Yes, sir. It's a very difficult to manage, sir. We used to get the patient and always complain the pain. In spite of good, this wound has healed nicely, full range of movements, and still they said I got a pain. So Dr. Guru Reddy sir used to tell, don't ask about the pain. Should ask about all other things. So how to judge, sir? If everything looks okay, movements fine, radiologically fine, knee around the knee is fine, no hip pain, no back pain. Still, how we will convince and how we will manage, sir, this type of patients?
Yeah, that's what the whole talk was. As you say, there are books, there are volumes of books for the unhappy TKR. It was covered within 8 minutes. But however, whenever the pain has come with the patient, radiologically they are almost good, normal. So that is where we have to see where is the problem, whether the patient is having pain because of some impingements or some component malpositioning. All these things you have to look. And then you may have to look for any other extrinsic problems like hip pathology, spine pathology. And most of the time you would have seen, even in your experience, we would have seen lumbar spondylosis with the radicular pain. They will be complaining of pain to the fellow, and the fellow may miss it also. So those things are all there. You may have to assess that. And the psychological aspects, expectations minus perceptions. So that's very, very important, and you may have to get along with that. And if you want, you have to really study the instability patterns. That's also very important. They are not satisfied most of the time. So in that scenario, you may have to identify that. And always, all the more, you have to first rule out the PJI, whatever it may be, even if the X-rays are normal, ESR, CRP is normal. Even there is some warmth, but not very much clear. So you must always rule out PJIs.
Sir, some they develop CRPS after the post-TCAR.
Yes.
So what is the best medication, sir? What you will do? Amitriptyline or gabapentin or blocks? What is the best medication for CRPS type of pain?
Yeah, once we see the warmth, inflammation, and some amount of stiffness, in most of the cases we go with steroids. We go with steroids in consultation with the physician if there is no contraindication for steroids, like uncontrolled diabetes. Even diabetics, we go with steroids. But if there is uncontrolled diabetes, in that situation, we go for, with the physician's opinion, we go with the analgesics. And as you say, gabapentin, we have to go for 100, 3 plus 300, along with the nortriptyline.
My question to Dr. Kunal is, do you think implant dictates also how a knee lasts for years together? Nowadays we get our patients 15 years, 18 years follow-ups, and we never had this functional alignment, all these things. And still we get some patients, they are still happy. And without naming companies, we see some implants are actually doing much better over this nearly 2-decade follow-ups. So according to you, do you think the implant type or maybe company also might help in giving long-term results? What is your experience? Just for understanding, I can say maybe one of the implant types is all poly, which we did a lot of all polys in our the late 2000s, and still we get patients, they're doing very well. They have no major complaints, and the joint lysis, nothing is there. So what did we do right that time, and what are we chasing now regarding maybe implant specifications or kinematics? What is your take?
This is a very important question. The whole implant morphology has to be studied. It is not only the mechanism of surgery or the mechanics of the knee alone that is going to matter, because once the TKR is done, the native mechanics is completely gone. So what I talked about is going to go off immediately after the TKA, and the new mechanics are going to come in. So the new mechanics are mainly the mechanics that the implant itself has innate. And some of the implants, as you said, are doing very well for a long term. And it's not only the implant, it's also the patient's, the regular biomechanics that they use, the way they are going about their activities of daily living, and how demanding the patient is. So sometimes these patients go around on the skiing, and they feel that the knee is not right. So that is for certain very demanding conditions where patient is still unhappy, but actually happy in the regular run. But most of our patients in India, you find that their activities of daily living is mostly taken care of by these knee joints. And also they come at a very late stage to us. And during this stage, they are happy with whatever they get. And in India, we see more happy knees than unhappy knees because of this. That is why probably your implant over a period of time has been good. And certain implants are innately design-wise good. And recently, there has been a very nice article which says talks about all these implant types which are improved recently, and the newer implants are definitely better.
So it's individual based is what?
Yeah, I think the long-term results of functional alignment is still awaited. But however, whatever mechanical alignment we have done so far, if we have repeatedly again reanalyzing it, So there will be some component of functional alignment which the surgeons have done, and they are more happy with that. So that is what the satisfaction rate comes with the mechanical alignment people also. That's I think in the long term only we may have to tell which alignment is much better. But however, there are proven results with the robotics for the, especially the Howell's paper is there for restricted kinematic alignment and kinematic alignments. Functional alignment is long-term results are yet to be published.
What is your opinion about the patellar resurfacing, preventing this knee pains?
Yeah. Patellar resurfacing is not contraindicated in experienced expert hands. Whatever patella you are removing, you resurface it. That's the very idea. So it's not that it's going to increase the joint reaction force, or you are going to overstuff. But in experienced hand, that's what I am telling. Whatever you want to remove it, you have to replace the implant. In that scenario, it's not going to affect. And especially when the patellofemoral sulcus or this thing, the track is maintained, and there is no issue at all. And if when you don't resurface it, that is what we do as a patelloplasty, we actually reduce the thickness of the patella. So it can become multifactorial because at least 1 mm you remove it. But I think there is no big difference between the patellar resurfacing and non-patellar resurfacing.
About the andromalacia patella cases going for the TKR, is there any difference in that?
I got your point, sir. When there is a gross patellar, cartilage defect, whether we will go for a replacement or not, patellar replacement or not, most of the time there is no difference in that, so we don't do that. I don't do that. Many people don't do that in India. Some centers, they constantly go for a replacement of the patella.
Yeah, for preoperative analgesia, I know Dr. Gautam is not there, but the entire panel can give the answer. What is your preoperative analgesia one night before TKR? What are the medications you give, or how you manage so that post-operatively patient has a little less? Intraoperative we know, but preoperatively what does the panel do for the audience?
So my routine preoperative medication the previous day is one NSAID with a sedative, preferably lonazepam, 0.5 mg or 1 mg depending on the weight, and immediately pre-op before the infusion, before the surgery, before the incision, the patient is infused with tranexamic acid. That is a routine thing, but of course during that time we do not give any preemptive analgesia. The preemptive analgesia is mostly given immediately post-operative. Even before the pain comes, we start off with the routine medications that we usually give post-operatively, and those medications are usually given even before the pain comes, after spinal anesthesia or your epidural anesthesia.
Any more questions? Okay, one last question to Dr. Shivkumar, sir. Sir, do you think that robotics will bring down the unhappy knees in near future? Using robotics or adapting robotics anyway? Because there are many unidentified things and there are so many alignments which we are talking right now. Each surgeon is following a different alignment philosophy.
Yeah, that's the very purpose of bringing the robo as a tool for the surgery. So robo is not going to replace the surgeon. Robo is made as a tool for the surgery, and the technical perfections or precisions are much better. So you validate each and every step. Say, for example, if you want to say the femoral component rotation, so normally it's better you go either for 0 or external rotation. You don't go for internal rotation. Still, it can be internal rotated provided the axis between the PCO and the TEA is much larger. So the gap. This all will be validated with the system. So this manually you will not be able to identify. So the consistency is a very, very important factor in bringing the satisfaction rate following the TKR. So these consistent results will be much better with the robotics. So it's not that you should not opt for robotics. it's always you better go for robotics. That's one of the surgeons pointed out. It will be like a Siam in 2035, like that. It's very important. It's going to be the era for robotics. It's not robotics which is going to do the surgery. Surgeon's dexterity is very, very important in doing the surgery, and our own knowledge is also very important.
Thank you, sir. With this, we close this session. Thank you.
Thank you very much, sir. We request the chairmen to accompany the speakers to be felicitated by our scientific committee chairman. Now I call upon for the next session, arthroplasty complex knee. For this, I request Dr. M.S. Goud, sir, Dr. Tajan Garu, and Dr. C.H. Hariprasad Garu to come onto the stage to chair this session. This session, Balaraju Naidu has completed the talk. We have another two good talks in this. One by Dr. Kushal, then by Dr. Chandrasekhar. Thank you. Okay. Request all the speakers and to stick to the time so that we would go on to the next session. It's slightly delayed in the process.
Good morning, everybody. The session is an arthroplasty in a complex knee. One topic is already covered by Dr. Balaraju. The next speaker will be Dr. Chandrasekhar. I invite Dr. Chandrasekhar to give his talk on management of bone loss in revision TKR. Dr. Chandrasekhar.
Slight change, sir. This is Dr. Kushal here.
Okay. Dr. Kushal, he will speak on principles of revision TKR.
Yes, sorry for the confusion. Dr. Chandrasekhar and I decided that first we'll cover principles and then go ahead and do the bone loss. I'm Dr. Kushal from Sunshine Bone and Joint Institute in Hyderabad, Kim Sunshine Hospitals. I'll be speaking on principles of revision TKR. So before we jump into revision surgery, we must know why the primary has failed. That's why I put this slide across, not to take you through all these things, but understand the reason why the primary failed. If you don't do that, then it's a disaster. So our goal of revision is first to eradicate the disease. For example, if there is an infection but that was missed and you went ahead and did a revision for that, it's a complete disaster. So make sure you identify it, then eradicate the disease. Restoring alignment is the second goal, where the different alignment philosophies of primary don't hold true for revision. Still the gold standard is very much a mechanical alignment. Restoring the stability by maintaining good flexion extension gaps and restoring the joint line. Now joint line discussion doesn't come up in primary because it's merely replacing cut bone with metal, and the joint line is rarely altered. But because in revisions you are going to have significant bone loss, that's where the concept of joint line comes in. And then to ensure durable fixation, because we have a lot of bone loss. So these are the main things that we have to plan out. As we get into the case, the extensile approaches come in. So while your primary doesn't need any of these, most of them don't need. The revisions, 80% of that, your quadriceps snip will do the trick. You can see there in the first image, it's just a 45-degree cut on the lateral side towards the apex of the tendon, and then either a TTO or a viviplasty is the next go-to option. How do you choose between these two extensile procedures? So you choose a TTO if you have a patella baha and you want to proximalize that, or if you have a distal tethering, that means if the pathology is more distal. But if you have a short contracted quadriceps, pathology is up there, then you can go ahead and lengthen the quadriceps with a viviplasty. Or of course if there's a prior TTO or a thin bone at the TT, then you can't use that. As you finish your approach and you reach your implants, the component removal is very important. Obviously, you have to preserve the bone, and the way to do that is to work at the implant cement interface. What you need to know additionally here is, if you know the implant, you will have the instruments ready. Like for in the first image you see there, that's the extractor for the femur. So make sure that you identify the implant company. How you remove it? Since the modular component is the polyethylene, remove that first, then work on your femur, and tibia is last, because to remove the tibia you need to subluxate the knee, and for that everything else needs to come out, and patella only if needed you remove that. The way to remove the tibia, since you don't have a easy way, it's seated on top of the tibia. This is a useful technique. It's called the stacked osteotome technique, where you can use wide osteotomes to distribute the force, and instead of crushing the anterior bone on the tibia. Again, we said joint line. Now joint line is important. There are many landmarks. None of these are really very accurate. 35 from medial, 25 from lateral, 10 from fibular head in millimeters, all of these, but they are a rough gauge, and yes, your idea should be to replicate this, though the adductor ratio is the most precise one. This is our study done with Dr. Mustafa Sitak and team on multi-center validation of the ratio and a novel composite index. Gap determinants in terms of flexion and extension. Now when you look at flexion gap, posterior condylar bone loss is massive most of the time, so you have to, that flexion gap will be determined by that, and the femoral component sizing, the increase or decrease of that will determine your flexion gap. And don't forget the concept of offset. In terms of extension gap, distal femur bone loss is also very common, so you have your extension gap determined by that, posterior capsular tightness or laxity, and then whether to use distal augments or not. So these primarily determine. How do you know intra-op? You have to be able to use either spacer blocks, tensionometers in the beginning to assess if there is a mismatch, so that you can plan the case. So how do you plan it? First thing is to do the tibial base plate, so you have to make sure that the platform is done, and then you work on your flexion and extension. The difference between primary and here is, here you are going to use a intramedullary alignment rod, because more often than not you are using stems inside, so the alignment is guided by the intramedullary stem. So make sure that your tibial cut is also like that, and the minimal bone resection is the way to go, not an entire biscuit, because that will cause further bone loss. And then you achieve a correct mechanical axis. Don't forget that because you are using stems, again the position of the base plate is not independent of the stem but dependent on the stem. So you need to plan your offset. So know your implant system and see whether that offset system is available or not. Then go for your management of flexion instability. As I said earlier, it's the size of the femur. So if you increase your femoral AP size, that's going to help you balance your flexion instability, and add posterior augments if needed to counter that bone loss. The sizing here is not AP as is done in primary, but more or less on mediolateral dimensions and based on your tibial size. So make sure that that is correctly done. Then you look at your rotation. The epicondylar axis is most reliable, because again you don't have your PCA as a good reference, and of course tibial platform as well. Distal femur augments, restoring the joint line, that's the real usefulness of this, and to counter the bone loss as well. It reduces the extension gap. Dr. Chandrasekhar will be dealing this in detail, but this is a paper that everyone must look at before going into the revision surgeries. It's the zonal classification by Morgan Jones, zone 1, 2 and 3, epiphysis, metaphysis and diaphysis. As a dictum, fixation in 2 out of 3 zones is mandatory, so make sure that you plan accordingly. Bone loss after removal, I will move quickly with this because it's also covered in the next talk. The classification will be covered, and how to deal with bone loss. I think all of these points will be covered, so for want of time, just a quick mention on sleeves. I think, sir, you have that as well, right? Okay. This is one of the papers we published on sleeves, which is again showing excellent survival at midterm for the sleeves used in type 2 and 3 defects, and cones. When you go to what kind of implant you should select, the least constraint necessary, that should be your approach to begin with, and the largest fixation possible with maximum bone preservation. That's how you should plan it. So we are all familiar with this kind of a increasing spectrum of constraint. When it comes to revision surgeries, most of the cases you cannot use from A to D. That means from your CR to definitely your CS, but sometimes you can use your PS. But most of the time you are going to end up using EFG. And what is that? The first is most commonly used is your varus valgus constraint, so higher and broader central post on the tibia that closely fits into the femoral cam. So when you have your medial and lateral ligaments still unable to balance after sufficient soft tissue release, or the difference between these gaps is about 3 mm or so, you can go ahead and use this. We published our paper on the survival of this VVCs mid to long term, and excellent 96% survival at 5 years in these kind of scenarios. So you have that broader and higher post on the tibia, which is visible in this image here, and the deeper notch and box of the VVC compared to the PS implant. So that's the big difference between the PS and the varus valgus constraint. You can see it in the image as well. The next level of constraint is the hinged processes. It's the most constrained one with a linked femoral and tibial component. So the tibial bearing rotates around the yoke on the tibial platform. So whenever you have extensive bone loss, ligamentous deficiency, or of course if you have a flexion extension significant mismatch which you are not able to balance, that is also a indication of hinged. And of course if you don't have any condyles, then you can go ahead and use a mega prosthesis after that. Stems, whether to use short or long, whether to do cemented or uncemented, I think that will also get covered in the next one, because that really is based on which zone of fixation you need to plan. I think Dr. Chandrasekhar will be dealing with that. So with that I'll end my talk. Thank you very much.
Thank you, Kushal. I think Chandrasekhar has made your topic very easy and gave more time.
Yes, sir. Thank you.
Now Dr. Chandrasekhar to talk on management of bone loss in revision TKR.
Can we have it on the screen, please? Good morning, everyone. Respected chairpersons, my senior colleagues and junior colleagues, thank you very much for the opportunity. So Kushal, in fact, has made my talk a little easier with covering the basic concepts. Management of bone loss in revision total knee arthroplasty is one of the challenging situations. So there are two aspects of a revision arthroplasty. One is managing bone loss, and the other one is the ligamentous insufficiency. So we have to understand the distinction between these two. Bone loss is a different concept and ligamentous deficiency is a different concept. So you can get bone loss in a primary situation where the arthritis has been neglected. We do come across severe bone defects even in primary arthroplasty. In the revision scenario, you can get bone loss because of stress shielding, or osteolysis because of wear, or septic or aseptic loosening, or poorly balanced implants, or sometimes if you are not careful while removing the pre-existing implants, you end up with removing too much of bone and sometimes loss of condyles. So the choice of reconstruction depends on where the bone loss is and how much is the bone loss, and of course the bone quality determines what sort of reconstruction options are there, the collateral ligament integrity, and the patient's age and the functional needs. The most useful classification is the Auri classification system. It's quite simple and it's very practical as well in order to decide what implant you're going to use for reconstructing the bone loss. So basically the Auri classification decides whether the loss of bone is in the metaphyseal area or the epiphyseal area, and whether it's a contained defect or an uncontained defect, and if there is any associated instability of the ligaments. So you have separate classification for both the femoral and the tibial sides. So it's classified into 3 subvarieties on both femoral and tibial sides. So 2 aspects are the amount of bone loss, whether it's contained or not contained, and whether the soft tissues are intact or not. Again, the zonal concept is very, very helpful in deciding where the fixation should be. So as Dr. Kunal was mentioning in the earlier talk, there has to be fixation in at least 2 areas, 2 zones, I mean epiphysis, metaphysis and the diaphysis. So there are different implants for different zones in the fixation. So pre-op planning is very, very important. Standard radiographs often underestimate the amount of bone loss. Sometimes CT scans may have to be done, but you have to be prepared for the worst when you are embarking a revision surgery, because intraoperative assessment is the most accurate in deciding how much bone you are left with. So the goals of reconstruction remain the same whether it is a primary or a revision scenario. It's important to restore the joint line rather than filling the gap with too thicker a poly. Go for a least constraint, try to restore the joint line and build up the bone, and then use the least possible polyethylene whenever possibly, whether it's a primary or in the revision scenario. Of course, restore the joint kinematics and the joint stability. So in Auri type 1, whether it is in the femoral side or the tibial side, there is an intact lower metaphyseal bone. Most of the time you can get away with a primary implant. If the defect is less than 5 millimeters, you can still manage with cement filling, and sometimes it can supplement with screws as well. So for Auri type 2 defects, the options are using a morselized bone graft for small contained defects less than a centimeter, whether it's when it's a non-infective scenario and it's not that good for cortical or severe uncontained defects. Metal augments have played a major role in managing the zone 2 defects, for especially if it's an uncontained defect, and if it is again not too big, again sleeves are better option than going for a metal augments, because there are some pros and cons with augments. Though they give good structural support over a period of time, you can develop radiolucencies underneath these augments, and there is a higher risk of fretting and corrosion because you are increasing the modularity when you are using a metal augment, and there can be stress shielding and bone loss underneath the augment. In Auri type 2B defects, the metaphyseal sleeves and cones have actually revolutionized the revision scenario. So in Auri type 3, constrained implants with resection, because in Auri type 3 there is a loss of the ligamentous integrity as well. So structural allografts also have been used, but they're not a great choice. In specific scenarios, you can still get away with metaphyseal sleeves and cones. So these cones are basically filling agents. So whenever there is a reliable cortical shell, where there is an intact cortex, you can still fill the gap with cones. It can be supplemented with bone grafts and as well as straight or offset stems. In most of the revision scenarios, stems are mandatory because that will help to bypass your zone 2 fixation, and high rates of osseointegration with these tantalum cones. So this is a typical example of a cone where it is acting like a filling agent to fill the defect in the zone 2. So this is a post-operative X-ray of a cone supplemented with stem fixation. Metaphyseal sleeves are cementless porous-coated titanium devices. They help with filling large contained or uncontained zone 2 defects. The advantage with sleeves is they give immediate rotational and axial stability, and they transfer the mechanical stress directly to the metaphysis and prevent stress shielding on diaphysis, unlike the stems. So they're used by ream and broach technique with press fit. The only risk is high risk of iatrogenic fractures, especially in osteoporotic bones, and they have given very good high, medium to long-term survivorship. The literature shows that the survivorship of sleeves are slightly better than the cones. Megaprosthesis in cases of extensive bone loss which is extending into the diaphyseal area. Elderly patients with low functional demand, this is a good choice, and when there is severe compromise of the collaterals. We'll go through a few case examples. This is of course a primary scenario where there is extensive bone loss on the medial aspect of the knee. So this is the post-operative X-ray. So if it is confined just to the zone 1, you can get away with bone graft and screws. This is a post-operative X-ray and walking video of this patient who was actually having a lot of difficulty in mobilization because of the severe varus thrust. And this is 6-week walking video of the same patient after bilateral total knee replacement. This is another example of extensive zone 1 defect. This patient had bilateral problem both on the medial and the lateral compartments. So this is on the right knee. It was more of a windswept deformity. So intraoperatively you can see the amount of defect. When we measured it, it was coming to almost 2 centimeters even after taking the bone cuts. So this was managed with bone graft and screw fixation. So we could make her to walk day 1. She was not walking for months prior to the surgery. So this is an example of again zone 1 defect, two-stage revision, where the bone loss was confined to zone 1 itself. So in that kind of a scenario, you can still get away with a simple constraint itself, and then stems are mandatory in this kind of scenario where there is not much of metaphyseal bone loss. This is another example of a patient with rheumatoid arthritis. She had a failed fixation on the left side. You can see this is Auri type 2 where there is a zone 2 defect, extensive loss of the condyles on the left knee. She was doing all right with the right knee. This is an intraoperative picture which showed collateral ligament, medial MCL laxity as well. So when we removed it, the implants just came in the hand. So this was reconstructed with bone graft for the reconstituting the condyles. And since the metaphyseal bone loss was there, so we had to use sleeves as well as stem fixation for this. This is another example of a two-stage revision. There was extensive bone loss both in the metaphysis and the diaphysis. This was referred to me at this stage where the patient had a spacer put in. So the extensive bone loss both on the femoral and the tibial side. This was the remnant bone after removing the bone. See, since he was 82-year-old, managed with a distal femur replacement processes. On the tibial bone defect was managed with sleeves along with stem extension on the tibial side. This is a post-operative video at 3 weeks post-surgery after the distal femur replacement. So in conclusion, when you're addressing bone loss, be prepared for the worst and be prepared with full armamentarium whenever you're embarking on a revision surgery. Respect and restore the joint line rather than filling the gaps with thicker polyethylene. Try to use least poly and build up the bone. As we follow in the revision scenario, first do the tibia, get the joint line correct, fill the flexion gap and then the extension gap. And the sleeves and cones have revolutionized the zone 2 defects and follow the constraint ladder on a case-to-case basis. Thank you.
Thank you, Dr. Chandrasekhar. Well presented.
Any questions for the speakers?
There's a lights rescheduling of this thing, sir. So we thank the chairmen for chairing this session. I request the speakers and the chairpersons to kindly be felicitated by the scientific committee.
After conventional and
done.
So may I request Dr. Chandrasekhar, Dr. Raja Ramesh, Dr. Kunal sir and Dr. Shivkumar sir, Dr. Ravi Gudipudi to please come onto the dais for a panel discussion between conventional and robotics. Yeah, Mithinachi, please. Yes, sir. Yes. Yeah, this, yes. Raja Ramesh sir, you are in the comment sector. Robotic. Yeah, Ravi sir, Ravi please. Sir, one more mic there, sir. We have lack of time, so we will do quickly. Sir, give this one, please. So it's a quick session. Thanks for giving this opportunity between the conventional and robotics. The delegates and postgraduates are in a lot of dilemma whether to do conventional or robotics. We will quickly go through these small questions, sir. Shivkumar sir, in why should a consultant surgeon in 2026 change their practice? You are a very experienced surgeon, used to do a routine conventional, but suddenly why you are changing into the robotics, sir?
Most of the time we are having the training of doing the surgeries by manual methods, and we take the cuts and then we go for the soft tissue balancing. Somehow or other, we really don't know how this patient will do in the post-operative period. So that is where when we have compared the results of the robotics And when we have validated the steps during the surgery, and the soft tissue dissection has been very less or minimal. So in that scenario, I feel that this change should be there in the surgical era of the orthopedic surgery, orthoplastic surgery.
Yeah, Mithinji, in robotic take care, truly a technological advancement or simply it is an expensive navigation system?
I wouldn't say it is a expensive navigational system. Definitely it's a technological advancement according to what I have experienced in robotics. Basically, not only it helps in navigation, but also the cuts are more refined, and human driven cuts may have some amount of plus or minus outliers, but in a robot we can be little more sure that probably the bone cuts and your gap balancing which is there is more data driven rather than associated with eyeballing. Having said that, again, maybe we can discuss some more points why I am for conventional rather than robotics.
Yes, sir. Chandrasekhar sir, what is your strong evidence to use the robo?
Well, I mean, this is like asking somebody in this era whether you want a smartphone or a normal phone. So if you have the technology, you can make the best use of it. Why not? And I know there are some evidence against robotics, like from the Australian registry as well as from the Canada as well, which have not shown any advantage with robotics. However, most of the centers have shown a definite, the advantage, especially if you are able to validate. I think the reason why robotics is still not picking up is one is the cost factor and the other is the availability. But at the same time, if you have proper training and if you have good experience with your conventional technique, then certainly robot is an added advantage. It's a useful, intelligent assistant for a good surgeon. It's not a substitute for a surgeon, but it's an intelligent assistant. So why not you make use of it?
Yeah, well taken, sir. Dr. Raja Ramesh, sir, we want to keep the implants in a good position. Either way, either conventional or robotic, you want to keep the implants or processes in a good position. Can either side shows convincing evidence that improved alignment consistently translate into the long-term functional outcome?
Yeah, here first I will go with the experience. See, human can't be replaced by robo or computer assisted. Previously it was computer assisted was the biggest form, and now the robo is in change. So it takes at least 10 years to go with the robo or not. But conventional it is not replaced by anything. So I support conventional. That's the human intelligence is more than the robo.
Kushal sir.
So I think the question about the accuracy.
Accuracy, yes.
If we just first split, robotics is used for all major three types which this audience is talking about. That is total knee, partial knee and total hip. So when it comes to accuracy, definitely all across all three types of modalities, it is better in terms of accuracy of implant positioning. That is proven. Now the next question that you had was, does it help in giving a better clinical outcome to the patients? So in total knee, I think more or less it is coming to light that it is not helping the patients beyond a certain early recovery period. In partial knees, it is definitely lowering the revision rates. So in that way, a big boon to the partial knee methodology to use the robotics. And also in hips, I think there's
Shivakumar sir, every degree of alignment error will actually matters clinically?
Yes, definitely. Because what is this? We all talk about the coronal balance. At the same time, the sagittal balance is also very, very important, which is not very much into the manual or conventional methods. Say, for example, if you want to flex 3 degrees, if you want to extend to 2 degrees, these are all very important for the femoral component. Again, tibial slope, that matters a lot. So you will not be able to exactly assess what is the tibial slope. So far, we have told it is 3 degrees and you put 2 fingers breadth and 3 fingers breadth, which is not true and it is not accurate also. So sagittal balance, robotics helps a lot. And again, in complex cases, whenever you want to adjust to varus to 2 or 3 degrees, you avoid these polyovers and augments also. So in that scenario, if you keep the entire HKA to 3 degrees, within 3 degrees, then this is going to help a lot. Robotics are going to help a lot. So that's what. So it matters.
It matters.
But it doesn't mean to say that this sub-millimeter, 1 or 2 millimeters, is going to alter the clinical outcome.
Yes, sir.
It
Thank you,
matters.
sir.
I agree with that. I mean, the basic thing is we need to know what is the target we want to achieve for a particular patient. Whether that is really going to translate into a real-time functional improvement or not is still not known, because there is ample literature which have shown that, you know, though your accuracy is improved, functional outcome may not vary. But at the same time, robotics are good because you are able to see real-time and validate what you are doing, because with conventional,
Yes.
you are not able to validate what you are doing, what you are achieving,
Correct,
trying to
sir.
achieve.
Dr. Ravi, sir, is a robotic surgery is easier for beginners, unnecessary for experts?
Yes, sir.
It's a youngsters, they should learn only the robotics, sir?
So I'll answer one that we
Yes.
had a recent publication in the Indian Journal of Orthopedic Surgery where we actually addressed all these 3 points, and we found that experienced surgeons actually are able to take into robotics much more easily. That's because they do almost the same line of work as a robot does.
Yes,
So probably experienced surgeons do well. Second thing is it's unnecessary for experienced surgeon. Last but not the least, it reduces the learning curve for students. For example, if you are teaching conventional TKR, one aspect, it might take hundreds of cases before the student really starts to understand how a TKR is, what is the line. But a robot directly there's data driven. So definitely learning curve wise, robot helps. But for skilled surgeons, experienced surgeons, as of today, maybe the requirement for robotics is not so serious or so required.
Kushal sir, is it justifiable like in Indian countries, like developing countries, where affordability remains the major concerns, to put an expensive robo in joint replacements?
So that's a very valid question. If you ask me, when I sit and counsel my patient about this, cost is brought into the discussion, and I tell them that if that extra cost of the robotics is going to put a hole in your pocket, then just don't worry about it. Total knee, that's what your question is. Total knee,
yes.
Without blinking, you can just go ahead with a
Normal conventional
as well.
So who benefits most economically? Raja Ramesh, you are in public sector hospital. Who benefits most economically?
It's
The
obviously
patient,
patient and the
surgeon,
hospital.
or the hospital?
Patient and the hospital.
Patient and hospital, not because you are in government sector. Yeah, Mithun is in corporate sector. Who will benefit, sir? Is
To
it
be
a
very
patient,
frank, we
surgeon,
don't-
or hospital?
We don't have the robot.
Yeah.
I'm in a big corporate center, but still we don't have the robot. We had a
Shivakumar
robot.
sir, I think in your hospital, who benefits most? Hospital or
No, the
surgeon?
mindset matters. This is what I would like to say. See, you are telling this robo is very expensive.
Yes.
So the expensive robo, see, if, for example, somebody was using this MISO, now they give it for 1 crore or 1.25 or even 50 also deposit, that itself is sufficient. So it is not the cost, it's only the mindset. The robots are technical tools which are going to help you, and you need not add cost to the patient at all. This is what we are going, in the future it is going to be. In our hospital, sir, to be very frank, we don't charge anything extra for robo. So we do the regular knee workup only, and some patients we avoid robo because of osteoporosis or some other contraindications. That's all. So I don't feel that this pattern of questions like cost and to the cost of the hospital, cost of the patient should not be there in the future, because it entirely lies on the mindset of the surgeon and the hospital where he is working.
One small point I wanted to say is basically who wants the robot? Is it the doctor or is it the patient? A study by us again in Journal of Clinical Case Reports, we found that the patient really doesn't seriously want a robot. It is the doctor who decides whether the robot is actually good or not. So probably if you are going to put an extra cost to the patient and amount of more chance of more intraoperative complications, justification for using a robot should be very high, which I feel in long-term results as of today is not justified.
Dr. Chandrasekhar, over a period of time, the conventional instruments will completely disappear?
Well, it depends on how fast the the robots are adopted across the centers. In India, it may take a really long time because of the cost factor, of course. Though over a period of time, the cost of robots may come down, but still it's more of learning and unlearning. It's basically people have to sort of, adapt and believe in it. Belief in technology, I think, is more important.
Yes. Kushal sir, is the certification is mandatory to start the robo? Any surgeon, if I want to do a surgery or with a robotic, I need to undergo compulsory certification
It
or
depends
not?
on the robot that you're using.
Right.
Like Stryker mandates it.
Legally,
but
legally,
other-
I'm talking,
no.
not about the any robo.
No,
Is
no.
a surgeon has to undergo certification?
No.
No need.
No
They
need.
can start.
That's correct.
Immediately. Yes.
Yes.
Okay, sir.
Can I add one point?
Yes.
There are obviously two types of robots, one which do by themselves and one you have a saw-based. We feel that maybe saw-based robots are more easier to do without certification rather than a burr-based. That's my experience. I don't know what is the panel's experience.
More recently, in our institute, they've been asking the surgeons for the certification.
What do you feel? Burr-based, you have to have the patient in one particular position, you have to bring the robot and all that. Saw-based robots...
No, I think
it's
for
not
you
just-
to be legally covered, I think it's always safer to have a certification course from whatever system you're using.
Okay, I totally agree to that. I'm talking of the type of robots that are there. So if you really feel certification...
No. See, the burr-based, saw-based doesn't matter. It's automotive or semi-automotive. That matters. See, for example, the Corey, Smith and Nephew, we have burr-based, but it is not going to alter any this thing. Even the position of the limb, anything is not going to alter the burring.
Yes, yes, sir. Yes,
so
sir.
I feel that the
Yeah,
certification
that is
not
more
required.
technical, Mithin. That is more technical. Sir, Shivakumar sir, can expert conventional surgeon consistently outperform an average robotic surgeon?
100%.
100%? Yes.
Yeah. The experts, conventional surgeon has definitely a better.
Sir, if the robot gives a best thing, even the way you don't have research, still you have to invest for robo, especially in government sectors.
Yes.
Limited resources where there is no money, but still you insist the government to invest on robots.
Yes, sir. Government always provides the infrastructure. This has to be one among the infrastructure. Say, for example, microscope. Have you ever spoken of microscope in a neurosurgery department? Now only this robo is being spoken of because of the marketing hype. It's not that. It is one of the infrastructure which should be there in the...
Raja Ramesh, in your training, do you train your residents both conventional and robotics or only robotics?
Yeah.
In your training institutes?
I will go with the conventional first, then robo.
So
See,
they should...
always conventional, without starting the
How
conventional.
many they have to do? 10, 50, 100?
There is no number, particularly it goes with the experience, whether you are 3 months, 6 months or number, it's minimum of 100. After that, you will know the basic component
There's a
anatomy
paper
and
which has
everything.
shown that between 7 and 20 is the learning curve
Yes,
for,
sir,
the,
yes,
for
sir.
the robotics.
Sir, last
So if
final
they're able to
question,
do
sir,
that-
from your sir, last one, this is a closer one. Shivakumar sir, complete the sentence, sir. The future of knee replacement belongs to A or B? A or B, sir? A is a conventional, B is a robo.
Robotic.
Robo, A or B?
Artificial intelligence.
Yes, sir. Kushal sir?
Not a clear-cut answer, but it definitely will be robotics.
Robotic,
There's
yes.
no question about it.
Raja Ramesh sir?
Always goes with a mix.
Mix, okay. Mithinji, A or B or C?
Experienced surgeon driving robotic AI.
Yeah, yes.
Mixed, sir.
Yes, sir, mixed, both A and B mixed. Thank you, sir. Rakesh, sir, for giving this opportunity.
Excellent,
Thank
sir.
you.
Excellent.
And next,
I really
Tosa
appreciate
is
the
in-
discussion we had and Jagan sir for moderating it.
Thank you, sir, because
Request
love-
all of
right,
you to
yes.
join
Yes.
for the honors by the organizing
Yes, sir.
team.
So
There
next
is a slight,
Tosa in 2027 in Hyderabad.
There is a slight change in the program as Dr. Sudhir Reddy has sent a video. We're just postponing that to the next session. Now I request Dr. L. Prakash Garu to come on to the dais and deliver his lecture.
एक मिनट, screen is हाँ here we are. Just put the mouse and put that. You connected? Huh? You have to connect it. You have to connect this shit. Come now. Good. Perfect. Good morning, everyone. In the next 20 minutes, I'll be covering a topic about which I think about 70% of the audience may not be familiar with. But now I'm into this, moved on from arthroplasty into something new called molecular therapeutics. Now, molecular therapeutics actually transforms musculoskeletal care through innovation, and I'm Dr. Prakash. I'll just start with a few examples. Osteoporotic stress fracture of the tibia, AO, double plating done. That's it at the end of 3 weeks. Advised amputation by all the 4 surgeons. Had an ozone bagging, full thickness myocutaneous flap, plate removed, nail done, and there it is, leg saved, fracture healed. Another one, you can see the message. This is actually a 8-month non-healing diabetic ulcer in a CKD patient, and one place advised amputation, another place advised bone cement, filling as a first stage and then rotation flap or something. That's in 7 days, 10 days, all healed in 4 weeks. Look at this foot. Day 1, day 3, day 17. Human papilloma virus. You can see fulminant. Belonged to a young model, and she was going to Germany to get some laser. Just one vaginal ozone and hematogenous ozone, and the parts have fallen off. Buccal cancer, you can see one on the left, just ozonated glycerine swabs and became alright. This is a type of diabetic ulcer which will go for midfoot amputation. He already had a ray amputation, you can see on this, and you can see such a deep ulcer gets filled up in less than 3 to 4 weeks, and he goes back to the field without any special footwear. Again, you can see non-healing diabetic ulcer, one ray amputated. This is almost 2 years old. The middle one is after healing, and the other one is after 1 year follow-up, still working in the fields. A case of yours, let us rather rare one, scraping and ozone, and there he is. And of course, the hot topic of today for an orthopedic surgeon, avascular necrosis of femoral head. You can see a sectoral avascular necrosis, head about to collapse, and 18 months later you can see that the head has recovered, no core decompression, and of course no THR. Again you can see on the left, a head on a verge of collapse, and right, the whole head has revascularized. This gentleman is a surgeon who had a hepatobiliary carcinoma, and he came to me, about 3 liters of ascites was aspirated. Do we have an audio lead here? Do we have an audio lead here? Audio. No audio. So it doesn't matter. So, this patient is giving his testimonial. So what?
I myself, Professor Dr. Praveen Chaudhary, MD Medicine, have taken Ibu from Dr. L. Prakash. Dr. L. Prakash, after chemo of pancreatic ductal adenocarcinoma. After that, the side effect of chemo dramatically reduced, and all hair grow well.
Anyway, he said that he is happy. Hello? Yes. So now, molecular therapeutics produces real, wonderful, quantifiable results in a wide variety of cases. 4 questions. What are these molecules? How do we produce or get them? How do they act? How are they administered in a patient? The 2 commonly used molecules are ozone and hydrogen. Ozone is triatomic oxygen. It is produced naturally when lightning strikes during the first rains. So whenever there is a lightning, you will find some faint fishy smell, and that is ozone. It has a trimodal action, 3 types. Just as our star used to shoot triple arrows, each hitting a different target, ozone also works in 3 different ways, hitting 3 different targets at the same time. It is one of the best antibacterial, antiviral, antifungal, antiparasitic agent. Meaning it is 16 times more powerful than chlorine bleach and 24 times more powerful than hydrogen peroxide. When all antibiotics fail, ozone comes to the rescue. We now have a series of about 40 TKRs, infected TKRs who were posted for 2-stage revision, who have been given ozone and they didn't need revision at all. Dr. Ganesh Hankam is in the audience here. He himself has a case which was advised 2-stage revision by many people, but the primary implant was retained, ozone was given, it consolidated, and the patient at the end of 5 years has no infection. This is a wonderful immune modulator, the first DMARD to be considered in all autoimmune disorders. And thirdly, the antioxidant cascade triggered by the oxidation, which is called a reactive oxidation species, will produce superoxide dismutase, catalase, glutathione peroxidase, glutathione, and NRF2 alpha. These are the strong antioxidants, and these continue to remain in the body 3 to 4 weeks after the session, and they continue to detoxify the body from the effects of pollutants, hydrocarbons, food additives, pesticides, insecticides, and other things, and help in age reversal also. So this has got a broader detoxification effect. This continues for a significant duration, helping the body to cleanse itself of toxins from vehicular pollution, hydrocarbons, pesticides, food additives. In addition, ozone also possesses excellent analgesic and anti-inflammatory action, making it the orthopedic surgeon's best friend. So the routes, except for inhalation, which is irritant to lungs, can be given subcutaneous, intravenous, intraarticular, paravertebral, epidural, local, topical, ozonated saline, major autoimmunotherapy. I'll show you some small clips subsequently. This is day before yesterday's case. Patient had a head injury and a chest injury, and he had massive periorbital hematoma and swelling. It was like a compartment syndrome around the eye, and within 20 minutes of injecting ozone in both upper eyelids and lower eyelids, you can see that everything has shrunk. This is a case which belongs to Dr. Ganesh of Telangana only. Patient with impending compartment syndrome, no fasciotomy was done, only subcutaneous ozone was administered. That's immediately after that, and that's the patient. Nowadays you stop doing fasciotomies. This intraarticular, you can see the joint is stiff in a rheumatoid, and there you can see the movements immediately after the thing. Hip, when there is no joint, you give intraarticular, and you can see that the joint distracts, opens up, movements dramatically improve, and you can delay total hip replacement by many years. The second molecule we use is hydrogen. Hydrogen is the most abundant molecule in the universe, but is not present on the earth in its native form. This is the most powerful antioxidant known to man and neutralizes most free radicals, protects the cell mitochondria, reduces inflammation, supports recovery, and increases the longevity. Hydrogen can be inhaled, injected, you can have a hydrogen bath, you can have hydrogen water infusion, a very wonderful molecule. This is me undergoing a hydrogen infusion drip, which I take monthly once for my longevity and age reversal, working well. That was me about 30 years ago, and that's me today. And you can see from 2019 to 2026, I have become younger and my hair has become darker from the roots. I walk 15 kilometers every day and I am very active because every month I take these procedures on myself. Now this is some theory which I will run through fast. How do these molecules act? We have to unlearn what we have learnt. We all know that mitochondria is the powerhouse of each individual cell. But How many of us know that the mitochondria have their own genes, which is different from our human genes? All the three people in the back will have different cellular genes, but their mitochondria will have identical genes. It is currently postulated that all humans inherit their mitochondria from a single female X chromosome, that is called the mother mitochondria. And mitochondria were once bacteria whose genes resembled a few genes of bacteria, and when the cell engulfed the mitochondria, if the mitochondria was stronger, it would kill the cell was stronger, it would kill that mitochondrial bacteria. In very rare cases, a symbiotic relationship was formed where mitochondria said, I will produce power and you supply energy. We have been seeing the illustration of one cell, one nucleus, one mitochondria in anatomy books. This is incorrect. This is the true picture, because RBC have 0 mitochondria. No cell has less than 50 mitochondria per cell, and some cells have up to 80,000 to 1 lakh mitochondria in a single cell. Every heart cell will have 11,000 mitochondria. With evolution, mitochondria increasingly took up the roles of more than energy: cell multiplication, cell death, apoptosis, telomere length, general aging, and many other subcellular roles. And so, right from cancers to aging, mitochondria started. When a mitochondria becomes rogue, uncontrolled cell multiplication will cause cancer, affect the thyroid, you get hypothyroidism, it affects the adrenals, you get hypertension, it affects this thing, pituitary satiation center, you get dyslipidemia. The cause is rogue mitochondria, and the rogue mitochondria will cause all this. Mitochondria becomes rogue by the toxins that we are increasingly accumulating: plastic, hydrocarbons, insecticides, pesticides, and of course bad lifestyle and incorrect type of food. And the rogue mitochondria will affect all organs, and that is why most arthritis patients are also diabetic and hypertensive and obese. So we have to reset the mitochondria, and thus we can see that all these disorders are interconnected or interlinked to one subcellular unit, which is a mitochondria which has gone rogue. Molecular therapies resets the rogue mitochondria and brings order from chaos. Now, a very simple question: how do we get ozone and hydrogen in our clinic? We have a ozone generator and a hydrogen generator. Ozone generator uses only pure oxygen cylinder, and the machine will produce ozone. You can fill it in a syringe and it will fill up. And ozone is something which will dissolve the latex, and you can see here it smells pungent. It is a glove, and the glove is torn. That's how hydrogen is produced. It is made from distilled water, H2O. It just separates into H2 gas and O gas. You just plug it in and switch the machine on, it will start producing hydrogen. And hydrogen can be tested by just flaming it, it will burn. And this cannot be blown out, you have to dip it in water. So as simple as that. So there is no recurring cost. Once you buy the machines, you continuously produce them, you don't have to pay to any pharmaceutical company. This is me undergoing a procedure called EBOO, which I now do almost once a month. You can see the dark colored venous blood which is going from the donor side, how it goes up, how it gets ozonized, and you can see the stark color difference of the bright red blood that is going back into my body. My assistant, who is here, Arunima, was diagnosed as juvenile diabetic 2 years ago with an HbA1c of 14.1 and sugar of 410, and she was put on 45 units of insulin. She is here sitting in the audience. Today her HbA1c is 6.2 and sugar is about 110 fasting, and she does not take any medication. She just takes once a month of this session. So where do I use molecular therapeutics in my practice? Metabolic and lifestyle disorders, diabetes, obesity, dyslipidemia, cardiovascular disorders, hypertension, atherosclerosis, heart failure. Very important, autoimmune and inflammatory, rheumatoid, lupus, IBD, psoriasis, neurological conditions, Alzheimer's, Parkinson's, multiple sclerosis, cancer care, oncology, post-chemo, post-radio. This is not a private treatment for cancer. Infectious diseases where all antibiotics fail, Right now H1N1 thing, dengue epidemic, one MMAST or one EBU will clear off the infection. Previously, whenever I used to take a flight, I used to get cough and cold when I come back from a conference. Now, touch wood, last 2-3 years, 4 years, I've never had that problem. Pictures speak louder than words. So I'm just going to show you 2 videos and close my talk. Number 1, this is a lady who is, you can see 74 years. You can see the date also. And she was wheelchair bound. And she refused to get a TKR because her younger sister had a TKR and one of the knees was infected. And she was on a wheelchair waiting for her second stage. So this woman said, I'll stay on wheelchair, but I will not get operated. I want a non-surgical treatment. So this was done, and that's 6 months later. She walks 500 meters to temple up and 500 meters back, that's 1 kilometer a day. She's on DMARD's Mukherjee regime. You can compare both the dates. One is on 4/24 and the other one is 11/24. So they are 8 months apart. No surgery has been done. Joint has opened up, cartilage is forming, patient is functional and pain-free. That's one. This is a lady, Sikh lady from Italy, who had come to Amritsar and fell and had a trochanteric fracture. Now actually, vascular ozone rapidly makes fractures heal and shortens the fracture healing time. In the group, the Italian doctor asked what to be done, so we said send him to our colleague Deepak, and there she had. Now she's saying,
such a blessing to know you through my dear doctor.
And then we can see her in 8 days walking, no surgery done. We were blocked and walked. Now we have crossed about 120 trochanteric fractures without DHS or PFN. And molecular therapies do hasten fracture healing. You can see here, that's the end of 3 weeks and that's the end of 4 weeks. And you can see the X-rays. On the left is 3rd February 2024. Next is 24th of March. And the fracture has healed. No plate nail can heal a fracture so fast. And that's the video she sent to me exactly at 90 days of the fracture, where she was practicing her calisthenics. And see the way she is jumping. So, take home message, be aware of the rogue mitochondria, the detrimental effects on the human body. 2, master ozone or hydrogen, and you can conquer many unconquerables. All therapists are welcome to join us in the studies. Let us change history and leave footprints on sands of time. Any orthopedic colleague who has entered into molecular therapeutics has increased his patients, got more blessings and much more happiness. You can take a photograph of this slide. This is my WhatsApp number. Send a text message in WhatsApp to me anytime you want. I will send you 800 papers of publications on ozone and hydrogen, how they work and how they are to be used. So this is the number on which you have to message me. I'll send a PDF file of all the published publications. We also have a textbook of molecular therapeutics which you can get whenever you feel like. And thank you all very much for wonderful patient listening. I could conclude about 4 minutes before my allotted time because we're running short of time. Thank you very much.
Thank you very much, sir.
Question? Yes, please.
No questions.
It was an excellent talk, sir.
Thank you very much.
Yeah, we will move on to the next orations.
Next,
So thank you very much.
I request the chair, the scientific committee in charge, Srinivas Reddy sir, Maheshwar sir, Ramkumar sir, and Vijay Chandra Reddy sir to come and felicitate Prakash sir. Apart from that, I request all the earlier speakers also to come on the stage to have a small felicitation from us, and then we will start with the orations, Oasis orations.
On here. I'll leave it here.
Give him a nice applause, sir. It was a fantastic thing. Very, very conventional for us. Kindly bear with the delay in the program. We will shortly be starting the Oasis orations. Thank you very much, Prakash sir. Request the Dr. Maheshwar sir and Srinivas sir kindly felicitate the chairpersons of this session. MS Gaud sir, Rajan sir, అందరికీ Rajan sir is also contesting next IOA treasurer post. Request all the members to support him too. I request all the members, because OAS's orations are going on, I request all the members who are standing outside to come into the hall. It will be only this session in this hall A. Halls and other things are stopped. I request all of you to come in. It's going to be a very interesting session for us. Excellent speakers in past president's oration, Dr. Krishna Gopal sir is going to do, Dr. Ramakrishnan sir is going to do, and Krishna Kiran sir are going to do. So request all the members to come into the hall A. I request the president of Oasis, Dr. P. Vijaychandra Reddy sir, to come onto the dais and preside this over. I also now, as welcome. I also request Oasis General Secretary General Dr. Roshan sir also to come onto the dais, please. Again, I appeal to all the members who are there outside to kindly don't stand on this thing, kindly come and sit here. It's going to be an interesting oration program. All the delegates are requested to come in. May I take the honors of calling upon the orator on the stage, Dr. Krishna Gopal Ramamurthy from Puducherry, sir. He is the past president of Oasis. He will be giving the presidential oration now. I request the secretary, sir, to introduce the orator.
Very good morning. Before I introduce the orator, I will just give a brief history about the Professor A. Srinivas Rao Presidential Oration. Professor A. Srinivas Rao was born on 2nd July 1940, completed his MBBS from Jipmar, Pondicherry in 1962 and his MS Orthopedics at AIIMS, New Delhi in 1968. He got a fellowship of orthopedic at Pathology Hospital for Special Surgery, New York in 1981. Professor A. Srinivas Rao worked as an assistant professor of orthopedics, Government Medical College, Andhra Pradesh from 1968 to 1984. At Government Medical College, Andhra Pradesh from 1984 to 1986 and again between 1988 and 1998. He was also a professor and head of Department of Orthopedics at Nizam's Institute, Hyderabad between 1986 to 88. He was Additional Director of Medical Education, Andhra Pradesh. He was the principal of Gandhi Medical College, Hyderabad during 1996 and he was also Superintendent of Gandhi Hospital, Secunderabad. He used to consult at CDR Hospitals, Hyderabad 1998 to 2005. Also was a visiting consultant, General Orthopedics and Orthopedic Oncology, KIMS Hospital, Secunderabad till date. His research experience is very vast, only few to mention. He was a research fellow at AIIMS, New Delhi between 1965 to 1966. Research and developed low-cost shank for immediate post-surgical prosthetic fittings in below-knee amputees at Hyderabad. His achievements and awards: he won the Orthopedic Association Johnson & Johnson Traveling Fellowship 1973. He was a Bombay Orthopedic Society E-Merck Fellow during 1976. He won the Vagreshwaradu Gold Medal for the best paper presented at the annual conference of Andhra Pradesh. International Service Award 1993 from Foundation Hyderabad. Vaidyaranga Seva Nidhi Award from International Social Service Award. Acharya Sri Sadbhavan Puraskar in 2005. He was also an emeritus professor at Gandhi Medical College, Secunderabad. Sir has delivered orations at many conferences, to name a few: at annual conference of UP Orthopedic Society, Jhansi, Indian Orthopedic Rheumatology Association, Ahmedabad, Dr. Satyanarayana Murthy Memorial Oration, Tosa during 2021 at Hyderabad. Sir has also delivered guest lectures in more than 25 conferences. He has been a faculty for many orthopedic courses and also in postgraduate teaching programs. He's been a postgraduate examiner on multiple times. Sir is also chairman of AP sections at IOA and represented AP chapter in the Indian Orthopedic Association conferences several times. His organizational and leadership skills: Sir has organized many conferences like APOCon, IOA conference at AP chapter of Indian Orthopedic Association conference, a course on prosthetic and orthotics at NIMS Hyderabad, and many CMEs of orthopedic education courses at Hyderabad and many more. He has plenty of publications and he was a member of IOA, AP chapter of IOA, Orthopedic Society of Twin Cities. He was a member of Association of Spine Surgeons of India, Hyderabad Surgeon Society, IMA, Member Society, Indian Orthopedic Rheumatology Associations. Professor A. Srinivas Rao Presidential Oration will be delivered today by our immediate past President of Oasis, Dr. Krishna Gopal sir. A brief introduction of the orator. Professor Krishna Gopal is a professor head of the Department of Orthopedics at Mahatma Gandhi Medical College and Research Institute, Pondicherry. He completed his MBBS from JJ Medical College, Davangere in Karnataka under Kuvempu University. He possesses a fellowship in orthoscopy and sports medicine from Sri Ramachandra Medical College. He had a small brief stint of 2 weeks of clinical attachment at NHS Hospital, Kent, UK. And also he had a clinical attachment under Professor Alex Felix Berda at Netherlands, Europe. He is also a member of the Indian Orthoscopy Society, Indian Orthopedic Association, Indian Medical Association, OASIS, Tamil Nadu Orthopedic Association, Tamil Nadu Arthroscopy Society, and also Pondicherry Orthopedic Association. Plenty of achievements, a few to mention. These are the work certifications he has. And today we have with us Dr. Krishna Gopal sir. Come. I request the president of the OASIS to adorn the orator with the gold medal and then honor him. Change chestanu.
Sir is going to do the oration. His topic is Panchatantra in orthopedics. It's going to be a beautiful talk.
Yeah. After adorning the Oasis presidential oration, I request Dr. Krishna Gopal R to deliver his oration. Thank you.
Good morning to all, respected President, respected General Secretary, and the august audience. I'm excited and overwhelmed to stand before this august audience to deliver the presidential oration by the name Panchatantra, where I had been taken 2.5 decades of experience. Though this may be a Panchatantra in orthopedics, it holds good across disciplines, and my talk will focus on arthroscopic career. So first tantra would be the knowledge. Every successful surgeon begins with the learning. And my learning started with the doyen of orthopedics, who by the name we have even an oration in this Oasis. So he has mentored me a lot and it laid me a foundation in orthopedics. I'm grateful to other teachers like Professor C. Subramaniam, Professor P.V. Vijayaraghavan, Professor S.V. Satyanarayana, Professor A. Chandrasekharan, Professor Gopinath Menon, Professor M. Mohan Kumar, Professor R. Durai Kumar. My first motivators towards arthroscopy were Professor M. Narayan Reddy and Professor Gokul Raj. One fine day after my post-graduation, when I met Dr. Narayan Reddy, he called me and asked me to do arthroscopy fellowship as it was fast evolving and no one in Pondicherry was doing it. He was at that time working at PIMS. Then I met Dr. Gokul Raj for a solution in this, and he asked me to meet Dr. Armugam. So I met Dr. Armugam for persuading fellowship. He then asked me to join in January 2003 as the first fellow under him. It was a joint program also with Dr. C. Rajshekhar Reddy at Vijaya Institute of Traumatology and Orthopedics. My basic skills in arthroscopy started here from these two stalwarts. During this fellowship program, we had an international arthroscopic meet where I gained my basic arthroscopic knowledge and skills under these esteemed faculties. Then after these 6 months of fellowship at the Ramchandra Institute, I had an opportunity to have observership arranged by Dr. Rajshekhar Reddy, arranged under these two surgeons, Dr. Raj Srivastava and Dr. Christopher Brooks. And following that, Professor Armugam had arranged an arthroscopic fellowship program at Amphia Hospital, Breda, Netherlands in 2003. So I stayed inside the hospital with so that I can learn more about the arthroscopy, and that is Alex Five and Dr. Van Omeren. This was inside the operating room. The other pictures with all the unit chiefs of that hospital during a department get together. So like every young surgeon, I believed surgery was about operating. My mentors taught me that surgery is actually about thinking. So preparation before performance is the key for a successful surgery. They taught me anatomy before arthroscopy, diagnosis before treatment, and humility before confidence. So one point I would like to mention here, during my undergraduate days, I had aversion towards osteology, finding the destiny to become an orthopedic postgraduate. And during my postgraduate days, I literally omitted the chapter in arthroscopy in the book Campbell, and that was my final destiny, to become an arthroscopic surgeon. The next tantra is skill. You all know that practice makes man perfect. So I started my arthroscopic practice at Puducherry at MGMCRI. So with the able support of Professor K.R. Tyagarajan, I started my arthroscopic career, and then head of the department and even the past Oasis president. My first ACL reconstruction was done with BTB graft for a duration of 3.5 hours with hand drill and with the help of Dr. Veerappan. These are a few pictures showing that I had to take my own set of arthroscopy system to institute to perform the surgeries. Since the institute took some time to procure the system way back in 2004, the institute was only 3 years old. I did almost first 100 plus cases with bone patellar graft and using hand drill and occasionally power drills. So later on in 2006, I had an opportunity to invite all these eminent faculties and conduct an arthroscopic program in MGMC to share the knowledge and get updated with the skills. Then I started doing hamstring graft ACL reconstruction by transtibial technique with cross pins, bioscrews, which this technique is now not in vogue. So I started attending several national and international conferences and cadaveric workshops in order to further update myself and sharpen my skills. These are the most important programs I have attended: shoulder and elbow course at Ganga Hospital, regional arthroscopic training programs by Indian Arthroscopy Society, cadaveric course on shoulder arthroscopy at Chulalong University, and as many Indo-European Arthroplasty Arthroscopy Foundation courses at Ramchandra Institute. Then I started doing the shoulder scopies. My first arthroscopy took much longer than today's procedures. Every portal placement required thought. Every movement demanded concentration. The mistakes I made became the teachers I never forget. I had 2 cases of interference screw blowout posteriorly in my earlier days and 1 patellar fracture while harvesting BTB graft. My third tantra would be the team. No great surgeon ever succeeds alone. So the team started with first with Dr. Veerappan in 2004 to 2010, where years passed by and there were many joining the team and leaving for their own personal reasons or their interest was on other subspecialties. Probably because I was the first to start with arthroscopy, they all moved to spine, plasty and so on. Dr. Vineet in earlier days and Dr. Kotishwar were the two persons who underwent fellowship and they joined my team. Currently, Dr. Kotishwar is in my team. I had a few postgraduates who were developed interest and followed me doing arthroscopies. So what a team adds actually. Another pair of eyes that can identify something you may miss. Difficult decisions can be discussed immediately. Anesthesia, positioning, instrumentation, post-op care and physiotherapy becomes coordinated. Complications can be managed more efficiently. A team provides continuity when the surgeon is not available. Even today, my team is operating on knee case. In this journey, I got an opportunity to share my knowledge, experience, skill to my assistants and postgraduates. While doing so, I kept learning and updating myself too. My greatest satisfaction today is not that I can perform an arthroscopy procedure. It is that I have people around me who can think, anticipate and act even before I ask or so. A single surgeon can perform an operation. A team can deliver a complete patient experience. And a good team can create the next generation of surgeons. A team, teaching and legacy. So my academic research works include, I had opportunity to involve in evidence-based research, thus contributing to postgraduate dissertations and publications. I have guided around 43 postgraduate students in their dissertation work till date, and around 16 plus were published in index journals in the field of general orthopedics and arthroscopy. A few of them to note are a study on vertical and oblique incision for hamstring graft harvest and its relationship with peri-incisional dysesthesia, study on the functional outcome of arthroscopic anterior cruciate ligament reconstruction done with bone patellar tendon bone graft using the IKDC score, correlation between MRA and arthroscopy in the internal derangement of knee, early clinical and functional outcome of rotator cuff tendinopathy of the shoulder treated with platelet-rich plasma injections, review on the various surgical techniques in the management of complete rotator cuff tear, and many more. So this is the team where Dr. Vineet and Dr. Surender were with me for a long time, and the assistant professors and the postgraduates at that time. Now we have a sophisticated team, well experienced with fellowship undergone. So these two persons, Dr. Kotishwar and Hari Kishore, are my team members, where they are taught to do the diagnostic, and even now Dr. Kotishwar is able to do many meniscal repairs and even better than me. I am proud of it. This is my current team. And I had an opportunity to meet my international mentor, Dr. Alex, in Chennai during the International European Arthroscopy Arthroplasty Foundation, along with my teammate. The next tantra would be the infrastructure. Technology never replaces the surgeon, but it empowers the surgeon. My first set of arthroscopy instruments were a halogen light source, single chip camera, and the video scope and the shaver system. But now the current instrument and OT setup which I have in Mahatma Gandhi Medical College is this one. I am fortunate to have this status. I am able to convince the management and get such an armamentarium. A small clip of what I had based on the infrastructure what I had during 15 years ago, and you can see the difference, how the clarity and how the camera was available 15 years ago and current 4K system. So this is the, sometimes I envy the current generation, so they are having 4K system and well advanced equipments in their armamentarium and they're easy to learn the technologies available. Sometimes it's difficult for some of us to learn at a later stage. So earlier days where the armamentarium was not available for meniscal repairs or the financial support by the patients were not available, we were forced to do meniscectomies so that patient goes back to work at the earlier stage. Currently, we are able to do a meniscal repair with available infrastructure, with a good team and the financial support by the scheme or insurance companies and the patient's awareness for undergoing such procedures. This is a small clip of a shoulder Bankart lesion. The anchor placement and following the repair, the entire labrum is on the glenoid. So when I started 2 decades back, resources were limited. We learned to maximize what we had. Today's technology, government and private schemes has transformed the arthroscopic procedures and the final outcome to the patients. Now infrastructure and technology are not luxury, but it's a mandate, as we had been talking few sessions earlier this day. It is patient safety. The last tantra is the patient factors. Everything starts with the patient and ends with the patient. So treat the patient, not the investigation. So assessment of the patient's history, clinical evaluation and radiological correlation is the prime factor and the key factor for all surgeons to treat the patients. The communication and trust, expectations from the patient, rehabilitation and follow-up are the most important. The availability of the government schemes, private insurances have facilitated patients to undergo surgeries where we restore anatomy and improve their clinical outcome. A good surgeon is one who knows when not to operate in a patient. The surgical outcome falls in 4 categories. 100% outcome will be with all these 4 things. 1 is the pre-op workup, 2 is the surgery per se, 3 is the post-operative care, and the 4th one is the patient himself, patient's compliance and his family support. So beyond the operating room, 5 hidden pillars. First, health, physical fitness and an active lifestyle, mental well-being and adequate rest, discipline in diet and daily routine. A successful career needs a healthy person behind it. A good family support, strongest support I have with my parents and my wife and children. So friends, maintain friendships beyond medicine, share laughter and experiences, space away from professional responsibilities. Good friends make journey lighter. So vacation and travel. So pause, explore and recharge. These are few pictures of my vacation and travel. And lastly, my passion, hospital to hospitality. That is a resort I'm owning. So to end this, that is the 5 tantras and knowledge, skill, team, infrastructure and patient factors. The best arthroscopic procedure is not the one performed through the smallest incision, but the one that leaves the greatest impact on a patient's life. Thank you.
I request Dr. Ramkumar sir, scientific physician sir, to respectfully accompany the orator down the hall.
Thank you, Dr. Krishna Gopal Ramurthy.
Thank you, sir.
I think your topic would have been an inspiration to many young orthopedic surgeons. Thank you very much.
Thank you, sir. Now we go ahead with Dr. Sudhakar Shetty sir's oration. This is given by Ramkishan sir. He's from Kollam, Kerala. His topic is My Journey in Arthroplasty. I request sir to kindly come onto the dais and give his oration. Request Secretary sir to introduce the orator.
Yeah, before I introduce the orator, I'll just give a small briefing about Professor M. Sudhakar Shetty oration. Professor M. Sudhakar Shetty oration. Professor M. Sudhakar Shetty was born in an illustrious family on 4th December 1946. He graduated from the prestigious Government Medical College, Bangalore, and earned his MS Ortho degree from Bombay University. Working as a resident in GS Medical College, Bombay, one of the busiest orthopedic centers of the country. He had acquired abundant skills in orthopedic surgery, and with the will and vision to serve his own people of his home district, he came back and settled down in Mangalore and joined the Kasturba Medical College as assistant professor way back in 1975. Professor Sudhakar Shetty, always determined to better himself, in 1980 he proceeded to Liverpool, worked with George Bentley, and he passed MCH Ortho with distinction. He served KMC Manipal for more than 32 years. He was a professor and head of the Department of Orthopedics for a full term. After retirement, he joined Enepoya Medical College as a professor and rose to be the vice dean of this medical college. A rare blend of perfect clinician, excellent teacher, and a brilliant surgeon, Professor Sudhakar Shetty had trained more than 200 postgraduate students who are spread all around the globe. He has an inherent thirst for teaching. He was instrumental in starting the popular Mangalore Orthopedic course, which is very popular today among the postgraduates. He is a visionary. He was a visionary. He started the Canara Orthopedic Society, which today has more than 350 members, imparting fellowships, understanding and knowledge treasures of its members. He was the past president of the KOA and Orthopedic Associations of South Indian states as well. A very active member of the Indian Orthopedic Association, he was awarded the coveted honorary membership and lifetime achievement award, which he richly deserved. Today, Professor M. Sudhakar Shetty oration will be delivered by Professor Dr. Ramakrishnan S. Dr. Ramakrishnan S., who works at Vijaya Hospital, Kotarkara, Kollam, Kerala. Sir completed his MBBS from Government Medical College, Trivandrum in 1992, MS Orthopedics from Government Medical College, Calicut in 1996. He also has Professor K.T. Dolakia Fellowship in Arthroplasty. He completed that in 2001. APOA Fellowship in 2006, Hamburg Fellowship in 2008, Professor P.K. Surendran Gold Medal of KOA for Best Paper in 2001. He's been practicing for the last 30 years and he's presented various papers at national and international conferences too. He was the president of Kerala Orthopedic Association in 2022. Sir, we are truly honored to present this citation to you on this occasion of Oasiscon 2026 for delivering the prestigious Dr. Sudhakar Shetty Memorial Oration and for your outstanding contributions to research, education and patient care. Thank you, sir. I request the President of Oasis to adorn the orator with the gold medal and honor him.
Visham Shanti Bhavatu.
It will come later. Come in this. Whatever you.
I prefer to have it.
Yeah, before the speaker starts his oration, I can also share my memories with Dr. Sudhakar Shetty sir. As a student of Dr. Sudhakar Shetty sir, in fact, I assisted him in way back in 1987 in a scoliotic spine surgery correction through by Harrington rods, Harrington instrumentation. That was the first surgery done at Wenlock Hospital in Mangalore. And I am also associated in starting the Mangalore orthopedic course, the first session I attended. And also we were awarded the best chapter award of Karnataka Orthopedic Association under his stewardship when it was conducted. So these are the memories of Dr. Sudhakar Shetty, very academic oriented and dynamic personality. We lost him, a good giant personality in the orthopedics from South India.
There are many students of Sudhakar Shetty sir here in the auditorium as well, sir. He is a known personality across South India. Even in Warangal Orthopedic Society, we have Dr. Kranti Kumar, who was a student, and as a postgraduate from Karnataka, we attended many conferences of KOA with under his guidance.
Hello, a very warm good morning to all of you assembled here. Respected Chairman, Secretary of the Oasiscon team members, senior members of the profession, my teachers, colleagues, friends, ladies and gentlemen. Let me first thank the organizing team and Oasis for giving me this opportunity to present my experiences in presence of this august audience. I am privileged to stand here to deliver the Professor Sudhakar Shetty oration. I have taken my experiences in arthroplasty as the topic for this oration for two reasons. One, arthroplasty being my best subject. I was the first surgeon in my district to perform the surgery in 2004. Also, I would like to give a few tips and messages to the younger upcoming orthopedic surgeons, which is a summation of my experiences.
Greetings from Kerala and Kerala Orthopedic Association. I come from the land of Lord Padmanabha, the temple being considered probably one of the richest religious places in the world. Also we have nearby the Jatayupara, where the mythological bird Jatayu laid his life trying to save Sita from Ravana. My flow pattern of the talk will be like this. I feel my talk will be incomplete without mentioning Sir John Charnley, the pioneer and legend who introduced us to the world of joint replacement. I also had the opportunity to read his book page to page twice during my fellowship. No amount of words can fully express my gratitude to my teachers who taught me the basics in orthopedics. Professor N.J. Mani, he is like my father. He used to say, Ramakrishnan is my son, not born out of me. So we are so much close. And also Professor M.K. Vishwanath, the late Professor M.K. Vishwanath, who was highly motivated teacher, and we used to have sessions where we had to forego our lunch and dinner. As you know, Professor T. Gopakumar sir also was a very active person. He first introduced me to the art and skill of presenting papers at conferences. I had my first experience, the real experience of learning arthroplasty under none other than the legendary Padma Shri K.T. Dolokia during my fellowship with him. As you know, he is the father of arthroplasty in India. His team members included some of the doyens in arthroplasty, Dr. Pachore sir, Professor Vaidya, Professor Lord, Professor Junjunwala, etc. I also had another stint with Dr. Ashok Rajagopal in Delhi during my WOC fellowship. These two personalities I haven't put names because I fully know that the whole crowd assembled here are well versed with them. Shantaram sir, we used to interact at various occasions and used to get a lot of scientific tips from him. And Professor Sudhakar Shetty, in whose name this oration has been instituted. And incidentally, he was my examiner for my MS. The above list of teachers is incomplete. You have a lot of senior persons whom I have learned during the course of my career. Professor Junjunwala, Cherian Thomas, K.C. Gopalakrishnan, Jay Prakash, Achan MLX. The list is quite long. I have imbibed quite a bit from each of these persons. So also goes with my colleagues and not to mention my patients who are ultimately our teachers. My mentors in APOA fellowship, Dr. David Choon and Professor Donald Hovey, I had a very good stint with them during my fellowship, HIP fellowship. And I had my revision fellowship at the Ento Clinic in 2008 where I saw Dr. Thorsten Gerke working in hips. He just finishes his primaries in 15 to 20 minutes. It was like a computer working on the hip. So also Dr. Bernschwanz and Dr. Klosser. This is the Endo Clinic in 2008. Dr. Sudhakar Shetty already has been given brief about him. He was born in 1946 in an illustrious family. And he did his MBBS in Bangalore and his MS from Bombay University, and he was working as a resident at St. G.S. Medical College. He was working in KMC, started as an assistant professor at KMC and served the institute for more than 32 years. He conducted the Oasiscon in 2007 in Mangalapuram, and he was also instrumental in starting the course with the same name. He was an exemplary leader, teacher, mentor, role model, and a superb host. I started my practice in this township in 1996, And there were many friends who actually dissuaded me in starting my career in a small township, in a small hospital setup. But fortunately or unfortunately, I had been persistent and had completed 30 years this year. And what started off as a single man department, we have now 6 full-time consultants in our hospital. The major part of my 3 decades career has been in this hospital. And my arthroplasty career started in 2004. And in the following slides, I selected a few cases which may be of interest and where you will have to think out of the box. This first case is a 60-year-old lady. She came to my OPD quite some time back on a wheelchair. She was quite healthy but for her OA knee. And the X-ray on the left actually is what she brought, and she was having severe pain. And on clinical evaluation, actually her tenderness was actually down a little further down distally in the metaphysis. And I had the wishful thinking of taking a longer X-ray, which actually revealed a stress fracture. And luckily for me, so I was prepared before the surgery, and I treated the patient with a stem extension. Otherwise, if I had not been for that clinical thinking, I would have struggled on the table. This X-ray belongs to a staff nurse who was actually bedridden, though she was in service. Her son used to take her to the hospital in an auto rickshaw and bring her back every day. She had a windswept deformity, as you all know, and she was struggling to make her personal needs by herself. So that was the first case where I did a bilateral, of course, staged 1, and also my first valgus knee. So I did the valgus knee with a stem extension, and the other one on with a regular implant. And this lady is still on my follow-up, nearly 22 years down the line, and we actually frequently invite her as a guest. And this is one of the photos where she inaugurated an arthritis camp in our hospital. This X-ray again belongs to a retired professor. He was having severe pain and he was having difficulty in walking. As you can see, there is a grotous deformity of the knee joint with a stress fracture in the upper tibial metaphysis. He was very reluctant to undergo surgery, but finally he is happy and walking nearly 15 years after the surgery. The next one is a quite interesting one. It's a 50-year-old lady, about 52-year-old lady. She was a very active person and a local politician. She was having recurrent pain and swelling in the knee joint. She didn't have any major comorbidities. And of course, sorry for the poor quality of the X-ray. It's an old X-ray that was way down in 2009. And I could detect some cystic lesion in the upper tibia. And we did an MRI scan actually which showed multiple cystic spaces in the proximal tibia and a few one in the distal femur also. So with some amount of preoperative planning, we operated her, opened her, and on the table we found lots of curdy white precipitate filling the joint and flakes of cartilage, free floating cartilage. So definitely we took the biopsy, histopathology, culture, everything was done, and we proceeded with the knee replacement. We used a stem extension as has to be done, and the culture report, the biopsy report came out as tuberculosis. It was a surprise because preoperatively, except for a slight elevation in ESR, there was no other parameters which could point to that. And of course, postoperatively we started her on a full course of ATT. I think we gave nearly 1 year of tuberculosis therapy. She is fine and she has upgraded herself into some panchayat president. This is X-ray of a doctor, a retired from health service. Her family has got two daughters and 2 son-in-laws, all doctors. And she came to me first, and I advised her to go for a total knee replacement. But probably after a lot of thinking and Googling and all, they went for a robotic uni knee replacement. And unfortunately for her, the surgeon got an intraoperative fracture in the upper tibia. And probably he thought he can manage it with a single screw. And she was made to have a bed rest for nearly 3 months, and then finally she had to undergo a revision, but she is fine nearly 7 years down the line. This is one of my own cases where I did the primary. She had a fall about 10 years after the primary and developed a late PCL failure, and without much ado we could revise it into a semi-constrained knee. This again is a learning point case. This is again a staff nurse. She was working in a small time hospital in a small township near our place, and the orthopedic surgeon offered to do a knee replacement for her, and unfortunately for her he cut the MCL and didn't realize it. And later on, after a few weeks, he reopened her, tried to put a bigger spacer. I haven't put the whole series of x-rays for lack of time. He put a thicker poly, repaired the MCL, but still it failed. And invariably what happened is she came to me, and we actually made her to, because most of the money was drained for 2-3 procedures. We posted her as part of a live demo during a conferences, and this x-ray actually is the post-operative x-ray which was done by one of the senior persons, but again it was not working for her, and after 4 surgeries she is totally head up with all sorts of knee replacements, and she said, I don't want these sorts of knees, kindly help me walk. So the only option is to go for an arthrodesis, and my mind and my team's mind is, when we remove this implant, there is going to be a huge bony defect, which how we are going to manage. Is it by an Ilisaro or is it some fibular graft? But all these again may take time, 6 months approximately. So she doesn't want to be bedridden also. So invariably we had the option of going in for what we call as a CAM prosthesis. It's a little expensive, but we subsidized all her other expenses so that we can make her walk. So I think it is 5 years now. I don't have the recent X-ray now, because when you call her back, she says, I'm doing fine, I don't need to come. So this is one of the initial X-rays, post-operative X-ray. She is walking fine, of course with an arthrodesed knee. So this is another case of a very sprightly, charming, glamorous lady, which in 50s. Her daughter is an Ayurvedic doctor in Singapore. And she came with bilateral knee pain. She wants to be relieved of that. She had tried all sorts of other conservative methods. And the X-ray on the left is actually what you call, we take as the weight bearing X-ray. And the one on the right is the valgus stress view, which is described by in the original textbook of the Oxford team. So when you have the space reforming in a valgus stress X-ray, naturally that patient is actually one of the ideal patients to undergo a unicompartmental knee. So we took up the challenge and we did a bilateral, I think it's probably the first bilateral ever done in our state, bilateral uni knee in one sitting. And she is fine now, nearly 13 years after that surgery. She is a very happy person and comes to me quite frequently. This is the X-ray which was taken a few months back. Still working fine. So we'll go to some hip cases. This is one of the earliest hip total hip I did. I do accept that the stem may not be the ideal position, but it is still working nearly 18 years down the line. This is another young man with a bilateral secondary OA. We went and did, of course, one hip at a time 2 uncemented hips, doing well. This is an interesting case of a 32-year-old lady. She came with her husband, and incidentally, this was in 2014. She had a surgery during childhood by one of the professors in Trivandrum. I think probably it was a Perthes. She didn't have any of the records of that. She says it was by about 12 years or 13 years of age. So from the X-rays available which we took, I find that the trochanter has been lateralized and the head is deformed and rudimentary. And with this painful hip, I think her husband was more concerned with the hip movement than the lady herself. But still she was also having pain. And she has already been shunted from one surgeon to other because it was a little tricky to do the replacement. So I finally took up the challenge, got one of my colleagues also in, and we discussed. We didn't have 3D printing at that time also. It was not very prevalent. We took the CT scans and discussed. And one of the questions before us was, what should we do with the trochanter? Do we leave it alone? Should we osteotomize and probably bring it down like that? Various options we were thinking. And finally we decided we will decide on the table, and we opened her up and did this surgery. We didn't osteotomize because the trochanter was way away from the track we are going into the femur. Opening the femoral canal was a little difficult because you can see that the upper end is quite sclerotic. We used a few drill bits first to sound that canal, and then got the canal right, and then put this long stem femoral prosthesis. Inadvertently we fractured the lesser trochanter, which after the surgery we used a PDS suture to tie it back so that it may be of bony support. So the X-ray on the left was the immediate post-op. The other one is nearly 12-13 years back. It's well incorporated. She is one of the happiest persons. Sometimes we should take up challenges during our course, but with adequate planning precautions. It will be definitely beneficial for both the surgeon as well as the patient. This is an infected bipolar, and she was just put on some antibiotics off and on, and some discharging sinus. Finally came to me. We did plan for a 2-stage procedure. So the implant was removed and a cemented, antibiotic impregnated cemented prosthesis. We made it on the table for cutting the cost. And after 6 weeks, the parameters came down, blood parameters came down, and we went and did the hip. But again, as you see on the left, in the postoperative period, she developed urinary tract infection because of the catheter. She developed chills, rigor, and the hip dislocated. Maybe it was about 7 days or 10 days after the surgery. So we had to, then probably I realized what went wrong. I thought maybe my acetabular version was not sufficient. And already this was the revision hip, and probably the soft tissues were more relaxed than I thought they were. So anyway, I have to again go in. I cannot wait on the patient or sit on the patient. So we again went in and converted the acetabulum, removed and put a new, what you call as a gription cup with screws, and giving more antiversion. And she is happy. Nearly 10 years down the line, she is very happy. Myself and my family are actually travel bugs. We go in bit once a year, we make it a point. This is one of the one taken during the last SICOT. So this case, again a hip case, a 60-year-old lady in a middle class family. She was actually walking on one limb practically, the right hip, right lower limb. And the left was a post-polio limb. She was using it in a hand to leg gait. And I saw her about 5 years back and told her, you need a hip replacement because of financial constraint. They went to a government hospital. And this was the immediate post-operative X-ray in that hospital. But the patient was having severe pain in the upper thigh in the post-operative period. And the surgeon just gave some analgesics. But later on, since the pain was not subsiding, they took an X-ray probably 2 weeks down the line. And if you notice, you can have, she has a periprosthetic fracture, type 2 periprosthetic fracture on the femur. And the surgeon, without intervening or discussing with anybody, just kept the patient on bed rest. And of course, the fracture healed, but in slight varus, the femur actually subsided. Because it was an uncemented hip, it just sank. And she cannot walk. That was the only limb she was actually walking on. The other was a support. So you have to, she just came and cried, sorry sir, you told us, but we went there. That's okay, it can happen. Mistakes can happen to any surgeon or anybody, but we have to learn from the mistakes and rectify that to move forward. So this is the X-ray which I took when I met her first. You can see the head is almost out of the cup. So we revised her with a long stem, and we were careful not to refracture it. There was a little bit more bowing of the femur, but she is fine now 6 months down the line. This X-ray was taken 2 weeks back, nearly 6 months. It was done in January. So mostly as any of a surgeon, we do hips, knees, primaries and revisions. But once in a while, we do the other joints also if required. Not an expert on that, but we study the case and do such joints also. So before I conclude, I'll have a few more slides. Just as my previous orator was saying, it takes 3 months to learn how to do an operation, 3 years to know when to do it, and 30 years to know when not to do it. This is by one of the famous neurosurgeons. And this statement is very important for the successful hip and knee replacement surgeries. God, give me the serenity to accept the things I cannot change, courage to change the things I can, and wisdom to know the difference. That's very important in life. We have to know what we can do, what is our ability and what is our limitation to move forward in the career. Before concluding, I'd like to pay my respects to my parents who molded me as a human being, and my family who have supported me always. And my advice to the Gen Z, before you do a joint replacement, get trained under a mentor. And when you do independently, at least for the first few cases, get a senior or a friend to guide you. And be perseverant in what you do. Keep a work-life balance. I was thinking while I was sitting there, Professor Krishna Gopal's talk and mine had lot of similarities in the way we approach the career and the life. And never make the same mistake twice. Learning from others' mistakes is always cheaper. That is the advantage of coming and listening to conferences like this. And never, as a youngster, take up such cases. Even I won't take this case into my practice. Thank you very much for the patient listening. Thank you very much.
Yeah, thank you, Professor Ramakrishnan, for your experience and the journey on arthroplasty. Thank you very much. We are enlightened.
We request the organizing team, along with Secretary General Sir, to kindly kindly accompany Sir down the hall.
Thank you, sir.
An honor.
Thank you, sir.
Now I take the privilege of presenting Dr. E. Krishna Kiran, who will be giving his oration on Dr. S.S.K. Marthandan oration.
Before introducing the orator, a brief introduction of the oration. Professor SSK Marthandam oration. Professor S. Subhakumar Marthandam, sir was former Vice Chancellor of Sri Ramachandra University, was a well-known orthopedic surgeon of India. Professor SSKM, as he was popularly known, he obtained his MBBS degree in 1965 from the Madras Medical College. Later he studied Diploma in Orthopedics in Madurai Medical College in 1972 and MS Orthopedics at Madras Medical College, graduating in 1976. Professor SSKM, with his teacher Dr. P.V.A. Mohandas, a renowned orthopedic surgeon, paved the way for revolutionizing certain aspects of orthopedic and trauma surgery in India. Professor S.S. Marthandam sir joined the Madras Medical College and subsequently became Professor of Orthopedics in Government Hospital Royapet. He was the first to perform a total knee replacement surgery in 1980 in a government sector. He was also responsible for evolving new surgical techniques in the management of pelvic injuries, which drastically changed the approach of orthopedic surgeons in the field in our country. At Sri Ramachandra Medical College and Research Institute, way back in 1995, he was responsible for for starting the Accident and Emergency Department, that is the BSc in Emergency and Trauma Care Technology course, the first of its kind in a teaching hospital in India. He was responsible for the creation of skill lab for orthopedic surgery and a cadaver lab at Sri Ramachandra Medical College in 2008, both of them the first in the country. In recognition of his significant contributions, Professor SSKM was elevated to the position of Vice Chancellor of Sri Ramachandra University in 2005. In recognition of his outstanding and lasting contributions made by Professor SSKM to the orthopedic surgery, the Tamil Nadu Dr. MGR Medical University confirmed on him the degree of DSc in November 2009. He was the recipient of the Lifetime Achievement Award by Indian Medical Association in April 2006, and he became the Vice President of Diplomat of National Board in 2010. He occupied many exalted positions in orthopedic associations at the state, national and international levels. Professor had more than 200 papers and 25 publications to his credit, besides authoring Vibhuth Marutvam, a book on trauma care in Tamil. This oration has been created by the grateful faculty, alumni, students of Professor SSKM in recognition of the outstanding and enduring contributions made to him to healthcare innovation, medical education and institution building. Today we have Dr. Krishna Kiran Echampatti to present the SSK Marthandam oration. A brief introduction of Dr. Krishna Kiran. Sir got his MBBS from Gandhi Medical College, Hyderabad in June 1998. MS Orthopedics from All India Institute of Medical Sciences, New Delhi in July 2001. He had a clinical observership in the Department of Orthopedics, Schwarzwald Bar Klinikum in Germany in May 2009. He had an observership in computer-navigated hip arthroplasty at the Golden Jubilee National Hospital, Glasgow, United Kingdom in November 2011. Positions held is a Director of Orthopedics, Medicover Hospitals, Madhapur and Hyderabad from November 2014 till date. He is a Consultant Orthopedic Surgeon, Krishna Institute of Medical Sciences, Hyderabad from June 2009 to 2014. He has more than 81 publications to his credit, and it's very difficult to mention the names of all of them here. He has authored a book. He has chapters in 4 different books. He has delivered guest lectures in over 32 conferences, and he has been a chairperson and moderator in over 27 national and international conferences. Professional and leadership and society positions. Education Chair, Indian Society of Hip and Knee Surgeons. He is presently holding that position. He has a fellowship, Committee Chair, Indian Society of Hip and Knee Surgeons 24-25. He was a Joint Secretary of Indian Orthoplasty Association 2022-24. He was the founding President, Telangana Association of Arthroplasty Surgeons. Postgraduate teaching and academic commitments. Is a DNB orthopedics teacher, Medicover Hospitals, High Tech City, Hyderabad since 2019. Clinical teaching, operative planning, surgical training, seminars, journal clubs, research guidance, dissertation, mentoring, and assessment. He is also a teacher in the FNB Orthoplasty, Medicover Hospitals, High Tech City since 2024. Also, to his credit, he has some charitable works. He has performed from 2022 to 24, sir has performed revision hip arthroplasty for the underprivileged village patients free of cost. Approximately once a month he is visited there as an ongoing charitable surgical commitment, totally free of cost at BIRD Hospital, Tirupati. From 2023 to present, he continues to perform revision hip arthroplasty for underprivileged patients free of cost as a part of an ongoing charitable surgical commitment. And here we have Dr. Krishna Kiran. Thank you, sir. May I ask the President of the Oasis to honor the orator?
Request the orator Dr. Krishna Kiran to give his oration. Dr. SSK Marthandan oration.
Good afternoon, respected President, Chairpersons, and my dear friends. It's indeed a great honor for me to be standing here before this august audience to talk about expanding frontiers in hip and knee arthroplasty, a subject which is very close to my heart, technique, innovation, and a few things I learnt along the way. So this is to honor the great man, Dr. SSK Marthandam, who was an eminent orthopedic surgeon who served as a former Vice Chancellor of Sri Ramchandra University, a prominent university in Chennai, and Chairman and Director of Orthopedic Care Center at Ramchandra Medical Center. At the outset, I'm really grateful for my family, my parents, my children, and my wife for allowing me to pursue my passion. And I'm also really grateful to this man, great man, a teacher to a lot of us, Professor A.S. Rao, who as an undergraduate put inside me the interest in orthopedic surgery. So really bow my head down and remember, sir, for all his zeal, enthusiasm, and encouragement he has given to me all these years. Where it really began, my postgraduate years at AIIMS gave me my first serious exposure to hip and knee arthroplasty. Working around doyens of arthroplasty like Professor Surya Bhan and Dr. Rajesh Malhotra exposed me to early bone banking, reconstruction, research, and writing. And looking back, that environment probably shaped me more than I realized at that time. And it's a great thing for me that these people have remained part of my life right through the training days till date. And these are some of the pictures with Professor Malhotra, who has been a guiding light and a source of constant inspiration for us. We were expected to look at a problem, ask why it happened, read around it, and come back with a better answer. So my early research and publications were important less for the papers themselves than for the habit they created. And if something in practice did not make sense, I was taught to question that particular thing. So we published our data in JBJS American, JBJS British, CORR, we published in Acta Orthopedica, and all these publications were as a postgraduate and a senior resident. So by the time I passed out, I had publications in all the major journals which are present in the modern day as well. The technique I learned from AIMS, it taught me how to operate. It also made me humble to understand when not to operate as well. Research taught me to question the unanswered questions, and patient decided which questions mattered. So this particular talk I have broken down into 5 particular aspects. This is an observation-driven practice from my own experience, and I hope and pray that it will help all the younger orthopedic surgeons sitting here not to be limited by what they see, but have a vision for a greater thing in order to take care of patients. So the first aspect will cover minimally invasive surgery, early discharge, pain-free rehab, and early return to work. The second will be based on CAS and robotics. Third topic again close to my heart, simplifying hip and knee revision surgery. Fourth is innovation, implant design, and finally teaching and giving back. So for me a good X-ray was not enough. So this particular patient, you can see that severe varus deformity which I treated in 2006, and this is an X-ray 20 years later. The patient just recently passed away. But I was increasingly uncomfortable with what patients went through after an otherwise successful operation. So although this patient did very well in the long term, she stayed in the hospital for 2 weeks. She was very unhappy with the pain she went through. She was really complaining for 3 months. And the pain, difficult mobilization, several days in hospital, and a recovery which felt much bigger than the operation itself impacted me greatly. Although I was very happy with what I did, what she gave me through that 2 weeks stayed with me for my life. So we kept changing small things. We started doing quadriceps sparing arthrotomy. We started doing better preoperative optimization. We started periarticular infiltration, intraarticular catheter, and continuous adductor canal block for the first time in the country in 2009. We used a multimodal analgesia protocol, and of late we started using the sodium channel blockade. None of the changes were dramatic. They were all incremental, small changes, and we observed that together they changed the recovery. And this is one of my patients today. Few hours after surgery, you can see how they're able to do a full straight leg raising and bending the knee. So what we did, we identified the roadblocks. We identified very early that pain, swelling, inability to mobilize, motor weakness, urinary retention, uncontrolled sugars, HP drop, lack of help, and outstation patients are probably the limiting factors for them to go back home soon after the surgery. We made efforts to understand the pain pathway, looked at the different modalities where we can intervene and stop the pain. Brain actually doesn't know, it never saw that the surgery happened. It needs some inflammatory mediators to give it that information. But we observed that if we are able to block the inflammatory mediators from getting into the brain in the first place, the brain will not recognize that the surgery ever happened. And some of the patients are really worried why I don't have any pain after surgery. So that is the complaint they have, which is probably a good complaint to have. And we must also evaluate what is the emotional response of this patient. Is this patient going to catastrophize pain, or is this patient going to bear pain? So this is something which you have to evaluate before the surgery. We also recognize surgical timelines. This is extremely important. We looked at preparation of the patient 2 weeks prior to surgery. We looked at the in-hospital care post-surgery, and we realized that the surgery is not 1 hour we spend in the OR, but it is a set of 2,500 to 3,000 hours that the patient has to go through. And if you optimize the patient through these 3,000 hours, hold their hand through these 3,000 hours, then that 1 hour becomes really worthwhile. But if you leave the patient for these 3,000 hours, you've really lost a golden opportunity. So what do? Step 1, optimize the patient. Never rush into a surgery, because this is an elective surgery. We don't need to do the surgery next day. You plan for preemptive analgesia, get your anesthetist on your side. Swelling reduction becomes a primary goal for any operative intervention. If you have an ankle sprain patient, you will not ask them to go and walk for 2,000 steps or 4,000 steps after the ankle sprain. What you will do, you will rest the patient, you will elevate the leg, you will ice this, give it some time to heal, and then put them on a focused rehabilitation program. A TKR is a much bigger insult to the body than an ankle sprain, so it's impossible to ask them to walk without support or start walking immediately after the surgery, unlimited amount of steps, and avoid giving them precautions of leg elevation, icing, compression stockings, and no wonder 7 days, 10 days, 15 days later, they come with a very, very swollen leg, very unhappy, with a lot of pain. Pre-op counseling regarding what they must expect, what will be the milestones at week, 2 weeks, 3 weeks, 6 weeks and 12 weeks must be clearly explained and given it in writing, and this helps them to plan their own life as well. Pre-surgery, you give them these medications, and the use of tranexamic acid and dexamethasone, which are continued for about 24 hours, are extremely important to reduce the bleeding and also to reduce inflammation, and this goes a long way in reducing pain after surgery. Step 3 is intraoperative. We graduated from these long medial parapatellar approaches with patellar reversion to subvastus and now modified mini midvastus approaches where the patella is just taken out of the way. And there is no excuse for not becoming better at surgery. You cannot keep on doing the old-fashioned surgery and expect patients to do well. It is insanity to expect better outcomes doing the same things over and over again. So you have to change something for a better outcome. My personal practice, surgical essentials. We do a quad sparing arthrotomy, we do calibrated soft tissue releases, we do functional alignment or a restricted kinematic protocol with robotics, no medullary canal opening, no drain. I have not put in a single drain in the last 20 years. Intraoperatively for pain management, combine multiple modalities. Don't get stuck to one modality. You do periarticular infiltration, you do an intra-articular epidural catheter in the joint for breakthrough pain, you put them on a continuous adductor canal block which they can take back home. And of late, we've started the pain portal injection for sodium channel blockade, and this helps to tide over the late onset pain after arthroplasty. And we diligently documented all our data, and we have at least 10 different publications on our own modalities and how efficient they were in managing pain after total knee arthroplasty. Fourth step, optimization of the patient after the surgery. Always tell them that you need to reduce your swelling. This is the number of step counts you need to do. This is what you must expect. Use your compression stockings. Keep the leg elevated. Put ice and give medications. Do not forget about the anti-inflammatory high protein diet which the patients need to be put in the perioperative period. And we have now done away with any sort of physiotherapy. It's just a video based physio. So that there's no physiotherapist going home for the patient. And eventually several days in hospital became about 24 hours in our practice. 80% of the patient go home within 24 hours of surgery, and for me that is as meaningful as improving an X-ray. And you can see how the patients are doing their own physiotherapy, how there is no extension lag right from the hospital, from 2 weeks, from 6 weeks follow-up, and you can see the range of motion which they are achieving without physiotherapy, and this is the reciprocal ambulation after a bilateral partial knee replacement. So there have been many success stories, and the same question took me to the hip as well. Patients have a hip replacement because they want their life back. I found it increasingly difficult to reconcile that with giving them a long list of precautions and restrictions afterwards, and that was one of the reasons I began my direct anterior hip journey. A new hip should give a patient more freedom, not a new set of fears, and we should get away from the dogma of criticizing things without even actually using them. And I think robotics with direct anterior approach is a game changer in hip arthroplasty. But we did not arrive at this overnight. So it's a journey to remember. It started about 15 years back when I met this man Hari Bezwada in Delhi, and you can see my colleague and best friend Sunil here in the picture as well, and he introduced us to this concept of direct anterior approach as a total for surgery. But this was not new to us. As a trainee at AIIMS and as a senior resident, we did a whole bunch of 2-incision MIS surgeries, and we really failed at it because there were 50 cases and we had a lot of trouble because there was not adequate training. We didn't understand what to do. But one thing which we were able to successfully do was in these patients with external rotation deformity and ankylosing spondylitis, where it was grotesque to position them in the lateral position, and also the sciatic nerve was very close to the greater trochanter because of the external rotation deformity. We started doing a neck osteotomy from the direct anterior approach. Then we would flip the patient and do the surgery from the posterior approach. And we published our work, which is the largest series on cementless total hip arthroplasty for bony ankylosis in patients with ankylosing spondylitis in 2008. And this continues to be the largest series till date. In 2012, Dr. Srinivas Kasha, my colleague from KIMS, gave me this very difficult problem, very complex problem. Patient had a hip inflection, abduction and external rotation. We were not really trained to do direct anterior approach, but there was only one way of dealing with this problem from the front. So we did an extended Smith-Peterson approach, two of us together. It took us 4 hours to do one hip and 4 hours to do the other hip. And this is a patient who had a complication. So she developed vascular injury on one side because we didn't know where to position the retractor. That vascular injury required repair, and the patient thankfully did well. Left side got infected after 4 years, for which we had to take everything out and do a tumor replacement process in a young patient. And you can see this is the 2024 X-ray, and I heard from him that she's still doing well. Although this patient had a reasonably good outcome and a favorable outcome, it again put a lot of questions in my head as to whether I am attempting these cases safely or I need to train more. And this is what I did. I trained with Dr. Christoph Cotton in a cadaveric training course in Bangkok, and further spoke for a long period of time, almost 4 years, with my friend Neil Shath in UPenn, who was using the table direct anterior approach. And today 80% of my hip practice is direct anterior approach. And you look at a patient few hours after arthroplasty of the hip, walking without support there. Although we didn't advise it, I went for rounds. I couldn't find the patient. The patient was so comfortable, he was walking around in the corridor. This is a patient at 2 weeks. I saw one patient 5 days later at a traffic signal waving to me, driving his own car. So this is something which helped me keep at direct anterior approach, and that has been my direct anterior hip journey. The third aspect of this particular oration is technology. So I was always fascinated by tech. Computer-assisted surgery appealed to the part of me that wanted to know exactly what I was doing rather than assume it. So that journey took me through CAS, knee, hip, and partial knee surgery, and eventually it graduated into robotic knee and hip surgery. It took 6 years for our vision to be validated by this paper from the Australian registry, which said that computer-navigated surgery for total knee arthroplasty reduced revision rates for patients less than 65 years. This was in 2015, we were doing from 2009. And we published our data on advances in computer-aided technology for total knee arthroplasty in orthopedics. So these two people were the ones who trained me in computer-assisted surgery. This was Professor Frederick Thielemann, who was a legendary surgeon from Villingen-Schwenningen area, Germany. And this is my friend Kamaldeep, who unfortunately is no more. He was from Golden Jubilee Hospital, Glasgow. He was an excellent visionary, excellent surgeon, and he was always ahead of his times. Unfortunately, we lost him last year. So with Kamal, we did a study, Sunil, myself and Kamal did a study on the dynamic nature of alignment and variation in normal knees. We found that the knee alignment was not a static phenomenon, but it changed with ambulation. So as you put leg in a bipedal stance or a unipedal stance, the alignment keeps changing. So that probably is one of the reasons why getting a 0-0-0 may not be required, and even if you get it, it may not be what we call as later on continued, because this particular thing will keep on changing with weight bearing. We published our work on dynamic patterns of varus deformity. We found that sometimes patients can have varus in extension, but this may become a valgus inflection. Sometimes it may be varus which may increase with flexion, sometimes it may decrease. We also looked at the state of the posterior medial condyle with the severity of deformity and found that 30% of the patients with severe varus deformity have this posterior medial condylar hypertrophy into the tibial thing, and we quantified this and published our work. The transition into robotics was seamless for me. I started with Navio and Cori in 2019. I've used all the robots on the market, and currently I use Mako as my go-to robot. The robot can tell me where I am, but it still needs me to decide where I want to go. So there is a lot of work which is going on, a lot of criticism for robotics that it is marketed and it is to directly solicit patients or something like that. But my take is different. If you buy a very fancy car or if you have an aeroplane which is state of the art, will that make you a driver or a pilot? Not. So the robot must be used as an intelligent assistant to help us determine where to go, and it must not be used as a primary surgeon for the surgery. So it allows and helps the surgeon execute the surgery only as good as the surgeon is. So it cannot make a bad surgeon into a good one, but a good surgeon will become an extraordinary surgeon with the use of a robot. The numbers created another problem in my head. So how to reproduce and reproducibly interpret them. So the robotic surgery can be overwhelming. You have a lot of data which is real time, which is dynamic, which is constantly coming in, and it gives us an extraordinary amount of information. The challenge is not obtaining the numbers, it is deciding which numbers matter for the person on the table. and the thinking shaped my work with extended restricted kinematic alignment, robotic UKR with kinematic alignment strategies, and robotic DAA TKR. The biggest advantage of robotic surgery is you first assess the situation, you plan for the individual patient, and then execute without error. With a manual surgery, you make the execution first, then assess what is happening, and then you have to plan. So in this situation, we are able to plan our soft tissue balancing by making minor adjustments into the bone cuts and also the resection depth, and this is perfectly well executable and good for the patient. So this is the work which we published on the grading of medial compartment tightness and the extended restricted kinematic alignment, which is our own alignment strategy for varus knees during image-free robotic TKR, and this is what we have published. What it has helped us achieve? It has helped us tackle the complex cases with simple solutions. So you have a very severe varus deformity. Today we know we don't need a PS or a constrained implant. In this case, I can make slight adjustments, get away with a cruciate retaining 9mm poly. If you have a severe valgus knee, same thing. If the MCL is competent, I don't need any constraint. I will get away with a CR. If you have an extra-articular deformity, again I will do a cruciate retaining, less conservative, highly conservative revision, primary procedure for that patient. Without technology, this unfortunately would not be possible. So we published our work with robotics as well about the predictability of implant sizes, how to calibrate rotation in an image-free robotics, and of course I had complication of thrombosed persistent median artery, and I was subject of this case report in JBJS, a 47-year-old orthopedic surgeon with a persistent wrist pain because of the use of burr-based robotics. Finally, there are cases that stay with you, and in 2013 a revision hip of mine failed. I remember the case not because it was unusual to see a failure, but I could not make peace with why the reconstruction had failed, and it did not fail once, it failed multiple times. And when you revise your own work, the X-ray looks much more different, and you can't have sleep, you have sleepless nights because of the failure. So we determined and detected this particular aspect for the first time in India, and we labeled this as abduction failure of the socket. It was in the West, and I took the help of my friend. This was a revision of the first case, and you can see that gradually the cup starts walking out because there is no inferior fixation. I kept coming back to one question: where is the bone I can actually trust? And in the last 10 years, this has been the focus of all my work in revision arthroplasty. The question became inferior fixation. So the idea did not arrive as an implant design. It started as a way of thinking about fixation in major acetabular bone loss, then became a technique, then a series of cases, and then something we kept refining, and eventually we've come out with an implant which will address this particular issue. For the first, we published the technique of how to do the superior pubic ramus screw placement in the video journal of JBJS Essential Surgical Techniques. Why the inferior fixation? Because there is a pattern which we observed to failures. This was a case which we saw from some other unit. You can see a reasonably well done reconstruction, and the same outcome, the cup flies out in the face, and abduction failures happen very often whenever there is no superior dome. So we set out to identify how to safely expose this hip to avoid instability. We saw one of the cases had instability in the past. So we looked at this anatomic mapping of inferior branch of superior gluteal nerve and found that the Gibson approach was probably superior to a posterior approach if you want to safely do the surgery. And we also published our work as a video on revision of total hip arthroplasty with retention of the femoral component, as you would see in a lot of the cases where you have to mobilize the femoral component. So we published our series of sequential stepwise soft tissue releases. We identified situations, high risk situations with bone loss superiorly, and these cases are the ones which require augments and inferior fixation. And if you are dealing with complex cases like a pelvic discontinuity, again these cases are the ones which will require augments, cup with ability for inferior fixation. We recognize that the acetabulum work like a keystone, and the connection between anterior and posterior columns is the keystone here, and unless you restore it through the presence of an augment, bone graft, or some sort of a situation, this reconstruction is likely to fail. So the first step in a revision procedure, reconstruct the keystone, put in a hemispherical cup, put in peripheral fixation. Therein lie the challenge. The pubis and ischium are very peripherally located, and even though you want to engage these areas, using the standard cups you will not be able to engage them because the multi-hole cups have screw holes which are much more interior, and we need a cup with peripheral screws. And you have this T-Mars which is available from Zimmer, but in this the surgery becomes messy because you have to drill that screw hole yourself on table. Where is the proof of concept for what I am talking about? This is a long-term success of the case which I showed you, which made me think about this particular concept in the first place. And this is the same patient with inferior fixation, and this is a 11-year X-ray of the same patient where the outcome has been successful. I have subsequently revised her right hip and done both her knees, and these patients are very good friends. How did I understand this? I understood the function of augment, whether I was using it for primary stability, whether I was using it for supplemental fixation, and where do I need custom augments. So this is a case which we did, a 3-year defect. You can see I put in an augment first to reduce the size of the cup, then I put in a T-Mars cup with inferior fixation, and then I put in a supplemental fixation augment for stability, and you can see how this particular entire construct is unitized and the liner cemented in correct inclination and version. And we have published our work on the use of augments and discontinuity for the first time from India. This is a paper which has come out, in fact, it's the first time from Asia which has come out on the role of distraction technique of in managing chronic pelvic discontinuity. This particular case again made me think. You can see this, we had a successful outcome of this discontinuity, but you can see how big the screws were. So 6.5 mm screws were too big for Indian patients. So we had gaps to address, and I reached out to Merrill, and thankfully they agreed. We had to leverage the accepted principles of inferior and hybrid fixation, make it simple for all the surgeons who are attempting revisions, make cup positioning, location of the screw holes reproducible, and reference it of Indian anatomy and dimensions, and make it affordable for all the patients undergoing revision surgery. So we did a study with a CT scan based study from 2 centers to identify the location, dimension, and the angle of the screw position for pubic ramus and ischium. And this is the 3D model which we created with the screw holes which were positioned exactly where the pubic ramus and ischium are. So if you are a surgeon who wants inferior fixation, this is an easy cup to do. Put the cup in correct inclination and position, and default the screws will go into the pubic ramus and ischium. What does this solve? It solves the problem of inferior fixation. There is no need for intraoperative imaging. There is no need to change the cup inclination and version. We have 5 mm variable angle locking screws, and this accommodates the small pubic ramus diameter in Indian patients. We have option for both hybrid and uncemented fixation, and you can address complex primary, 3A, 3B, and discontinuity. Again, where is the proof? Case, 80-year-old man with a associated both column fracture. We did a primary fixation with cup, made him walk day 1, and you can see the fracture integrating in 3 months time using the principle. So any proof of principle is the outcome of the principle. So if the outcome is not good, whatever I say you should not trust. Another case, you can see a intrapelvic protrusion of a bipolar. We have n number of cases, but I did not put all the cases up. But we have done about 21 cases now, and in each case the cup screw goes in very reliably, and the outcome has been fantastic. And it was a proud moment for me when my mentor Dr. Rajesh Malhotra launched this cup on 15th August 2026, and I'm pleased about the implant, but what matters most to me is that the journey began 13 years ago with a patient whose result was not good enough. And this was launched along with Dr. Vijay Bose's Halo Stem last week. Some of my best ideas have come from the cases I would rather have got right the first time. And this is a case which I keep going back to, looking at the X-ray when I become more arrogant or proud of myself. So this was a case I operated in 2007. The patient had a dislocation at 3 months because the physiotherapist thought her range of motion was not good enough. He flexed it beyond 90. We tried n number of techniques. We could never put it back in. She sustained a periprosthetic fracture, came back, I fixed it. She refused further surgery because she was having some girdle stone in the past from 1992. In 2024, she came back to me with femoral component loosening and pain, and she said, do something for this. And this is where I got this concept. I spoke to the Jajal guys and I designed this cup, which is a cup with an augment. So you have a separate augment and a separate cup, which is a customized augment and a customized cup to address this particular problem. You can see there is absolutely no bone there, no walls. So we thought putting it in a triflange would be more difficult because it's very difficult to introduce that. So we decided to de-link this construct by putting an augment and a cup, and now this particular design is well accepted and used across revision arthroplasty fraternity in our country. And this is the proof of concept again. You can see the intraoperative picture where you have used the custom augmented cup and unitized everything. And you can see the 1.5 year follow-up of the same patient who is doing well with this reconstruction. This is another example, 6 previous surgeries, not walking for 6 years, and we did the same thing, custom cup, custom augment, and then the patient did well. For the revision knee, again I had this thing in my mind, the available implants are very, very difficult to put in our population. So we did a CT based study and designed these fillers, cones and sleeves for our population, and this is widely used from Biorad as the Evocon, Rotocon revision knee system which I have designed, and we have used it to take care of some of our complex revision cases as well over the last 4 or 5 years. And you can see this case with a significant bone loss following osteolysis. You can see the extent of bone loss, and this is the reconstruction, and this is the follow-up of the patient, showing that with a proper thought process we can convert a complex primary into something like a revision with good outcomes even in these complex cases. Another example of a very severe defect which needed all my skill and expertise, we did a tibial tubercle transfer, gastrocnemius flap, and it was very gratifying that this patient at 5 years was able to walk and do his activities of daily living. And this is what surgeons live for. Success is useful, failure is useful too. Success gives us the confidence to take on harder problems. Failures makes us go back, look again, and ask whether we were as clever as we thought. I have needed both in my life, and the chase for excellence has a cost. I lost my health, and then I regained my health because I realized for a long time it is easy to say yes to everything. Another case, another meeting, another paper, another new technique. Over time, I've learned excellence is not the same as being available for everything. You have to decide what deserves your time. And you do things which make you happy irrespective of agenda and compensation, and that keeps you connected with your friends, keeps you happy, keeps you younger, and you can pursue all your things which you have never pursued in your life. Not everything important in life happens in an operating room. Family, health, friends, time away from work, these are easy to postpone because the next operation always feels urgent. I'm still learning the balance. I suspect most surgeons in this room are, but I think the sooner you arrive at this balance, greater it will be. There is no perfect balance, only priorities we keep revisiting. There is enough success to go around, but you need colleagues. I had excellent colleagues to keep me grounded, excellent friends who have been there with me for the last 30-35 years. Some of them are here in this August audience as well, and they keep me highly grounded, humble, and to the ground. Medicine can make us unnecessarily competitive. One of the things I enjoy more now is seeing a colleague do something well or watching a trainee become better than I was at the same stage. Someone else doing well does not make our own journey any smaller. From being taught to teaching, I began this journey surrounded by teachers who gave me opportunities, expected me to think, and I had colleagues who had more belief in my ability than sometimes I myself had. Today, teaching DNB, FNB trainees, some of my own trainees are now heading units in different units, and it makes me immensely proud, and that our legacy is not a technique or an implant, it is what the next surgeon does when we are not in the room. What I would tell my younger self, keep chasing excellence, but don't confuse it with recognition. Stay curious, especially when you think you already know the answer. Be genuinely happy with when other people succeed. Let success give you confidence and failure give you humility, and protect the parts of your life that have got nothing to do with orthopedics. I once thought expanding frontiers meant doing more difficult surgery. Now I think the more difficult frontier is continuing to grow without losing perspective, chasing excellence in patient care, creating real legacy through training and innovation, and not forgetting your priorities at home, your responsibilities with your friends, and to your own self to take care of your body and mind. So dear friends, keep moving the frontier in technique, in thinking, and hopefully you find yourselves. God bless. Thank you very much.
Excellent. Excellent, Kiran. Good, your journey of expanding frontiers, both in the hip and knee arthroplasty. Thank you very much. Thank you.
We thank Kiran for the excellent perspective. It's been the same for the last 20 years since we saw him. It's been an inspiration for us too. Thank you, Sunil. I request This ends the great scientific orations at this Oasiscon. Now we go ahead with the PG quiz in Hall A. We want the organizing team and Dr. Ramkumar Reddy sir, President Tosa, to felicitate the present Oasis President Dr. VCR sir and Secretary General. While this is going on, we will be playing the video of role of PRP by Dr. Sudhir Reddy. Unfortunately, he could not join us. Once this is over, we will have ortho PG quiz in this hall, while interested people can go into Hall B, where we will be having young arthritic knee followed by giant cell tumor of bone. So all interested can go there.
Jagan sir has been missing during this.
Small request from the organizing team. We have just misplaced the badge of Dr. Jagan Mohan in the hall. Request anyone, if you find that, kindly get it to us. The image is shared on the screen. Anyone, anywhere, if you find this particular badge, which is projected on the screen. Yeah, thank you, VCR sir. We got that. If Jagan sir is going to do something else, only we are going to give this badge in the evening, not now. It is promise. If you promise, only we are going to give, sir. Yeah. Done? Done.
Promised. Interesting session while orthopedics is going on. Consultants.
Hall A, we will have ortho PG quiz. This particular thing is going to be presented by Sriwant. Resource person is Mr. Srikant. Reporter is Sridhar. While this is going on, I request the team to switch on the role of PRP by Dr. Sudhir Reddy.
Plasma and stem cell use in osteoarthritis of the knee, in particular focus on evidence. And good morning, everyone. It's an honor to speak at Tosa Oasiscon, but due to some urgent, unavoidable commitment, I was unable to come here today, and I'm thankful for the organizers to allow me to do this, and I hope you won't mind it. So my topic today is platelet-rich plasma and stem cell use in osteoarthritis of the knee, in particular focus on evidence and regulations. I have to admit, I was a great fan of regenerative medicine, and I was very passionate about it. In 2007, when I was a consultant in the United Kingdom, I decided to go back to India. So 8 months before going back to India, I resigned my job and spent my time in regenerative medicine. I spent my time in labs, growing chondrocytes, doing AC autologous chondrocyte implantation. I visited many companies in Europe working in ACI and Messi. I was one of the third member in Indian International Cartilage Research Society from India at that time. I used to interact with Lars Peterson, who is considered as the father of autologous chondrocyte implantation. I even worked with a company called Tygenix and tried to bring it to India. We came here, we're trying to establish in Genome Valley because Tygenix at that time was the only company which conducted the clinical trials and was the only company which was expected to get approval for ACI as a drug and withstand European regulations. But then for most of these companies, the trials didn't work out. The enthusiasm died down and the slowly reality started sinking in and most of them closed down. T-Tech closed down, Tygenix closed down, we lost a lot of money. So for me also the reality struck. So I was very passionate, but I realized that passion alone isn't going to be enough, especially when it is someone else's body under the knife there and someone else's the money. So you have to back up your passion with scientific evidence and you have to play within regulations. So let's look at platelet-rich plasma for osteoarthritis of the knee. So I always wondered how this works because these platelets are already there in your body, in your entire, and they have the ability to go wherever they want. If there's an injury, bleeding, the body directs the platelets to go there. They all accumulate there. They all secrete growth factors, attract other cells, and form a clot. So wherever there's an injury, they reach there. That is how the body developed over billions of years. It's a natural mechanism. Why does it need somebody to come and take 10 ml of blood from your arm here and then put it in the knee without doing anything? You're just centrifuging and removing some red blood cells and putting that remaining into the knee. How is it expected to work? I wasn't really convinced. So logically to me it didn't stand the trial. So we'll look at the evidence. If you ask anyone what is the best single trial, most rigorous trial that looked at the true evidence of a PRP versus placebo, they have to admit, even the ardent supporters of PRP have to admit, there's a RESTORE trial that is published in JAMA in 2021. This was a large trial with 288 patients. It was a randomized controlled, two-armed control trial with a triple-blind control trial. So the results of that are very revealing. The pain change at 12 months is no significant benefit. The medial tibial cartilage volume loss, again, absolutely no benefit. In fact, PRP seem to have lost a little bit more cartilage than placebo in that. And the other trial, which most of the supporters of PRP quote, is a 2025 meta-analysis of 11 RCTs. Even that trial shows that there is an advantage of PRP over placebo in terms of pain up to 3 months, and then some evidence up to 3 months, by 6 months. But by about 12 months, all the evidence fades, all the advantage fades away, and it is no better than placebo. So as the rigor goes up, the support goes down. The best single RCT RESTORE is negative. Full meta-analysis shows that it is a weak, fading effect, and the umbrella review says it's a very uncertain evidence or effect. So this is same results in a glance. And these are the recommendations of various professional organizations that are involved in treating osteoarthritis of the knee. Most of them are either not recommended or a weak grudging acceptance because there's some benefit of doubt. They're not clear, so they say, okay, you may use it. If there is a conservative management has failed in mild to moderate, you can use it. So the takeaway is the same. So let's look at the regulatory landscape. PRP genuinely falls in the regulatory gap in Indian scenario. There is no law that governs PRP. There are several laws that govern, several aspects like the law that governs the cell therapies is ICMR stem cell guidelines. It specifically says PRP is not governed by it. PRP is outside it because it's not a cell therapy. So drugs and cosmetics, PRP is not a drug, it's not a device, it's not stored, so it's not blood bank. The only thing that governs is NMC Professional Code of Conduct, which governs the clinical use which governs the doctors about the clinical use of this. So, if you are going to use it in routine, you should be governed by NMC Professional Conduct Regulations, and you should take an informed consent by disclosing the mixed evidence. So, then let's look at stem cell therapy for knee osteoarthritis. So here, the evidence is much more clearer and the regulations are also much more clearer. So if we look at evidence hierarchy, the Cochrane Living Systematic Review, it says benefits are small and uncertain, whereas great meta-analysis of RCT shows that it has little or no meaningful pain relief. And the level 1 RCT systematic review again says they are not superior to placebo. So all of these, poor evidence, may not be real. So none of them really support. So this is a Cochrane Living Systematic Review. This is the highest tier of clinical evidence, continuously updated every 3 months. It's a low evidence of any benefit. And systematic review says of RCTs, MSC injection are not better than placebo injections. So, and whatever little benefit that comes also is probably the benefit because of placebo, not because of the stem cells themselves. This is a summary of the same thing. These are the references. Let's look at the Indian regulations. So there are 3 frameworks. This national guidelines for stem cell research cover the research aspect of it. The drugs cover the product aspect of it. Like, some companies produce a product after stem cells, like Unistem, of Stempeutics, and they have to go through these stringent rules. Whereas the clinical use is governed by ICMR clinical evidence policy. So when used in research, it is permissible in basic and preclinical research in evidence-backed therapies like bone marrow transplantation only. In knee osteoarthritis, even if you want to use it as research, it has to be approved and registered clinical trials with ethical review and informed consent. You cannot use it in clinics. So the only approved stem cell therapy in India is bone marrow transplantation, and every other stem cell application, including all approaches to knee osteoarthritis, remain outside routine approved clinical practice and is
This particular session, PG quiz, has 6 teams with 2 each. This would be, the quiz master would be Srikanth. About 110 questions would be posed. Request the members not to give any cross questions at the time. If any, they would be answered by the quiz master, Dr. Srivant, at the end. The way to sit in this particular 12 is through a lucky draw. We don't know which team would join each other. So request Srikanth to do the
The quiz is about to start. Please come.
Yeah. Request all the students, one by one, would come, pick up the chit, so that you would get your team. Man, 1, 3, 5. Next. Show it to Srikanth, not you. हाँ.
ఆన్సర్ చెప్పాలా?
Mics will be provided to all of you, where that you only one would speak. Two, though you are in a team, you discuss, but one would present the answer. Only one. Exciting thing to see. Yeah, timer will come for you, so watch out. Best wishes to all the contestants. I would like Srikanth to take over. Srikanth, sorry.
Yeah.
Project the instructions.
Good afternoon,
first.
everyone. I'm Dr. Srivanth, working as an assistant professor at KMC Warangal. Today we are conducting the prestigious Oasiscon Tosa 2026 PG quiz. This quiz consists of total number of questions 103. Each question carries 1 mark. Each team gets 17 questions and 4 rounds. Okay, first round is pass on round, which contains 24 questions, 25 seconds each, 20 to 25 seconds. Second round is direct round, is 24 questions, and we have increased the time to 25 seconds. And third round is pass on round, which contains again 24 questions, which contains 25 seconds each. And fourth round is rapid response round, where we are having 30 questions, and each team will get 5 questions for a period of 1 minute. Keep your mobile phones in silent mode. Only one of the team members should answer. If unanswered question by the team members, it will go to the audience. Interruptions by the quiz program is not entertained, and the quiz master's decision is final. Did all the members get the mic? Did everyone get the mic? You got the mic? The one more mic, please.
You have to introduce briefly about the team members.
Okay. Introductions. Kindly introduce yourself.
I am Dr. Kadir Tirmurthy, and this is my partner Dr. Bhavish. We are from Tejaswini Hospital and SSIOT from Mangalore, Karnataka.
Hello, I am Dr. Jyotirmay, and my partner is Dr. Gautam. We are from KMC Warangal.
Hello, I am Dr. Nitish Lakshman, and here with me is Dr. Akshit Kandelwal. We are both postgraduates from Kasturba Medical College, Mangalore.
I'm Dr. Gyaneshwari, and my partner is Dr. Sai Prasanna. We are from Kakatiya Medical College, Warangal.
Good afternoon, everyone. I'm Dr. Uzma Khan, and my teammate is Dr. Ubaidul from Osmania Medical College, Hyderabad.
Good afternoon, everyone. Myself, Dr. Uday Gupta. My partner is Dr. Krishna Kumar. We are from KMC Warangal.
We are going ahead with the quiz. Now this is the mock questions. This is how the question will be displayed. You have to choose the option and followed which you will find a slide with the answer. This is a mock round. Question 2. Okay, mock round. Question 3. Either you have to choose true or false. Question 4. Do any one of you have any doubts? Yeah, I'll tell you. Yeah. In pass on round, we are going to start with questions where one team, it will start with team A. Team A, the question will be started, question to you. If you are not answering, it should be passed on to question, team B. And if you are not answering, team C, D, E and F. If any one of you are not answering the question, it will be passed on to the audience. Okay? No negative marking.
What audience are going to get?
Yes, what audience are going to get then?
Chocolate.
Yeah, thank you. Sweet.
Yeah. See, if suppose if team A it gives you a wrong answer, automatically the question will be passed on to the team B. Okay, and the second question will start from team B again. Okay, and the third question will start from team C, team D, next team E, team F. Okay, so we are starting now, and all the best to all the postgraduates who are participating. Okay.
Course, every half of the session, quarter session.
For each round, we are displaying the scores, sir.
Yes, that is.
Yes.
Fantastic.
We are making a note of scores.
Expect transparency here from the
Yes, sir.
team.
Each team will be given scores at the end of this round. Okay.
So,
Starting now. Question to team A.
Option B, combination of white blood cell scan and a technetium bone scan.
Correct. Coming to team B, next question.
Option B, it results from the traction on the extended.
Wrong answer. Next, team C. Huh? They didn't say pass on. They have made it wrong. Passing means it will pass on. Okay. Third question. Team C.
Answer 2, central 1/3.
Posterior horn is the answer. Team D now. Correct answer. Next, coming to team E.
Option 4, sir.
Correct answer. Next, team F. Time is up.
Option D.
Wrong answer. Okay. Coming to team A.
Tight, option 4, tight medial collateral ligament.
Wrong answer. Coming to team B.
Option 4.
Correct answer. Coming to team C.
Answer 3.
Wrong answer. Team D. Please answer team D. Right answer. Team E, kindly answer this question.
Option 1, sir.
Wrong answer. Coming to team F, next question. Team F, please answer.
2.
Correct answer. Team A.
Option 2, osteonecrosis.
Correct answer, team A. Coming to team B. Please be faster. Team B.
Option 2.
Wrong answer. Coming to team C. Time is up. Please.
In 4, sir.
Wrong answer. Team D. Correct answer. Team E.
Option D.
Answer please.
D.
Pardon?
D. Option D.
D. Correct answer. Team E. Team F.
B.
Option?
B. Second.
Wrong answer. Team F. Coming to Team A again. Team A.
Option A, adductor magnus.
Right answer, Team A. Coming to Team B.
Option 3.
Right answer. Team C.
Option D.
Wrong answer. Coming to Team D.
Option A.
Right answer, Team D. Now coming to Team E. Start the timer.
Option B. Second one.
Pardon me? Team E. What is the answer?
Option B, sir, second one.
Right answer, Team E. Team F.
1.
Wrong answer, team F. End of round 1. Scores, please.
Team A got 3 marks, Team B 2 points, Team C 0, Team D 4 marks, Team E 3 points, Team F 1.
Team D is leading now after first round.
Team D is leading with 4 marks, next by Team A and E.
Coming to the second round. This is direct questions. So team A will be given few questions. They have to answer all the questions. Okay? Then followed by team B, then team C, D, E, F. Okay? Team A. Start the timer.
Option B, Lisfranc ligament avulsion.
Right answer.
Option C.
Right answer. Time up.
Option A.
Wrong answer.
Option 4, asymmetrical physeal growth.
Correct answer. Coming to team B. Now you have all the direct questions.
Option C.
Right option.
Diabetes.
What is the option?
Option E, sir.
Wrong answer.
Option 4.
Wrong answer. Time up.
Fourth.
Wrong answer. Team C. Now you are given direct questions.
Option B. Option B.
Right answer?
Option A.
Wrong answer? Can anyone of the audience answer what is TCPO2? Okay, next question.
B.
Right answer?
In E.
Option?
E.
Wrong answer? Coming to team D. Direct questions.
Option 2.
Option? Wrong answer?
Option A.
Right answer?
Option E.
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 Huh?
Option E.
Wrong answer? Time up. Group D. Time up. Okay. Right answer is Panner's disease, 0. Now coming to group team E. Direct questions to you, team E. HOE is heterotopic ossificants.
D, sir.
Pardon me?
D, fourth one.
Stiffness.
Yes.
Wrong answer?
Option D, sir. Fourth one.
Wrong answer?
5.
Right answer?
E. E.
Right answer? Coming to team F, direct questions.
B.
Pardon me?
B.
B.
B second.
Okay, right answer?
C.
Right answer? Time up, team. Huh?
B. Second.
Wrong answer?
One.
Wrong answer? End of second round. Scores please.
By the end of second round, Team A is in leading position. Their score is 6 marks. And Team D in second position, score is 5 marks. And Team E in third position, score is 5 marks. And B team 3 marks, C team 2 marks, and Team F 3 marks.
Now coming to the third round, which contains pass on round. If you don't know the answer, please pass on. This again consists of 24 questions. Each team will get 4 questions. Team A, timer please. Timer please. Time up.
Option 2, resection of dysplastic region of tibia, insertion of a vascularized fibula.
Wrong answer. Team B. Time up.
Option 4. Option 4.
Wrong answer. Team C.
Option 2.
Right answer. Team D.
Option 3.
Option?
3.
Wrong answer. Coming to team D. E.
Three, sir.
Pardon me?
3.
Right answer. Team F. Next question.
Five. Fifth.
Wrong answer. Team A.
Option 4.
Which option?
4.
Right answer. Coming to team B.
Option 4.
Wrong answer. Team C.
Option 1.
Wrong answer. Team D.
Option 3.
Pardon?
Option 3.
Wrong answer. Team E.
First one, sir.
First option.
First option.
Right answer. Team F.
One. First.
Wrong answer. Team A.
Option 1.
Wrong answer. Team B.
Option 3.
3. Wrong answer. C. Team C.
Option 1.
Option 1. Wrong answer. Team D.
Circumferentially. Option 2.
Option?
Option 2.
Right answer. Team F, sorry, Team E. Next question.
Option 3, sir.
Option?
3.
Right answer. Next, coming to Team F.
Fourth.
Right answer. Coming to Team A. Time up.
Amount of heel varus. Option 5.
Wrong answer. Team B.
Option 4.
Right answer. Team C.
Option 2.
2. Wrong answer. Coming to Team D. Wrong answer. Team E.
Option 4, sir.
Team E, what is the answer?
4.
4. Wrong answer. Coming to Team F. Start the timer. Start the timer, please. Already extra 5 seconds have been given to Team F.
3. Third one.
Right answer. End of third round. Scores, please.
By the end of third round, Team A got 7 points, Team B 4 points, Team C 3 points, Team D 6 points, Team E 8 points, and Team F 5 points. The leading are Team E followed by Team A.
We are entering the fourth round, which is a rapid response. This round consists of questions will be posed to each team. So they have to answer all the questions in 1 minute. Okay? Team wise.
Sir, one doubt.
Yes.
Regarding that, can we pass questions and come back to that, or?
No, you cannot come back.
Okay.
You have to answer all the questions within 1 minute.
This is direct question.
Direct questions. Rapid response.
Sir, like if imagine we don't want to answer the second question at that point, can we go to third and come back to the second?
No, you cannot do it like a question paper. You have to answer that point itself. Rapid fire or rapid response round. Team A. This consists of 5 questions per each. We'll start. Start the timer. If you delay for one question, the next question will be dropped. So be faster.
Option 5.
Right answer?
Shoulder internal rotation. Option 3.
Wrong answer?
Option 3.
3.
Option 1, sir.
You cannot change the answers like that. Wrong answer? Time up.
Option 3.
Wrong answer? So, Team A has finished 1 minute. So, this question will be going to Team B, or else we'll go to directly Team B. Yeah. Team B, start.
Option A.
A.
Option 1.
Wrong answer?
Option 2.
Wrong answer?
Option 3.
3. Wrong answer. Time up. Team C, start.
Osteonecrosis, 1.
Wrong answer.
Option 3.
3. Wrong answer.
Option 5.
5. Wrong answer.
Option 1.
1. Wrong answer. Time up. Coming to group D.
Option 1.
Wrong answer.
Option 4.
4.
Option 4.
Wrong answer.
Option 1.
1.
1.
Right answer.
Option 4.
4. Wrong answer. Time up. Group D. Now coming to team E. Start.
Four.
Coronoid process. Huh?
Yes, sir.
Wrong answer.
Three.
3.
3.
Right answer.
Four.
Time up. Pardon?
Four.
4. Wrong answer. Coming to team F. Start. See the image over there.
Slap region, E, slap tier.
Wrong answer.
D.
Pardon?
Option D, 4.
Wrong option.
Option B, second.
Wrong. Wrong answer.
Option B.
B.
Yes.
Wrong answer. End of fourth round. Scores, please.
By the end of fourth round, Team C got 3 marks, Team B got 4 marks, and Team F got 5 marks, and Team D got 7 marks. Team A are the second runner-ups, they got 8 marks, and Team E are the winners of the quiz, got 9 marks from Osmania Medical College.
The winner of TOSACon Oasiscon 2026 held at Warangal. The winners are Osmania Medical College Group E with total 9 marks. The first runner-up goes to Tejaswini Hospital, Team A with 8 marks. And second runner-up goes to KMC Warangal, Team D with 7 marks. Congratulations to the winners. We'll take a photograph. Yeah. Thank you everyone. Please wait. Srinivas Reddy sir kuda ippare.
All quiz participants can have photo with the TOSA president. Good afternoon, everyone. Next, we are going to start spine session, which includes spine endoscopy. For this spine endoscopy, we are inviting our chairpersons, Dr. S. Srinivas Reddy sir, please come on to the dais. And Dr. GVS Murthy sir, please come on to the dais as chairpersons for spine endoscopy sir. Dr. Anusu Anand sir, please come on to the dais as a chairperson for spine endoscopy session.
Now the spine endoscopic session will start. First lecture is slight modification in the order of presentation. First lecture is by Dr. Shrikant Tega on FES for disc herniation. May I request Dr. Shrikant?
Hello, good afternoon everyone. Hi sir, I'm Dr. Shrikant. I'm going to present about a very basic talk about doing a endoscopic surgery. It's an interlaminar endoscopic surgery. It is for the people who are going to just start their own practice, and these are the very basic techniques which I'm going to tell. So indications pertaining to, I'm going to discuss only discectomy indications and all. So interlaminar to start with best is L5S1 followed by L4-5. Central, posterolateral, down or up migrating, huge disc prolapse with dorsal migration, and recurrent disc prolapse are the indications for L4-5 and L5S1 interlaminar discectomy. So the basic instrumentation almost remains same except for the armamentarium. The main armamentarium which we have is the endoscope. It is a working channel endoscope. If you can see, So it has a working channel in itself, which is of 5.7 mm, and we have a lens through which goes through it, and we have ingress and outgress channels. So the instrument size must be 5.7 or lesser than that. So these are all the basic instruments which we use in the regular spine surgery, but the instruments are longer. And the other three instruments which we use, which we are used differently, are number 5, number 6, and number 7. That is a working sleeve, the sheath, as well as a dual dissector, which are different. Apart from that, there are RF probes, which is a flexi probe. The 13 number is a flexi probe, and a side firing probe is a number 12 one. So when we go for a routine spine surgery, we just check the films grossly, and we can go and do the surgery confidently. There won't be an issue. But when we are dealing with the endoscopic spine surgery, there are minute details which we have to look into. So for in X-ray spine, we usually look into the interpedicular diameter, interpedicular distance, which is most at L5S1, followed by L4-5, and it decreases as we ascend above. Apart from that, what we can assess is how much bone we have to drill to make the window big and to access the disc fragment. So looking at the second film, we can see the facet joint is marked in the triangular fashion. We can see the medial border of the facet, and the other line shows the line of the thecal sac. So you can see there is a good gap in between the two things, so that without any lot of burring is not needed. We can just cut the fragment, go through, and take the disc and come out. And in this film, you can see that there is hardly any space between the lateral border of the thecal sac and the facet joint. So here you need a lot of burring, so that you can go in and take out the disc fragment. So to begin with, it's a big headache when you have not handled any orthoscopic instruments before, and you're just a spine surgeon or an orthopedic surgeon, and you're dealing directly with the endoscopy. So these 7 cables are the things which you have to remember, so that you will not get frustrated when you're starting the case. Because before putting the incision itself, half of the energy goes in dealing with all this along with our stuff. So this is very, very important. These 7 cables has to be taken care of. So before starting the surgery, the steps start actually. So you have to check whether your instruments are working, your scope is fine, your plasma is firing well or not. So all these things has to be checked. So equipment has to be checked a day before. Pre-op planning has to be done on X-ray and MRI as said before. Positioning of the patient is very important. Flexion attitude is acceptable and better, and neutral is also fine, but extension is not acceptable. So operative steps are marking the level. Then we usually give erector spinal block. It's optional. Then we insert a needle. Then we give a skin and deep fascia incision. Then we insert an obturator and railroad a sleeve on it, and then we put an endoscope. So it goes something like this. So this is erector spinal block, L4 erector spinal block. Then we mark the level. We are going to do L4-5 surgery here. So we start our entry point at a spinal-laminar junction. So this is a needle being inserted. Then we make a skin incision. This is a deep fascia cut, and then we clear it soft tissue with the artery, and then we put our sheath and endoscope. So this is a case example of L5S1 right-sided disc. So here you can see the interlaminar window is very, very much fine. So this doesn't need any kind of drilling. You can straight away go into interlaminar space and take out the disc. So this is the landing of the sheath as well as working sheath as well as obturator. So intraoperative steps, after you put the endoscope, what are you going to do? First you are going to do the soft tissue clearance. There is some muscle creep which is there, you have to take it out, and then you have to identify the structures like flavum, lamina, facet, inferior lamina, and then do flavectomy, identify neural structures, and then do the discectomy. So this is a small video. So this is the L5S1 level we are operating. Right side is a cranial level. Left side is a caudal, and up side is a medial, and the lower side is a lateral lever. So we are doing the soft tissue clearance. We are taking out all the muscle creep which is there, and then what we are seeing is a glistening yellow whitish structure is a superficial flam which we are seeing, and then we identify the structures. So that's the lamina. This is a facet, and this is a clear cut superficial flavum. Then we start doing flavectomy, we start cutting it, and then we start making a small window, and then we extend it. So this is the entry we are making into superficial flavum. And then we cut it, then we upcut it, and then you can see the epidural fat tissue. After this, the next step is to identify the neural structures. Here you can see the thecal sac as well as the traversing route. So this space is identified, then the root is retracted by the dural dissector, and then the discectomy is done. The root retraction is done, and then the discectomy is done. After the discectomy is done, then you check for how is the shoulder of the root, how is the axil of the root, and how is the overall movement of the root which is happening. So I will show you that in the last video. So this is a 31 female with left lower limb radiculopathy, more since past 6 months, very significant since past 10 days, was not able to sit or stand. Leg score was 9 by 10, SLR was positive on the left side and motor power was normal. So this is the MRI, this is the cut short film, the left sided parasagittal cut as well as axial cut. You can see there is an extruded fragment at alpha S1 level and is a small extruded fragment here. So this is a post-surgery video. So you can see the flavectomy has been done, the phlegm has been cleared off. What you are seeing is the traversing route, S1 traversing route, and the medial side is the thecal sac. Then we put a dural dissector inside to check how the shoulder of the root is there. So the dural dissector is being inserted, the shoulder is there, the shoulder is free, the disc was there, it has been removed. And that is the axil of the nerve root, which you are seeing is the axil of the nerve root. You can see the nerve root is freely mobile. And that was a place where the disc was there. So this is the disc fragments which you can see. So that was a inferior migrated fragment you are able to see here. So you can see that is also confirmed by the root, by the C-arm, by putting the root probe. Thank you. Hi, sir.
Shall we go to questions at the end, sir? Or there is one question from my side.
Yes, sir.
Any operation for an orthopedic surgeon, when we want to train the youngsters,
yes, sir,
we'll show them this is median nerve, this is radial artery, like that we show.
Yes, sir.
Because it is seen by both of them.
Yes, sir.
In your case, it is seen only by the surgeon.
Yes, sir.
So how are you going to train the youngsters? See, in pathology, they have a microscope through which they see, other person also can see.
Yes.
There is one microscope for them.
Yes, sir.
Where multiple people can see the same slide.
Yes, sir.
Do you have anything like that?
No, sir. In fact, if OT allows 7-8 people can come together, stand behind and see it is live, it is in front of you. They can orient, you can ask in between whenever the scope is being rotated, the orientation may be lost. But when you are right side and the left side, the landmarks are very, very clear. When you are on the left side, the left is cranial, the right is caudal. And the medial side is the one which is on the upper side, and the lateral side is the lateral side. Whenever we are rotating the scope, the things may change, then you can ask the mentor. So not only a single person, lot of people who are standing in the OT can ask it, not an issue.
From the audience? There are no questions, I think. There are multiple questions, I think I'll ask you later on.
Sure, sir. Thank you, sir.
Because there is another question, which one will go for surgery, which one, this micro discectomy, which one will go for open surgery, that's what?
Sir, all indications, wherever you can do micro discectomy, you can do endoscopic, sir. There is no contraindication as such. So wherever you can do micro, you can do endo.
Thank you, Dr. Srikanth.
Thank you, sir.
The next one, Dr. Basit, M.A. Basit could not come. They wanted to play a video of his talk to have a continuity of this procedures. So transforaminal endoscopic lumbar dissection, best indications and technique by Dr. Basit.
endoscopic and minimal invasive spine surgeon in Mannat Hospital, Sundarnagar, Himachal Pradesh. Today I'll be talking about transforaminal endoscopy, its positioning and its technique. Challenging time required a different solution to degenerative spine conditions. When we look at this image on the left side, you will see this patient must be having a lot of problems with these implants, care surgical procedure. Why it is, there is a paradigm shift in spine surgery. We want a procedure that should help and benefit our patients. We want our patients should have minimal collateral tissue damage. They should be doing well post-surgery. They should be mobilized quickly, and they should have less post-op pain. And our results should be comparable to other procedures. So it was natural that now patients and even doctors are shifting to ultra-minimally invasive procedures like endoscopic procedures, and among them transforaminal endoscopic procedure is one of the ultra-minimally invasive procedure. This is in a way, we can compare it to the minimal effective dose in pharmacology, because transforaminal procedure is the smallest amount of intervention needed to achieve the desired therapeutic effect, because we are giving less post-operative comorbidity to the patient and we are able to mobilize the patient as early as possible after the procedure. Why it is minimally effective dose? Because we can do it in local anesthesia, we can do it in sedation, and above all, it's a daycare surgical procedure. We can tell the patient to go to home after 4 to 6 hours of the procedure. And most important thing is that it minimizes interaction among different patients and other allied health personnel, leading to less cross infections. So if you compare the complication rates of different discectomy techniques for symptomatic lumbar disc herniation, we have seen that the transforaminal endoscopic procedure, as compared to open microdiscectomy or open discectomy or microdiscectomy, has a lower risk of overall complications and a lower risk of complication necessitating conservative treatment. So it's in a way nowadays a gold standard for lumbar disc herniation. This is my paper, which also compares the transforaminal endoscopic discectomy versus conventional microdiscectomy, and our results were very encouraging. So whenever you want to post a patient of lumbar disc herniation for transforaminal procedure, first of all, you should do a pre-consultation and you should be clear about the indications that are there for this procedure. We usually go for the standard indication like prolapse disc in L1 to S1 region. They can be central, paracentral, foraminal disc or extraforaminal disc. We can expand these indications to highly migrated disc, calcified disc, recurrent discs, lateral stenosis, and we can also do some other less common indications. We can do it in them like facet cysts, discal cysts, tumors. So, but I'll suggest to beginners that you should do initially these procedures in the standard indications. There are some relative contraindications for transforaminal lumbar discectomy. That is, we can divide them into anatomical related and pathology related. When you look at the anatomical related contraindications, you should be very careful about the exiting nerve root anomalies like duplicate nerve root, low-lying nerve root. If iliac crest is high, that it is reaching up to the mid pedicle of the L4, then you should be careful as a beginner to start with such type of patients. You should always try to do initially with the simple patients, which are easy to do. And there are some pathology-related contraindications like calcified disc. One should be very careful while dealing in such patients, because when you strike the disc with the dilator, sometimes it breaks and forms a pyramid-type cone, which compresses the nerve root. It's better to do interlaminar procedure in such cases. And if there is bilateral extensive central and lateral venous stenosis from the facet and flavum, one should go for the interlaminar approach, because the bilateral symptoms won't be treated by transforaminal procedure. So one should know the steps in transforaminal endoscopic lumbar discectomy. First of all, you should have a proper pre-op surgical planning. You should know the location of the disc. You should know about the patient size, because it's important. If your patient is obese, then your scope should be larger, and your needle should be longer. There are some anatomical factors which you have to be very careful about, like if you are doing it in the upper lumbar segments, there is presence of kidney, traversing nerve root, relationship to pedicle. If there is duplication of root or low-lying root, you should be careful at that time. And moreover, if there is a small foramen, then there are more chances of post-operative nerve root dysesthesia with this approach. So you have to be careful, or you have to use a very smaller dilator for this procedure. And we have already discussed about the high iliac crest, and most important step in the transforaminal lumbar discectomy is the MRI assessment. You should have a proper MRI assessment. You should talk to your radiologist, who will give you the coordinates or the distance from where you have to enter the skin, how far lateral you should be. So this is very important. So how to calculate the tangent or the entry point is very important. There are various constant factors. First of all, you should determine the deepest part of the disc planned to be removed, measure the distance to the skin, which is the blue arrow, then plan the proposed trajectory, and measure the angle between the proposed trajectory. This is a very simple way to do it. We have already shown you in the workshop how to measure all these angles. But you can also ask your radiologist to give you a rough idea for the entry point. So when we are doing the transforaminal procedure, safe extraforaminal docking and floating technique is very important for the upper lumbar or thoracolumbar junction. This is very important because there is dural expansion at the upper lumbar and thoracic levels. Usually our reference point in lower lumbar areas is the medial pedicular line, but when you go into the upper lumbar areas or thoracolumbar junction, it's usually the middle pedicular line. So one has to be careful while docking so that you don't cross the middle pedicular line. There is also one more important thing, that the presence of kidney at higher lumbar segments is there, and one has to be very careful, have to be more flatter than steep angle of inclination. Because if you go for the steep angle of if you go for the flatter angle of inclination, you can damage the kidney. So you have to be more steep at that level, and best is to do the floating technique. When in our Indian setup, when you look at the average distance for the transforaminal approach, it's around 8 to 12 centimeters. It varies with patients. You have to calculate it in every patient. And when you go for the extraforaminal approach, it's around 6 to 8 centimeters from the midline. One important thing for the beginners, I want to say, first palpate the quadratus lumborum muscle, see its extent from, you can see when you go in the upper lumbar segment, it's more medial. When you go to the lower lumbar segment, it's more lateral, it's lateral edge. So you have your needle placement should start from the medial to the lateral edge of the quadratus lumborum muscle, so that you don't breach the peritoneum, so you don't cause harm to the internal organs. So these are some of the anesthesia related interventions that what you have to do before taking the patient to the OR. This is what I do with my patient. First, I usually prepare 3 syringes, 4 ml of ropivacaine, 1 person with 6 ml of normal saline, 10 ml syringe, 3 ml for skin and 7 ml for subcutaneous tissue. Then second syringe, 4 ml ropivacaine, 1 person with 6 ml of normal saline, 7 ml for facet and epidural area, and 3 ml for annulus. And third syringe, I don't use it routinely, but when I only use it for standby breakthrough pain. So this is the positioning and setup. For left-sided approach, I'll stand on the left side, and my radiologist and my endoscopy screen will be on the right side. And when I'm doing the right side approach, it will be opposite of it. This is how you place the patient on the bolster so that the abdomen is free. Then you start the marking of the patients. Once you have marked everything, then you should know about the barriers of the Camden's triangle, and you should find a safe zone of entry in the Camden's triangle. We all know that it is formed from the it's formed from the traversing nerve root, exiting nerve root, and the upper end plate of the lower vertebra. There are various neurological barriers like sympathetic trunk, ganglia, exiting nerve root, traversing nerve, sinovertebral nerve. So best is to find you have to find a proper safe corridor in its entry. Once you enter it, then you are safe. So docking and localization of target site is very important. Trajectory is important because if it is placed too anterior to the vertebra, it can cause contamination of the needle. If you are too flat, you can strike the spinous process or the lamina. So best is to strike the facet and just manipulate the needle there. If you want to be more flatter, you will have to do a foraminoplasty in the patient. So I'll be just giving you a rough idea how to put these lines in the patient. First of all, you will put the patient in the prone position. After that, you will mark the midline of the spine of the patient. After squaring the vertebrae, target vertebrae, then you will put the discal line or the horizontal line. After that, we'll start, after knowing the depth of the disc, then we'll start putting the needle inside. Your needle should not cross the medial pedicular line in the AP view, and it should not cross the posterior vertebral line in lateral view. If you have achieved this, then your entry is safe and you can start your procedure. So then once you enter the bleeding early phase of surgery, neural elements are in the proximity, bony work at the superior articular facet. You can see I'm just in the foraminal area. And now you can see the facet. This is the disc. You can see the fragment of the disc is visible. I'll be working on the SAP so that I can clearly see the neural elements and the disc fibers. I'm using the articulating bar here. Once I use the articulating bar, I work on the, I thin it out, and I'll see the ligamentum flavum also now. So in this way, you are using this ultra minimally invasive technique. You are not disrupting any collateral tissue. You are not causing harm to the patient. Everything is preserved. Only the pathological fragment has been removed. So it's a targeted fragmentectomy, and patient is pain-free. And immediately you can send the patient home after 4 to 6 hours of the procedure. For beginners, this slide is very important because this will help them to understand you can do all type of herniations with this procedure. If it's up migrated, central herniation, or down migrated, just remember that facet is the door, pedicle is the pivot of seesaw. Just use the so try to find the pathologic material, because if you remove all the disc material, it will lead to early degeneration and back pain. But you should not leave most of till then you can never see the half and half view. So try to be flat when you are doing the transforaminal procedure. So if you are doing any procedure, there will be some complications. So one should be aware how to handle these complications. You can have exiting nerve root dysesthesia, which you can manage by medications, steroid, pregabalin, neurotropic agents. Then you can use nerve block. So risk is more, and best is to do half and half view inspection. Full of loose fragments, and don't remove. Don't try to remove less. Try to remove adequate. So you should be able to know the difference between the back pain and the recurrence. Try to learn this difference, and always ask your patient to wear the brace post-operatively 4 to 6 weeks. And once the recurrence is there, so management can be conservative, or you have to do revision surgery. Conservative you can do if the fragment is small, it will resolve by itself. But if the fragment is big and there are a lot of symptoms, then you should either go with the transforaminal route, which is easier, or you can go with the interlaminar route because you will find you won't find any problem of scarring in that area. So my take-home message for transforaminal endoscopic approach is that it is easy to access, especially in foraminal and extraforaminal disc herniations and ipsilateral recess stenosis, and ventral epidural space can be easily accessed with this approach. You can remove the disc fragments, shave off the osteophytes. So it's one of the easiest and the best approach for such pathologies. And it is biomechanically least destabilizing because you are not removing any facet, you are not doing any posterior work which will destabilize the spinal segment. So it's one of the ultra minimally invasive procedure which gives all the benefits of open procedures. So we all know about the benefit zone of endoscopic spine surgery. The benefits of endoscopic spine surgery increase when alternative options are increasingly invasive and complex. So it's one of the best choices in the toolbox of a spine surgeon. We should know about these procedures because you will give all the benefits of the procedure to your patient, and your patient will be always happy post procedure. Thank you. If anyone has any questions, you can ask. Thank you so much for patient listening.
Sir, I want to answer on behalf of Dr.
Hello,
Bhatt.
sir.
If you got any questions regarding transforaminal endoscopic discectomy, you can ask me. So actually he has conducted the pre-conference workshop because of some domestic work. He has left the small video. Sir.
Okay. I have a question, sir. Am I permitted, sir?
Yeah, yes, sir.
No, I am asking my co-chair. We always tell these patients, if you go for discectomy of L4, L5, what guarantee you have that you won't have disc in L5S1?
So recurrence is all at L5S1. There is a possibility.
How are you going to counsel the patient?
So we will definitely tell the literature what it says. 1 to 5% recurrence is always a possibility. So we restrain the patient from lifting weights, twisting, bending forward for next 1 to 2 years. We tell them the annulus has to seal because these procedures are nothing but a targeted fragmentectomy. We are not approaching posterior, rather we are going through the so-called the Campine's triangle. So that's why we say them that there is always a possibility of recurrence.
Maybe we can tell the patient that the complication rate is very minimal. You are not going to have any disability of others because of disturbance of the muscles, and you have to do exercise to
strengthen their core,
strengthen the muscles. So it will give the same effects as open discectomy or microdiscectomy. Maybe that's nice.
Okay. Dr. Ramesh Gazula already on podium. He will be talking about diversity of uniportal endoscopic spine surgery.
Thank you, sir. Thanks for a nice introduction. At the outset, I would like to thank the scientific chairman, Dr. Maheshwar sir, for giving me this opportunity. So I'll be talking on diversity of uniportal endoscopic spine surgery as well as the extended indications. So here are my teachers, Gangtek Lim, Dr. Gore, and whatever I am is because of Gangtek Lim. So ultimately it's all to decompress the neural structures, whether it is cervical, dorsal, lumbar. The pathology could be discal, flaval buckling, or disc osteophyte complex, or a hypertrophied facet. So ultimately it's all to decompress. So the options left for this, since years it's a conventional open surgery, then we moved on to microscopy, then tubular system, and one of the surgeons was talking about Destendo. Yes, Destendo. But there are certain limitations. The problem with open microscopy is all about the posterior ligamental complex. We're going to knock out whether it's a spinous process, lamina, anything. So ultimately this is all leading to some amount of iatrogenic instability, going for a hardware installation like you're going to put screws. So that's the main limitation, and the field is bloody and the angle of view is 0. So in order for a better view, you got to knock out a lot of bone, and there's no magnification, the maneuverability is not possible. So to overcome all these things, the full endoscopic spine surgery has come into vogue. 80 years back, I started with transforaminal endoscopic discectomy. This is what Dr. Basit was telling. Thanks to Mr. Parvez Kambin, he's an Iranian doctor who could find out a normal anatomical corridor through which we can go from foramen into the disc way back in 1973. Then they started doing as fluoro-guided nuclear extraction. Then they started introducing an arthroscope to take out, debulk the central. There were certain limitations. So now we are doing with a 3.7 internal diameter scope, and this is a Cambine's triangle between exiting, traversing and end plate. It's a targeted fragment technique. It is a fluoro-guided procedure, and Dr. Basit has already explained. I'm just skipping all these slides. You can go for general, regional, whatever. The position adopted is prone, and it's a fluoro-guided procedure. You got to go almost 10 to 12 centimeters from the midline, and this is almost like a Seldinger technique. And these are the armamentarium. It's a small video clip you can see here. So this is how the needle is docked on the fluoroscopy, and guide wire is passed, and the obturator is passed, and the working sleeve is introduced, and this is a scope, and this is how a targeted fragmentectomy is being done. We can nicely remove the fragments. So everything is under vision. It requires a lot of precision and understanding. That's the end of surgery, wherein you can see a free floating dura. So there are certain limitations with transfemoral which made us to move to interlaminar. Maybe because of it, 5S1, though interlaminar window is wide, but there is high riding iliac crest. That was an obstacle to go from the midline almost 10-12 centimeter far away, hitting the iliac crest. So that was a limitation. And even the mobility inside the foramen was also something, was an obstruction, as well as if the disc annulus is calcified, we could not address that, as well as in case if there is posterior elements from flaval hypertrophy, we were not in a position to address. That made us to go into interlaminar full endoscopy. Someone was asking like, what are the indications? Whatever is applicable for microscopy, open surgery, distendo is applicable for full endoscopy with minimal damage. So we are not doing any tissue trauma there. So anesthesia technique, yes, Dr. Srikanth has already covered, so I just want to skip all this. So at my center, I do under segmental epidural sensory dose. So I avoid general anesthesia. So all my patients, the patient is conscious, patient himself or herself is an intraoperative neuromonitor, and this is the operative setup, and this is already covered. The instruments are almost same like an open surgery. There's no difference. The working length is more. They are all small instruments, and we use saline irrigation, for remove the debris and to achieve some amount of hemostasis, the clarity, the clear vision. And this is a bone burr which we use, and this is all, this is already covered by Dr. Srikanth, so I'll just cut short. So small incisions, hardly 6-7 mm incision, introducing a scope. You can see here an obturator is inserted, and the sleeve is railroaded, and scope is introduced, and that's how the ligamentum flavum straight away without any bone work at 5S1 and with a limited bone work at 4-5 or 3-4, transgress the ligamentum flavum. Then the saline pushes the dura down, and you can do the same how you were doing in open surgery or microscopy. But everything is under vision, and it's almost tubular, it's precise. You can see this is an example here with the help of another retractor. I'm retracting the root, and we are trying to take out the disc material. Everything is under disc, and there's nothing like incomplete. So everything is, this you can see a post-operative scar. It's a very small incision, even you cannot find out in post-operative MRI too. So you can see the difference, microscopy, endoscopy. I just want to show you one case scenario here. So you can see here the incision, and you see here, this is the disc material which is being retrieved. And here the patient wanted to see actually the material also. So since patient is conscious, we're trying to show him, even you can see here, the patient was interested to see his fragment. You can see here, so that's what. So the second case, and all the patients, since we are doing at a sensory dose, patients are able to walk out of the theater. So then the diversity of monoportal has extended to LCS, lumbar canal stenosis, wherein we were doing over-the-top decompression. This is a case scenario of a 58-year-old male patient suffering with LCS, and people are asking, most of my open surgery friends, how can you go to the opposite side? It's possible. It's a technical challenge. Got to burr the base of spinous process, go outside, you can see, go to the base of spinous and look down from cephalate to caudal. You can see the opposite side lateral disease, that is the L5 traversing nerve root on the opposite side. And now I'm trying to view my camera from cephalate, caudal to cephalate. This is ipsilateral side. I'm standing on the patient's left side. You can see the traversing nerve on both sides. So adequate decompression, whatever you're getting under open surgery, can be done with endoscopy with minimal bone work, because it's a 15-degree view. You can undercut the lamina, so you don't require, it's not a 90-degree or 0-degree view. So then we started extending all this, adding a functional anesthesia for high-risk cases, like patient is a 84 with severe canal stenosis at 3 levels, and she is suffering with all diseases which we see in Harrison textbook. And you can see here, with her permission, we are able to show her even face. You can see here. So patient is conscious throughout surgery. Patient is talking to us and we are able to perform the surgery. Then even we moved on to high risk cases. This is a global hypokinesia with less than 20% ejection fraction. Patient underwent a double wall replacement. Patient present with 4-5 PIVD, and we could do it under functional anesthesia. Then we extended, we diversified the application of monoportal to the revision surgeries. In the beginning, people used to say that, if there is a recurrent disc, it has to be open. No, it is far, far better with a monoportal, whether it's previously operated by microscopy or open or endoscopy. So here is a case scenario of a 6-year-old open discectomy patient. Patient has got recurrence at 5S1. So we have done fragmentectomy. You can see the incision of open. You see such a huge incision. This is incision of a endoscopy. And then we were started doing, initially when there is LCS, if there's 2 levels, 2 small incision, we used to do it 3-3, 4-4. But now with the help of my teacher, Gangtek Lim, I started doing jumping technique. This is a case scenario of a 4-level stenosis. The incision remains the same, the single 6 mm incision, but the thoracolumbar fascia is split at multiple levels, and we could address. We are leveraging the advantage of the lumbar lordosis and doing with a monoportal endoscopy. You can just expect the amount of tissue trauma. It's far, far minimum, and that's why we are able to mobilize the patient immediately after surgery. That's a beauty. So you can see here 4 levels, L2, 3, 3, 4, 4, 5, 5S1. So 4 levels we have addressed in 3.5 hours, and patient is morbidly obese, and she has got a lot of comorbids. So you can see the fluoro images, and that's the post-op. Some of my colleagues were asking, like, maybe you might be doing more bone work. I know you can see here how much amount of the bone work. Everything is medial to the pedicle, so hardly less amount of bone work, because we are using the optics. The 15-degree optics are, in some scopes it is 25. And you can see the incision, it's very small. We could do this such a small single stitch, 4 levels. So then we move on to endotelops. There is a light ecclesis, grade 2, grade 3, unstable. Yeah, we started doing endofusions, the same what we used to do in open T-leaf. You can see here, we dock on exactly at the pass junction, and we try to retrieve the IAP, SAP file to use as autograft. And you can see that's a traversing nerve root, exiting nerve root. This is a disc, and we prepare the disc, and we prepare the end plates, push in the graft which you have prepared along with, BMAC, and then we dock in a cage. You can see nicely a cage has been docked. This is under vision. That's what I want to say. See, this is all the fluoroscopic images, how we are doing, and the screws are done by MI system. There's no open. So then we started extending into the dorsal area also. We started doing even a calcified disc by transforaminal, and even the so-called fixations we're doing even through transcambins. What Dr. Basit was speaking, so same through the same transforaminal, we are able to do a K-leaf as well as the transforaminal, the fixation. And then we moved to do the calcified ligaments at the dorsal level, the compressive myelopathies. You can see here, this is a case wherein, there's calcification of the dorsal, the ligamentum flavum, and there's a patient presented with compressive myelopathy, and we could nicely do decompression. We can de-roof if it is if it is attached. Here the patient is conscious. You can see here. Now our anesthetist, is talking to the patient. That's a beauty. And immediately after post-operative, we are able to make them walk. This is a post-operative MRI. You can see everything is decompressed. And then we move to cervical area. Initially, we started to do only for disc work if it is a paracentral or foraminal disc. And here is a case of C5, C6. Patient has got a huge disc at C5, C6. We used to do under general anesthesia, but not off late. Since 1 year, we are doing under segmental epidural anesthesia. That's a beauty, because most of the cervical compressive myelopathy patients are aged, and they are with a lot of comorbids. They are not fit for general anesthesia. So now we are doing under cervical epidurals. You can see here 5-6, that's a C6 nerve root there. So I am retracting the root, and after doing a laminoforaminotomy, I am trying to retrieve the disc material nicely. You can see here, this is hardly a 6 mm incision. And then we started moving to cervical stenotic myelopathy. We started applying for single level OPLL, focal, then multi-level. Now we started doing decompression at 4 levels. You see this case, This case we have done 4-level decompression with a single incision of 6 mm under segmental epidural. Patient was conscious. We have left in between, this is a bridging bone, for the sake of stability, and the patient, you can see the cervical levels, multi-levels, it is being decompressed, not only ipsilateral side, this is ipsilateral side, but also to the opposite side too. So I'll zoom it to the opposite side. You can see this is opposite side also. So, and we are writing a big paper on this in international journal very soon, and I have even presented in international congress because it is first of its kind, doing under epidural. Now, this is our first case. Patient is 69-year-old, post-EABG, ejection fraction 33%, diabetic hypertensive with severe compressive myelopathy. Patient was in uric grade 5, and you can see the epidural catheter there. This is hardly a working sleeve, and then we done multi-level decompression, and this was a reported case which I was talking about long back. So we are nicely done. I'm just keeping the video and running short of time. So this is the post-operative images I can show you after decompression. Yeah, this is a post-operative CT, and this is patient was near grade 5. After 3 months, he has gone to moved to grade 3, and then very recently, 6 months back, we started extending the indications of monoportal to even piriformis stenotomy. Here is a case, patient was present for last 4 years with piriformis syndrome, switching from pain physicians to spine surgeons. Then patient landed at my hospital, and we could do a diagnostic block twice and confirm, and then we have done a piriformis stenotomy with a small incision. So I just want to show you, see, we could find it out. Otherwise, we had to give big incisions. Patient is very young, unmarried. So see, we are completely knocked out the piriformis. And then even sometimes, post-operative complication, Dr. Abhinandan is going to cover you. Yeah, definitely, sometimes we come across dural tear. This is a case of Angstpa with uchronosis. And to my dismay, it so happened there was a dural tear. Yeah, it happens. So it happens in open, it happens in this one. Then how we can do it? People used to say that you have to open it to repair it. No, it's not required. I'm able to pack the Duragen inside. You can see here, it's nicely placed. You can see the blackish things. This is uchronosis. The phlegm is completely blackened. And then, we used to even suture with 6-0 nylon with a monoportal endoscopy. Just imagine. So ultimately, I just want to, the take-home message is full endoscopic techniques are getting better, and replacing, I can proudly say, replacing open and minimal invasive procedures. And to spice it up, we have added the functional anesthesia. I say it's a far superior and has got a lot of advantages, especially in elderly. Thank you for the patient hearing. Thank you. Any doubts? Sir, okay, sir. Thank you, sir.
Okay. Next speaker will be Dr. Abhinandan Reddy. Complications of spine endoscopy, and if they are, how to manage them.
So good afternoon, one and all. So I am practicing in Hyderabad. I am a senior consultant at Direct Hospitals. No matter how good you are a surgeon, everybody has got his own share of complications. And you will become a better surgeon day by day when you are able to handle those complications and give the patient the best result. So even though we say endoscopy, we have a very good vision, we have a lot of control over the neural elements and also the bleeding, we have our own share of complications as endoscopic spine surgeons. So I'll run you through few of those which we encounter in endoscopy spine. So these are like incidental durotomies, dysesthesias, incomplete decompressions, nerve root injuries, recurrent disc herniations, epidural hematomas, and discitis. So as we can see, the literature also says there are a lot of complications in any of the surgeries regarding spine, but especially in endoscopic spine, these are like most commonly related to the incidental durotomies, transient dysesthesias, discitis, and nerve root injuries. So there are a lot of literature covering all this. And incidental durotomy, though it is much lesser than what happens in open spine surgery, which is like 2.7%, but in endoscopy it is like 0.8 to 0 to 0.8 or 0.6%. The incidence is more in interlaminar kind of endoscopic procedures, and Kim et al., as Dr. Ramesh has shown you, Kim et al. Has divided into 4 types depending on the type and extent of the dural tears and where it is and how far the neural elements are involved and how much the neural elements are entangled in the dural tear. So these are the classifications. Here I would like to quickly run through and show you what happens when we do in what happens in a dural tear and how the dural elements are floating in the saline irrigation and how to deal with it. So the most common zones where the dural tears occur are in the axillary area, and the second zone is the thecal sac, the main central sac, and the other area which we encounter the dural tears are in the traversing areas, traversing root areas. So this is a case example where the axillary fragment, as you can see in the image, when we are trying to retrieve it, there might be lot of adhesions because of the chronic disc. So incidental durotomies are more common in such kind of chronic disc and a huge disc where it is stuck in the axilla. So as you can see here, there is an axillary dural tear near the root, exiting root. So these are few case examples where I am showing you the axillary dural tears. See, under the saline irrigation, you can see the neural elements are floating, but as such there is a dural tear. Here we can fix it through Duragen. What we use generally, regularly when there is a dural tear, we use a small Duragen patch. We just leave it there. Though the image is showing it very huge on the screen, but it is hardly around 2 to 3 mm only. So the dissector which you are seeing is only 3 mm. The size of the dural tear is roughly around 3 mm only. So we pack it with the Duragen and we come out. Because of a small incision for introducing the scope, the tissues will fall back and there will be no more a channel from where the CSF will leak out. So the other, which I was saying, the traversing root area dural tear. As you can see, because of the chronic adhesions of the ligamentum flavum or the disc, there can be some dural tears while removing the ligamentum flavum or while cutting the ligamentum flavum using our instruments. So as you can see, here also we use, most commonly we use a Duragen patch. It's a small simple patch. We decrease the saline irrigation there. We just put a patch there. Because of the pressure from the outside, the patch just sticks onto the neural elements and does not allow any CSF to leak out. So as you can see here, this is a small central dural tear which will become a pressure point from where the dural rent will give lot of CSF leak in the post-op. So this can also be managed in spite of being a very huge pressure point using a small Duragen patch. This can also be managed easily in a endoscopic procedure. Here also we place a small Duragen patch which will get stick onto the dural tear there. As you can see, this is very easy for us as trained spine endoscopic surgeons. We can easily place the Duragen patch there inside and outside and block the CSF egress. So as you can see, there is a roughened tear because of chronic adhesions of the ligamentum flavum. While removing the ligamentum flavum, there is a huge tear where the neural elements are trying to come out. Here we pack it with the inlay outlay grafts. That is, we gently push the Duragen patch into the dura, covering the neural elements. Slowly we insert inside the dura, just pack it up. Then again place another Duragen patch over the dura. So it is an inlay overlay technique. So it completely seals off the dural tear. So these are few examples, like this was a case by Dr. Ramesh in the Ang's pond. So as you can see, the neural elements are trying to come out because of the chronic ligamentum flavum adhesions, especially in the Angst-Pond cases. There is bound to happen a dural tear in any kind of surgery, be it an open surgery or a microscopic surgery or endoscopic surgery. You are always expecting a dural tear. So need not worry if there is a dural tear, especially in endoscopic spine surgery, because you can easily tackle with a small Duragen patch, and also because you can work very close to the dura. The chances of having a dural tear is usually very, very less, but even if you have a small dural tear, you can easily deal it with a Duragen patch or a suture. So as we are moving through the advances in dural tear repair, we have slowly introduced for long tumors, we are excising the intradural tumors, and also we are trying to suture it like we do in arthroscopic repair also. So I have shown you, right, this is an inlay technique. We are introducing the Duragen inside the dural canal, and we will seal it with another Duragen patch over it. So this was what was I was talking. In large tumors or large dural tears, after excising the tumor, we are trying to introduce this needle 6-0 prolines and trying to suture the dura using endoscopic techniques only. So there is no need to fear about having a large dural tear. What will happen? Will the wound heal or not? So those days are gone. Now through endoscopic techniques, we can even suture the dural repairs. So we have tried this in few cases. We were successful. Then we have slowly advanced to other techniques like what I was showing. Here we have excised the intradural tumor, and we have put a stay suture using a 6-0 proline, and slowly we have introduced the pediatric laparoscopic vascular clips. So we have slowly sealed the dura. So you can see almost 4 centimeters of 4 centimeters of dural tear has been repaired endoscopically using pediatric clips. So the major part where we tend to do these kind of injuries are while cutting the ligamentum flavum. So understanding the instrumentation, where to use, how to use, and what to use is the most important part of any surgery, be it an open surgery or a microscopic surgery or a endoscopic surgery. Using the correct instrument for the correct step is most important. So how to cut a flavum using different instruments, slowly using your scope, seeing underneath what is happening. After having an adequate view, then only you cut the ligamentum flavum so that you are not holding the dura and cutting it. So the quick takeaways from this are: identification of the dural defect is more important to minimize the short and long-term adverse consequences, and incidence of dural injury is more with interlaminar kind of technique rather than transforaminal technique. In case of large dural injury, have less threshold to convert, give some time, try to repeat endoscopically. If not, then only convert. And identify the structure which you are cutting before entering into the intradural epidural space. And post-operative dysesthesia are also common, especially in endoscopic surgery, because we are using radiofrequency probes. Another 1 minute. Radiofrequency probes. So we are cauterizing the elements, bleeders, very close to the neural element. So these are most common, especially in endoscopic surgeries, depending on the type of probes which you are using. Another complication might be epidural hematomas. If you don't try to cauterize the bleeding structures, or if your saline pressure is too low, probably after removing the scope, there can be an epidural hematoma which can give a mass effect, and the patient might still complain of the similar complaints which he was having pre-operative. So this is a kind of example where you can see in the first image there was a epidural hematoma, but to our surprise, this was done somewhere else, but to our surprise, when we went inside and saw, there was a dural tear. Epidural hematoma we combined with an dural tear. So we went in again and we repaired it with a Duragen patch. Incomplete decompression is also a part of endoscopic spine surgery, because we might be scared how far to go, how far to decompress. So incomplete decompression can also be a part of the complication, because patient might still have this similar complaints what he was having pre-operatively. On the same side, ipsilateral side, you might be very good, but doing it on the contralateral side, especially fearing the complications, you might leave it incomplete. So adequate decompression is always necessary. So recurrence is always a part of any kind of disc surgery, but the recurrence of disc herniation, especially in endoscopic spine surgery, is very, very less, because you tend to see the disc material very closely and you tend to remove all the disc fragments which are loose. So discitis is also a problem. Definitely when you are using so much of saline irrigation methods, so much of instruments, you have to be very particular who is handling the saline irrigation methods, who is handling all the pipings, who is handling all the cords, cameras, light source and all the instrumentation, because every aspect involves a source of infection. So you have to be very careful. And yes, infection can be a part of endoscopic spine surgery. And post-operative instability and facet injury, because if you are drilling more and more bone, some point of time you will be removing the entire facet. So inadvertently you are going to make that segment unstable. And bleeding is always, it is easy to control once you know how to use the scope and how to use to manage the pressure intraoperatively. But if there is lot of bleeding and if you are tending to use a lot of radio frequency ablation, then you might end up burning the root or the dura or giving the ganglion symptoms later to the patient. Thank you.
Okay. Next speaker will be Dr. Kiran Jaiswal, UVE indication and technique.
Hello, good evening. Thank you, Tosa. Thank you, Chairperson. My young orthopedicians over here and young spine surgeons going to be endoscopic spine surgeon in future. So, today I am going with a little bit of change of subject, including 1, 2, 3, 4, all types of endoscopic spine surgery, and why you should try to do endoscopic spine surgery. You should be aware of the evolution of the endoscopic spine surgery in India and worldwide. In India, almost from era of 2001 to 2010, it has been evolved by first generation transfemoral endoscopic spine surgery. My all 4 colleagues, they have narrated very nicely. Transfemoral interlaminar, PSLD, that is posterior stenotic, that is monoportal, and all the indications of today's spine surgery can be handled with endoscopic spine surgery. Then why UBE, unilateral biportal endoscopic spine surgery? Being orthopedic surgeon, it is very easy for you. You are used to with the arthroscopy. This is arthrospine. This is underwater MISS. This is underwater open surgery. So this is underwater under fluid medium, open MISS. And with the open and MISS, if you are very well used to, very well versed, then you can be able to complete. So now, here the agenda is what we cover today. It's a landscape, that is rise of the endoscopic spine surgery, procedure types, uniportal versus biportal, procedure tracks, training framework and mentorship. Why the rise of endoscopic spine surgery gradually in India and abroad? Why? Because endoscopic spine surgery has seen exponential growth over the past decade, or rather past 1.5 to 2 decades gradually, and driven by the patient's demands for the faster recovery. It's not surgeons now, it's patients, they are demanding, sir, I want endoscopic spine surgery. Will you be able to do? This is my patient's demand. So I must say, this is the time for you to learn, to jump gradually. It's gradual. See, it's not like Rome cannot be built in the one day. Same way here, you have to go with the all anatomical, pathological, structure, learning program. It has its own schedule. So same way, in India now, we are all, majority of the people, they are almost covering almost 50 over dedicated endoscopic spine centers, and abroad also. And young surgeons who are choosing endoscopy as a primary skill, you are most welcome. See, all the indications, complications has been discussed, so I am not going into that. Why? It's minimal invasive, then going to be the ultra minimal. With the ultra less, percentage of the complications are there, but it's reduced down tenfold. Remember this. So understanding the spectrum of the procedure is, again, you have seen nicely, right? Discectomy, foraminoplasty, everything, thoracic and lumbar, nicely narrated by Dr. Ramesh. Now, the question will arise for you. being a young spine surgeon, going to be the endoscopic spine surgeon, the question will arise for you, whether shall I start with uniportal or biportal? Sir, this costs too much, this costs too much. How can I start? Sir, technique. So these are the things. What would you like? So incline, from my side I would suggest the most training programs recommended uniportal PLD, because see, there are a lot of mentors in the PLD or uniportal. There are a lot of mentors in pan India. You can search, you can identify for the monoportal. For biportal, there are very less. Including me, I am biportal, monoportal, transforaminal. So the thing is very less. So the mastering one system first deeply, so far as, right, then like gradual superficial exposure to all if you can keep, rather than be a master of one and then jump to another. So this is why structure training matters. Complication already been narrated by Dr. Abhi and has been mentioned nicely. So these are the 4 pillar theory: cadaveric workshop, simulations and live surgeries that you should attend whenever you get time. Even I am asking for the SR people, young orthopedicians who are just passed out, they should gradually incline, if they are inclined into, they think of that I have to do some spine work then. Otherwise, there are a lot of scope in other also. So the foundation phase, this is again, as I said, anatomy, optics and camera. Everything has been narrated very nicely by previous 4 consultants, speakers. So this is the learning curve. Supervised learning curve with the 30 to 50 is must. Now simulation training, there are a lot of simulation training available except cadaveric. See, cadaveric is very costly than simulation. They at least triangulate yourself, identify, reach the site. So this is ultimately hand-eye coordination. Make comfortable with your hand-eye. Then cadaveric. No training program is complete without cadaveric. You should, right? There is no alternative. There are a lot of centers. Endoscopic Spine Foundation of India, Pan India, it's running. Here my best friend Dr. Ramesh, he is also running lots of programs and other thing, observation, assisted phase and supervised independent phase. See, supervised independent, that is direct proctorship rather than mentorship. This is going to help you. Then competency milestone, it's again cognitive crisis management. Crisis management just now Dr. Abhi has shown. Cognitive competency just Dr. Ramesh has shown. These are cognitive competency, critical management. Then technical competency, that is again, it's related with the what available in your hand. Keep everything in your armamentarium, right? Proper burr, RF, plasma, everything should be proper, and your trained staff. Then I'm not going into the of the lumbar endoscopic discectomy. Already you have seen nicely, nice videos. So, but here you can assess all 4 corners of lateral recesses of pedicle to pedicle, horizontal, vertical. These are all 4 corners. You can see, you can visualize. That can be little difficult with the MISS, not impossible. See, everything previously our forefathers, they are invented. Everything was possible, they are doing. So this is little bit one step ahead to minimize the muscle bone injury and soft tissue respect and early recovery because patients demand. Interbody fusion already been explained. Cervical thoracic approaches explained. So handling complication already explained. This is what I am telling about. Proctorship and mentorship. My young generation should, at least if they are inclined, please join. Please ask those who are doing regularly, at least visit them. Ask them. They are not going to say no. So building your endoscopic setup, everything. Common mistake as a beginner. See, I have seen 1, 2, 3, 4, 5. Can I start directly? No, sir. Right. If you are skipping step of your learning curve, it's going to make, see, this is your career. You are making your career. Lifelong you are doing it. Why don't you spend at least few months, few at least cases, few at least conferences and cadaveric simulation and other workshop? You should. And after learning, this is what video review of your own cases. We don't have, oh, I did it. I finished it. Review it, send it to your mentor or proctors who had done, guide you. So, after reviewing of your own cases, you will come to know that I need to at least rectify, correct this. That is for your proper future outcome. So, training programs in India, that's okay. Programs, different. That's it, the last file. Thank you very much. Never begin without formal program. Again I'm telling you, proper anatomical, theoretical, simulation, cadaver and program life surgeries are non-negotiable. This is what? Non-negotiable. Don't do it, don't skip it. Rest of the other thing, once you have started it, you can be the master of it. But unless you take first step, how will you? So this is the thing. Now, monoportal or biportal, that is your choice. Thank you.
I think we will have question session at the end.
Thank you, sir.
I have some questions to you also.
Thank you very much.
And learning curve in UBE spine surgery, biportal spine surgery by Dr. Suresh Chikatla. There, Dr. Suresh.
Good afternoon, respected seniors and my dear friends. I am going to share my UB experience in the last few years. So I am myself Dr. Suresh Chikatla, working in KIMS Hospital, Hyderabad. So if you observe that trends in spine surgery has undergone a remarkable transformation in last few decades. So the transformation or evolution not only in the size of the incision, so it's mainly preserving the anatomy of the spinal tissue and the target on the pathology and reducing the hospital stay. So so now the era has moved, the pendulum is moved towards the endoscopy. So why there is a paradigm shift towards a UB? So usually UB we usually do with the two small pores, and it allows the maneuvering, and it has two portals. One is viewing portal for that is for the endoscope, and the working portal for the instruments to pass on. So it allows the bimanual maneuvering. So the key principles is it allows direct access to the interlaminar space. You can clearly see the medial and lateral line and the top portion, the cranial portion of the lamina, and the inferior portion, caudal portion of the lamina. You can clearly see the target of the operation site. So it is easily adaptable. Why? Because you are doing from the prone position. So if you are habituated to do suction in one hand and using instrument in the other hand, it becomes more easier for you to use the scope and the working instrument in the other hand. And you can use your regular conventional instruments also, and under the high-end endoscopic magnification. So it has a freedom of open surgery with the endoscopy view. So you can see the scar and immediately post-op 15 days, and you can see the immediate post-op scar. The scar is very less, and it causes very less muscle disruption and minimal blood loss. The recovery is very fast compared to the conventional and microscopic discectomies. So you have a lot of workspace. So what we call the workspace here is called Swan's place. This is a space between the multifidus muscle. So once you enter into the multifidus muscle, the muscles will lift up with the hydrostatic pressure and creates a lot of workspace in front of you. And it has a lot more decompression capability, and you can easily do the bone and soft tissue resection. It's all about the working portal, where you keep and from which side you enter. For the left-handed people, so we'll stand on the left, on the patient to left side, and we'll have a working portal beneath the disc space, and on the left-hand side you will have the viewing portal. For the right-sided disc, so we will be standing so on the right side of the patient. The working portal and the viewing portal will be reversed. So always you should be careful, like the working portal should be aligned with the disc space. Then that becomes easier for the instruments to pass on inside. So which incision to you give, whether it is vertical or horizontal? So for the beginners, I would recommend to give the vertical incision. Why? Because if you want to convert it into open procedure, in case of any difficulty, you can easily convert into open procedure. But the transverse incision is cosmetically well accepted. So here the main problem comes with the triangulation. What is the triangulation? Triangulation is seeing your instrument under endoscope. So if you are keeping distance of at least 3 centimeters between these two incisions, so you can easily identify your instrument under the scope. If it is more than 3 centimeters, you will be lost and you won't see the instruments under the scope. And if it is less than 3 centimeters, the instruments usually fights with each other. So the other tools used in the biportal endoscopy is mainly the endoscope. We use 0-degree scope, and some surgeons they are using the 30-degree scope also, and the drilling system and RF system is more important here. And the more important is the watertight medium. So here the basic concepts, so water pressure lifts the muscles from the spinolabnar junction. It creates a lot of workspace. So as a main here, the water pressure maintenance, we always recommend to you have the pressure of 30 to 50 degrees of water pressure. So that can be calculated from the patient positioning height and the sandbag distance also. So how to choose the right endoscope is more important. When the water flowing to the endoscope is also most important. It should not flow in like a flower. No. It should always flow in a forward direction only. And sudden outflow also equally important. Whatever the flow we are sending inside, that should come out from the working portal. So how to tackle the bleeding? So this becomes we have different maneuvers to tackle the bleeding. So we have to keep the fluid pressure minimum 35 degrees, and you should use the right bipolar. And we have different types of bipolar available in the market, 90 degrees and flexible RF probes. And if the bleeding is coming from the bone, you can use the bone wax also. And of course the meticulous position also is more important. There should not be any intra-abdominal pressure. And if you want to use, you can use the local infiltration with your regular drugs. So this is the initial steps showing placing the portals in a Swan's place. So we always mark the midline, and we always mark the disc line. So we'll keep our working portal very close to the disc space. At least we'll keep this within the 1 centimeter, and the viewing port is 2 centimeters from the disc space. So and we'll try to create a tunnel here, and the tunnel's creation is to passes of the water from endoscope tube to the working space. And these are the basic steps of UBE, and you see we are seeing the cephalad portion, we are seeing the lamina portion and the caudal portion is, so that we are seeing the interlaminar portion, and this is a drill, and we are doing the bone work, and we are taking out all the inferior portion of lamina. Once it is done, we are the remaining portion of bone is removed with the upcutters. And underneath you can see the ligamentum flavum. Once adequate bone work is done, you will remove the ligamentum flavum, and inside you can see the dural space. So once you remove the ligamentum flavum, you can see the dural sheath. So once adequately decompression is done, you can just medialize the nerve root, and you can see the nipple portion coming out, and this is the extruded portion of the disc. And so you can just milk out and take out the disc fragment, and you search for the any loose fragment inside. And this is all done within and the use of high speed burr. So high speed burr has a significant RPM, which causes it creates a lot of bone dust. It obscures the vision, and it causes a lot of bleeding also from inside. So, and whenever the bony work is completely done and you are remove the ligamentum flavum portion, if you want to do again some bony work, it becomes very difficult. We are working very close to the neurostructures. So, so we have seen a lot of complication related to bone high speed burr when we have shifted our strategy to use the ultrasonic bone cutter. The thermal injury with this ultrasonic bone, it is very less, and it produces very low, less bone dust, and the field also looks very clean here. So this is the way we cut the bone, and it won't damage the underlying neurological structures. So this is once we are done with this disc related case, and we have ventured into the topic discussion. Here the patient with the severe zero canal stenosis, and so we are removing the right sided facet. So with the hypertrophic facet, so we have done the left sided decompression, and we moved on to right side. So here the beauty is that we can use the regular osteotomes. So we can use the regular osteotomy. You can take out the chunk as a bone, complete removal can be done, and you can just visualize both the roots, you see. So the roots are very much free there. So this is what we call the over-top decompression. You can simulate the open surgeries with the endoscopy. This is the beauty of the UB system. And you can venture into the interbody fusion also. Once everything is done, just once remove the inferior facet and remove the superior articular facet of the lower segment. So you will be landing on the disc space, and you prepare the disc, and you do sequential remirroring, and you pack with the bone graft, and so just you can insert whatever the size is, the size cage you can insert. Here is a patient of symptomatic grade 2 listhesis, and we have reduced the listhesis, and we put the cage also here. So just you can simulate the whatever you want to process we do in the open surgeries. That is the more advantageous, and you can slowly we moved on to the cervical disc also. So it's low, the freedom is very less compared to the cervical disc. So here the ligament of flavum is very thin, and not like in a regular lumbar disc space. So you have to land exactly on the facets, and look for the V point, and just do bone work, straddle trimming of the upper lamina and lower lamina. And if you are doing at 5-6 level, you need some pediculotomy also to just visualize the root. Here you cannot retract the root, just you have to go, the most of the discs are usually lies in the axillary portion. Just maneuver and you maneuver it, and you can just take it off the whichever is the extrude disc is there. So this is, so here the problem comes with the depth. You should have an idea how much depth you should go in. So why? Because here you are dealing with the spinal cord, and you cannot retract, you cannot damage the nerve root. So this is how we remove the cervical discs. And my learning curve, so for my suggestion is just you start, if you want to be a UB surgeon, you start with doing lateral recess decompression first, and move on to lumbar discectomy, and you go with the bilateral decompression, and you can plan extra foraminal, and you venture into the T-leaf, and slowly move on to the cervical, and last I would recommend to go with the thoracic region. And you see, all the glitter is not gold. So we have dark episodes also during earlier days of my UV. So we have some complication, and this has come. So you see, the first case is she has 0 degree canal stenosis, and I did not do adequate bony work there. Just I entered into the canal without doing adequate bony work, and without removing the ligament of flavum. That is the result of that. So then we have to open it up and we suture the this one real rent. And the second one is also, you see, so the disc looks very fishy, something like this, looking like some end plate thing or some extrude fragment. We don't know. We have just milked out the this portion, and just we are trying to open it up, just trying to remove the fragment. So suddenly we could notice a small linear tear or the ventral aspect of the dura. So it is a ventral, it is lying more on the ventral aspect, so we could not do anything there. So even luckily the patient is very happy there. So he has no complaints related to that. And this also is the axillary disc. So we didn't do adequate bony work here. So here we try to remove the disc from the axillary region. So we caught the nerve root here. So this is all problem comes with the inadequate body work. Sorry, sir. It's over, I think.
Time.
It's okay. So, thank you.
We request all the speakers to come on to the dais.
Request all the speakers to come on to the dais for a discussion. Basit, Ramesh, Srikant, Abhinandan, Kiran and Suresh.
Sir, Kiran sir, I think you are the secretary of endospine spine. Please, shall we give the choice to the audience to ask questions? Please, any questions from audience?
Good afternoon to respected teachers. So my question to Ramesh sir. Sir, in case of lumbar canal stenosis, after removal of adequate disc, if the symptoms still persist, what will be the immediate step or management in the case of lumbar canal stenosis?
Hello. Yeah, if it is canal stenosis secondary to disc, you mean to say?
Yes, sir. Secondary to disc with neurological claudication. So if after removal of adequate disc, what will be, if the patient persists with similar complications, similar symptoms, sir, what will be the immediate next step? Like we want to go it for MRI again, evaluate and
Basically, we don't take MRI immediately because there is a lot of neural edema. So interpreting the MRI immediately after surgery would be a tremendous task for us.
Yes.
So we give a time, next 3 weeks to 4 weeks, let the neural edema settle, then we take an MRI and reassess. Okay. So that's why when just before taking out the scope, we try to see all the corners. That's what Dr. Kiran was repeatedly saying, pedicle to pedicle decompression, both sides.
Yes, sir.
Ipsilateral, contralateral side. So that's a thing. And since you are saying LCS secondary to disc, yesterday I was operating in Hyderabad.
Yes.
So you have to do opposite side contralateral work adequately. Even you have to retract from opposite side also the root to the ipsilateral side and take out the debulk the disc. It's not only decompression from one side. So definitely you can achieve adequate decompression.
Yes, thank you.
May I?
Ramesh.
May I continue with the? Yes.
Sir,
She
sir.
is looking young buddy into the spine. So, dear, you asked the canal stenosis with the persistence of the neurological claudication, not other symptoms.
Yes, sir.
And you did decompression,
Yes.
posterior decompression.
Yes.
And Dr. Ramesh said about ventral also,
Mm-hmm.
right? If it is ventral ossified, then you have to do just posterior only. Otherwise, rest of the other, as per line of, this is, see, underwater surgical principles, tubular underwater, minimal invasive underwater. So now you think of whether you did the right level. Number one, the question arises, right level. Number two, there is no harm if patient doing kich-kich, better to go for X-ray MRI again, identify and prove yourself. Yes, sir.
Thank you, sir.
Question is, you have asked to whether to give transverse incision or vertical incision. by giving verticalization, it can be converted into open methods. So nowadays, we see laparoscopic surgeons. If they fail, they call general surgeons to intervene because they can't do general surgery. Understood what I'm?
Yes.
So what is that your take? Should we get an expertise in open techniques first?
Yeah,
Before-
definitely, sir. So you should aware of the anatomy and you should know where you are going and you should know the pathology also very much clear. And then only you venture into the endoscopy. So my sincere suggestion is you have to be perfect with the open surgeries, then you can plan for the endoscopy. Otherwise, if you have committed any mistake in the endoscopy, you cannot rectify it.
Sir.
May I?
One more question is there, sir.
Yes, sir. But the thing is, meanwhile, during the curriculum of neuro and ortho, you might have come across 3 years continuously with the anatomy. No doubt, cases may be lower, but anatomy won't differ. Second thing, first year, second year, third year and SRC, you might have gone through it. So there is no some sort of confusion in their mind also that they are not aware of the anatomy. Now what he has done very nicely, the thing is triangulation will take sometimes for beginners half an hour, 1 hour, and even they lose the patience. And that's why he has asked initially you take vertical so that you can convert into MISS. Because they are very well you used to with comfortable with the tubular or MLD also. So that is the why. Otherwise, always you start with 2 pots, start it, do it, check it. Everything you see is, once you land on the flavor, everything is equal. After that, you are the master.
No, actually it's the same question, sir. I mean, I wanted to ask how well versed you should be in spine surgery, like conventional spine surgery, to venture into endoscopy. Because I actually answered well by Suresh. Recently there was one surgery in Singapore, they are trained in robotics. Intraoperatively the robot failed. So those guys who were operating the robotic spine surgery, they didn't know how to operate this the regular conventional way. So they had to, and this is a fact, I mean it's a Globus robot, the Globus people are discussing. So the same thing, I believe if Ramesh or Suresh, anybody can answer. I mean, what is the level of your spine training should be there to venture into endoscopy? If there is any intraoperative or postoperative complications, they
So, sir, what you want to ask is simply, if I am a student of MS Orthopedics, how many years I have to do fellowship to get a fellowship to be competent in endoscopic spine? That is what we want to know. Because see, some fellowships are there for 4 weeks,
Yes, sir.
some are there for 6 months, some are
So-
there for 2 years. So how much time is required?
So it is just you should have minimum of 2 years of fellowship experience before entering into, like if you want to establish yourself as a spine surgeon, you should have at least 2 years of experience working with a surgeon who does good numbers. So if he is doing around 30 to 40 numbers per month, so you'll gain more experience. If you are working with a guy who is doing 10 cases, you won't get anything. So is at least minimum 2 years should be there.
Excellent, sir. Thank you very much.
Yes.
I think
The
we need to-
same thing is, I'll continue with.
Hello.
Yes. Here, at least in observership, or even those who want to do, 1 case in a week compulsory, they should attend, they should do, or they should learn. So, 52 cases, at least they are comfortable at that plateau level. Now they can start with their own complications and then again learn.
Thank you very much, sir.
Sir, one more question. Sir,
I think
how is this endoscope, what is the role for endoscope in revision spine surgery? That I wanted to inquire.
Revision secondary to disc herniation or revision to what?
Revision spine surgery, if a patient has undergone microdiscectomy earlier and he has recurrence of symptoms, then how far is endoscopy useful in recurrent?
100% it is useful if you are expertise in doing either monoportal or biportal, it's up to you. And this is our philosophy. We have been doing it excellently. So if you master it, if you have good eye coordination, if you have better dexterity, the saline irrigation itself will clear the tissue dissection. And you can make out the endoscopic anatomy very well, even it was previously operated by open or microscopy or tubular system.
Sir, are there any chances for this endoscopy being turned into open surgery in a revision spine surgery?
There is always a scope for opening that, but it only the patience of the surgeon. That is more important. So, and how well versed are you with the endoscopic techniques? So, especially in revision surgery, endoscopic is really a boon because there are many gadgets you have like side-firing RF and a flexible RF where you can shrink the tissue and get the anatomy right. Especially in a revision case where there are a lot of adhesions, and also the saline irrigation will give you a plane which is not visible earlier with the normal microscopic field of surgery. So the chances of opening it is always there, but persistence with the procedure, probably you might end up doing the endoscopy normally.
So thank you, sir.
The thing, just a minute, sir, 1 second, sir, don't mind. The other answer for you is most of the open surgeons says that if there is a recurrence, open it, fix it, and forget it. That is their philosophy. But the advantage of endoscopy is you don't require any fixation because you're not going to do a lot of tissue trauma. That's the key. So even with a recurrence, we can 100% address that with the help of endoscopy, whether it is UBE or monoportal.
Sir, the endoscopy is motion preserving surgery, number 1. Number 2, recurrence, the size of recurrence and type of recurrence. We can choose the type of all 3 varieties, transforaminal, monoportal or UBE. You can apply. Everything is less tissue trauma. That based on your dexterity, your choosing your UBE or monoportal. Thank you very much, sir.
I think we will
Thank
end
you.
up this session.
Thank you, audience. Thank you, sir.
Thank you, chairpersons, for doing this program. Thank the speakers. We'll go on to the next session. I request chairpersons to felicitate all the speakers. So let us be quick, sir. I think we are running out of time. Next session will be on basic knee arthroscopy. That's a meniscus session. I request for this session also Dr. D. Maheshwar, our scientific committee chairman and senior surgeon, to come after the felicitation and join this. Next, I request Dr. Rajesh to come and chair this session. I also request Abhiram to chair this session. It's one of their favorite topics actually, arthroscopy, both of them. As far as Osa are concerned, they are the 2 entities whom we consider the giants of arthroscopy. Thank you. Welcome. Hare Krishna. I request Dr. Y. Hare Krishna
Good afternoon, everyone. Now we'll start with the knee arthroscopy session. So first of all, I'd like to welcome all the delegates and the faculty, both state and national faculty, for this knee scientific session of arthroscopy. A special welcome to Dr. Sundarajan sir, current IAS president, for coming all the way from Coimbatore. Thank you so much, sir. We'll start with the first talk. The first talk is by Dr. Naren Subramani. The injury that okay, types of meniscal repair, sorry.
Swaroop.
Sarvesham Shanti Bhavatu.
So good evening everyone. I am Dr. Naren Subramani from Kamani Hospitals, Hyderabad, here to talk about the meniscus repair techniques and which technique to use when. So over the years the meniscus repair has gained the popularity in repairing techniques and as well as the implants to preserve the meniscus as much as possible and to provide a balanced stabilized knee. Why the meniscus repairs has gained so much of popularity is to improve the joint longevity. Always the tears on the red zone or red zone has to be repaired properly, and the technique depends on the tear location, surgeon expertise and the instruments that is available. The first decision whenever we see the meniscus repair is to preserve the meniscus, either providing the stable and balanced knee because it helps in load transmission, increases the cartilage protection over the here, and it improves the stability and the protection of the knee. Based on the repairability always starts with the biology of the meniscus. So based on the amount of blood supply, the meniscus has been broadly divided into three zones: red, white and white zone, where the red zone have a more vascular and it has a good functional outcome following the repair, where the white is almost avascular, where the repair usually goes for meniscectomies. So what is the indications for the repair? Usually it is a peripheral longitudinal tears of less than 3 centimeters, or vertical tears in the vascular zone, and the traumatic tears in young patients. So there are various repair techniques of predominantly being outside in, all inside and inside out technique. This names has come based on the suture settlings inside and outside the joint. The inside out technique, where it has been strongest of all other techniques, usually indicated in case of posterior horn tears and the body of meniscus tears, where the sutures are passed from inside the joint, crosses the capsule and it is tied externally. The disadvantage of the technique is we have to give a separate accessory incision for tying the knot, and there is a chance for neurovascular injuries. Whereas the advantage is it is a strong fixation, cost effective, and it has a proven long term outcome. The inside out technique, inside out repair, has a various zone specific cannulas that facilitate in repairing techniques. The outside in repair, it is usually indicated in case of anterior horn tears and the body tears of the meniscus, where the needle is passed from outside the joint, crosses the capsule inside the joint through the meniscus, and the sutures are shuttled and it is tied internally. The advantage is you can position the suture placement and it is minimal incision is required. The limitation is it is technically limiting and you cannot use it for the posterior horn because of neurovascular injuries. And the all inside being more popular nowadays, the indications are mid body, and you can use it for the posterior horn tears, posterior horn and mid body tears. The arthroscopic device that enters the joint deploys the anchors within the joint itself and the knots are placed. The advantage is minimal invasive, shorter operative time, and the limitations are that implants are costly and the risk of implant related complications are there. So this is a comparative overall outcome between the techniques, where the inside out is for the posterior horn tears and outside in for the anterior horn, and all inside for the body and the posterior horn tears. In case of a complex or revision cases, all inside is preferred, and in case of limited access or a small peripheral tears where the inside out tears are present. So this is one of our patient with 22 years old male with a history of trauma, skid and fall from two-wheeler. On examination, McMurray's was positive for medial meniscus, and on imaging he had a large bucket handle tear on the peripheral zone. We can see a double PCL sign on the sagittal section, and on diagnostic scopy we have a large floating meniscus inside the notch that is flipped inside the notch, and with the help of a probe the meniscus is positioned back to its position following the pie crusting. And once the meniscus is positioned back, we have used a reduction stitch using an outside-in technique where you first pass a needle inside the joint, and we use a Prolin round body, 2 Prolin, and we take it through the, shuttle the Prolin through the anteromedial portal, and we make an additional 1 more Prolin with a spinal needle to make a loop that enters into the joint, and we take the initial first single Prolin, take inside the loop and bring it outside the joint. So once this is done, once the meniscus is positioned in its position, then we can use an all-inside device for positioning the posterior horn tears, where we can use a initial sleeve guide, and then the device enters inside, pierces the meniscus, and then the second bite is on the capsule. We can use horizontal or the vertical mattress based on the comfort. Once it is positioned inside, the device is deployed, and then it is tensioned. And the anchor is tensioned and the knot gets tensioned out. And this can be sequentially done till the body of the repair. And for the anterior horn tears, again we can use an all inside out outside in technique, where you take a Prolin, pass it in below the meniscus, and 1 more Prolin, make a loop and pass it outside the meniscus and take it out. So that's our final repair. And the post-op rehabilitation always depends on what type of tear and associated injuries. For an isolated meniscus tears, it is immobilization for 2 to 3 weeks, followed by gradual range of movement and strengthening exercise, and return to sports for after 4 to 6 months. And the complications are suture failure or the re-tear or the implant migration, or you can have a neurovascular injuries, infection and stiffness. So to conclude, the technique should be selected based on the tear specific and surgeon dependent. A meniscal preservation improves a long-term outcome. A future is a biologic augmentation with a scaffold-assisted healing. I thank my mentor, Dr. Jayaprasad sir, for giving me scope and making me pursue in these techniques. Thank you, sir, and thank Team Tosa and Oasis. Thank you.
Nice presentation, sir. Thank you.
Thank you.
Now I invite Dr. Y. Harikrishna for presentation of root tears, the injury that behaves like bone and bone while the MRI looks almost normal.
So good afternoon everyone, I am Dr. Hari Krishna. I work at Care Hospital, High Tech City. Today I am going to speak about medial meniscus and lateral meniscus root tears. So what is a root tear? So any tear that is close to 1 centimeter within the meniscal attachment of the tibia at the root part is called as root tear. And in young individuals, mostly root tears are traumatic, and in older individuals it is usually a trivial injury or sometimes no injury at all. A typical presentation that we see in our day-to-day practice is a male or a female in late 40s or early 50s with a pre-existing knee pain which is on and off while long walking or taking stairs, and suddenly the pain increases within like after a trivial injury or sometimes no injury. There will be a sudden increase in pain which doesn't subside with any medication, and it keeps on increasing day by day. That is where you have to suspect a meniscal root tear,
and go for MRI. Usually we will be a little hesitant to go for MRI at that age group, but this presentation you should always go for the MRI, because a root tear, if undiagnosed and neglected, will eventually lead, the only option left will be a knee replacement at a very young age. So what do you see in the MRI? The upper two images are of normal knee, and the lower two images are of the root tear. In sagittal sections, we look for something called the ghost sign, where when we follow the meniscus, suddenly the meniscus disappears, right in like in the picture down. So that is called ghost sign, which is pathognomic of a root tear. The other thing that we see is in the coronal sections, where the root attachment, as seen in the upper one, the arrow mark, the root attachment is no longer attached and the meniscus will be freely floating. So what happens after a meniscal root tear? Now the root is no longer attached, so the meniscus starts moving out of the medial compartment, which is something we call as meniscal extrusion. So any meniscus out of the compartment of about more than 2 mm overhang, we call it as meniscus extrusion. This meniscus extrusion now results in a bone-to-bone contact between the femur and the tibia, leading to cartilage pressure and eventually osteoarthritis. So how it behaves after a root tear? So either in the early stages they have simple fraying, they like grade 1, grade 2 chondromalacia. In the late stages they go into grade 3 and sometimes also grade 4 if neglected for too long, where the bone gets exposed. So the classification, Laprade classified this into type 1, the partial tear, where the tear is only at the white or red-white zone. These tears either require a simple meniscectomy or a side-to-side repair. Whereas type 2 is a complete tear. Depending on the site of the tear, how close it to the root, we divide them into 2A, 2B, 2C, which is 0 to 3 mm, 3 to 6 mm and more than 6 mm. Now type 3. Type 3 is a complete root tear along with a bucket handle tear or a meniscocapsular tear. Here we have to repair the root. Along with that we have to repair the bucket handle or the meniscocapsular tear too. And type 4 is an oblique tear, and type 5 is a root avulsion fracture with a bony fragment. Outcome of repair depends on how early you have intervened and depends on the BMI of the patient. So if we intervene within a month, the results are excellent. Up to 3 months are good, they have a good result, but beyond 3 months you have to be sure that the cartilage is good on the MRI and counsel the patient accordingly. And BMI, if the low BMI will obviously have a very good result. If the BMI is high, the chance of recurrence in pain is high. Nevertheless, any root repair will at least postpone the knee replacement for at least 2 years. After 10 years, in most of the studies, it says that 75% of the individuals go for knee replacement. The methods of root repair. There are different methods. The most popular one and most followed one is the pull-out technique. Either it can be a single tunnel, a pull-out, a two tunnel technique, 1 bite, 2 bites, or a tunnel from the anteromedial tibia or a tunnel from the anterolateral tibia. This anterolateral tibial tunnel will be useful when you are going for a H2O, so that the screws will not coalesce with the tunnel. And the fixation on tibia can be by anchor, tensionable buttons or non-tensionable buttons. The diameter of the tunnel has no role in the outcome. Now the other way is suture anchor using a reverse anchor technique or an anchor from the posteromedial portal. An all inside repair where the root is just attached to the PCL and the posteromedial capsule. Now augmentation, it can be done by gracilis tendon. If the root is not so healthy, you can loop the gracilis at the posterior horn level and bring that gracilis into the root tunnel. The other one is medialization anchor, where an anchor is placed at the body of the meniscus, that is at the posteromedial tibia, and the meniscus extrusion is, the meniscus is lateralized. Now lateral meniscus also can have a root tear, but these root tears are mostly traumatic and they are associated with some other tear like ACL. And the prognosis of lateral meniscus tears are very good because the extrusion of meniscus is very less when compared to medial meniscal root tears. So coming to my technique, I use 2 tunnels. So this is how a root tear looks like in the arthroscopy. You can see the root of the posterior root tear of meniscus. The meniscus is getting lifted off from the tibia. Now if the workspace is very low, you can do something called the MCL pie crusting, where with a needle we poke the MCL and as you can see, the joint opens up very beautifully. and you can avoid the cartilage damage. Now bed preparation, so with the help of a ring curate and the shaver, denude the cartilage at the base of that root so that the meniscus is going to get attached to the raw bone. After that, use a meniscal root repair jig and I use 2 tunnels. As you can see, at least leave a gap of about 5 to 6 mm between the 2 tunnels. Then use a first pass mini or a scorpion and take bites and shuttle them with number 2 fiber wire. So I take 2 bites at the level of those tunnels and shuttle them into the tunnels that you have already drilled using a PDS. So this is the final repair. You can see 2 tunnels, 2 fiber wires. So either you can use a small button and fix these fiber wires against the button, or you can as well tie it to each other just without any metal implant. Thank you.
Thank you, sir.
Next speaker would be Dr. V. Jaganmohan Reddy. He'll be speaking about the ramp lesions.
Maheshwar sir, okay to start, sir?
Yes, sir.
Sir, are you giving extra time or no?
No, sir.
Okay, sir.
Please
Thank you.
stick to the time. Thank you.
Okay, sir. Thank you, sir. Thank you for giving this opportunity. Thank you, Sai Fanichandra and Jaiprasad sir, for giving this opportunity. Asked me to talk on the ramp. Actually, Sai Fanichandra has given it message on WhatsApp, sir. Please talk on ramp. Just only one word he has sent. I thought ramp, this is a big auditorium, there is a ramp, how to design the ramp, how to prevent the fall, fractures. I'm thinking about that. I put on ChatGPT, I made a preparation. This morning he said ramp in the knee joint, he said. So again, overnight I prepared, sir, this talk. So ramp lesions, the tear hiding behind the nearly every ACL you reconstruct. We will discuss about the anatomy, classification, diagnosis and biomechanics and operative strategies and outcomes. 42% we miss the ramp lesions. New thing is posteromedial portal to identify the ramp lesions, and you should aim is less than 10% the target failure. This is brief about myself. This is the hidden lesion problem is a quality problem. So what is missed? Usually the peripheral longitudinal tear of the posterior horn of the middle meniscus at the meniscocapsular junction, meniscotibial ligament, and part of the some semimembranosus will form the important structure that prevents the ramp lesion. Why it matters? If you lose the medial meniscus as a secondary restraint, leaves the residual anteroposterior translation and rotational instability, even after if you do a good ACL reconstruction, till you will have a residual laxity, both anteroposterior, especially rotational instability. What changes the practice is a reproducible posteromedial portal to probe it to identify the ramp lesions. So prevalence is, there is a 42% miss of the ramp lesions in any ACL reconstruction, and in a registry also the 15.3%, 84% only the MRI will diagnosis. and 42% are detected by the arthroscopic examination, especially if you put a posteromedial portal. So it starts from 1988 by Strobel to 2024-25. There is modern evidence. There is a good evidence that there is a ramp lesion in ACL injuries. What's the anatomy and pathophysiology is the posterior horn of the medial meniscus. It attaches with the menisco-capsular junction and capsule and MTL, meniscotibial ligament, and part of the semimembranosus also will play a role in the stabilization of the posterior horn of the medial meniscus. It is in the vascular zone, that is a red zone. It's a 5 mm from the capsular junction. So if you miss it, if you give a good fixation, it will heal because abundant vascular supply at this area. So even if you fix it, it will heal definitely. If it's a white zone, even if you fix, sometimes meniscus may fail. So there are the 3-layer structures: posteromedial capsule, menisco-capsular junction, and meniscotibial ligament is important. And how the ramp, once ACL failure, this medial meniscus will drag forward and the capsule and MTL will damage, and the ramp lesion occurs at the menisco-capsular junction. So there are various classification system, Thorne classification, Laparidae morphological classification is partially stable, partially unstable, partially stable on the tibial side, partial stable on the femoral side, complete separation, and complex states. How to diagnose? This is very, very important. If you diagnose, you will treat. If you don't diagnose, we may miss it. So the standard MRI may not give 3 Tesla also with a 30 degree of flexion position. It may recognize up to 85%, but 15% still we will miss in the MRI. And you will have some fluid interpretation and posteromedial tibial bone bruises, and you will have a junctional signal. And very, very important is you probe with the arthroscope. So normally you do a standard anteromedial portal, anterolateral portal. You try to push your scope between the PCL and middle femoral condyle, go and see. And usually if you are there, you use a posteromedial portal, weaving portal, and then you probe with it and assess the menisco-capsular integrity and check for the posterior horn of the medial meniscus. Is there any ramp lesion is there or not? Once is there, you classify, document, and your treatment depends upon the type of ramp lesion. So what are the risk profile is male sex, younger age groups, revision ACLRs, and if the patient already got a lateral meniscal tear, very high risk, high chances of ramp lesion. With the patient got a high grade pivot shift, there is a high suspicion of ramp lesion. High ACL remnant, there is one MCL injury is the one you should suspect about the ramp lesion. The biomechanics wise, you should need to ACL deficit, ACL with a ramp, ACLR only, ACLR plus repair. So what are the consequences if you leave the ramp lesion without addressing? You will have a residual apilaxity, rotational instability, you will have a constant overload on your graft that will cause the premature failure of the graft, and you will have a cartilage damage with this. So what are the surgical techniques? Depend upon the ramp thing. First you classify the ramp before repair, and if it is stable, you ignore it. You can do a small triphony. Anyhow, you are doing the ACLR that generates a lot of tissue promotion that will heal, and repair with ACLR and use a vertical mattress. That is a very good repair for that. Algorithm is posteromedial portal, stable, leave it, or triphony things. Unstable, you repair it. If it is a grade 4 and grade 5, you should consider extra procedures like lateral extraarticular tenodesis, either Laparidae procedure or repair of the ALL should be considered. So all inside technique is the one: identify, confirm, prepare the bed, pass the device, and fixation. You can use the hook repair. In a complex tear, don't hesitate to put additional posterolateral portal. Posterolateral portal used as a weaving portal, and posteromedial is a working portal. So outcomes and failures is the good outcome. If you repair the ACL along with the ramp, you will have a good outcome of LISHOM and IKDC score. And the failure analysis, they compared, if you don't repair, there's a very high chance of failure. Should every ramp requires a lateral extra-articular tenodesis like LET procedure or ALL repair? No, not required. If it is a high suspicion, type 3, type 4 ramp lesions, you consider for LEP. And protocol should be pre-op, MRI should be there, and look for the post-medial corner injuries. Intraoperative, you assess carefully. Post-operative, no flexion, not more than 90, and partial weight bearing, and you should audit yourself. What has changed recently? Post-medial portal has added along with the ACL reconstruction, classify the tear, repair the unstable patterns, consider for LEP in high ramp lesions, and you should audit your outcomes. These are the key evidence. Thank you, sir.
A nice time, very exactly. And
time is okay, sir.
Okay, super, very nice.
Perfect, very nice.
Very perfect. And may I call upon Dr. Satish K.
Sir, next Oasiscon in 2027 in Hyderabad, sir. Dates
Yes,
and
sir.
venue will be communicated soon. Thank you, sir.
You all the best. Satish K. Speaking on repair, resect or rehabilitate.
Yeah, good evening all. I am the another student of Dr. Jayaprasad. At the outset, I thanks my friends Dr. Hari and Fani for giving me this opportunity. My duty is to conclude the previous talks. So I am Dr. K. Satish Kumar from Medicover Hospital, Secunderabad. What exactly is a degenerative meniscus? A meniscus of approximately more than 40 years of age with no cellularity is called a degenerative meniscus, and that is prone for a tear. Now we are going to see, we will just check how the treatment will be for degenerative meniscus. It's not good. Okay. The evolution was like that. The 6 decades ago, there was the only treatment option was to remove the meniscus, the meniscectomy. And in 1982, after removing the meniscus, they thought that it's a very important structure, and removing the meniscus will lead to cartilage degeneration and osteoarthritis. So they come to partial meniscectomy was alternative to complete meniscectomy. And in 1989, the first allograft or meniscal transplant was done after knowing the importance of the meniscus. But the current prevailing trend is repairing meniscus is related to maintaining the tissue intactness, because the meniscus is a important structure in maintaining the knee homogeneity. So now it is a time for a paradigm shift for the meniscal repair, because meniscus is being very important structure. And but sometimes after doing the arthroscopy, after doing so many times, may not be possible. Now we will see the efforts, how they are going, how many efforts we can put to keep the meniscus intact. Now it is an established fact that if the meniscus is removed, it will lead to osteoarthritis. And at all events, a degenerative meniscus lesion points to an osteoarthritic knee or at least an elevated risk of osteoarthritis. That is why meniscus has to be kept inside wherever it is possible. But the success depends upon the age of the patient and age of the tear. How or later the patient has come and consulted the consultant, and the experience of the surgeon. The surgeon's experience is also important in bringing the good result for a meniscal tear repair success. And the type of the tear and zone, it is red zone or red white zone or white zone,
and the technique what you are going to use. If you triangulate the meniscus keeping the sutures intact, the blood supply may be lost. And the use of orthobiologics and the practical experience, how many meniscus tears you have repaired, and patient compliance. If the patient doesn't follow your efforts and if he doesn't complement your efforts, it's going to fail. So the main important is patient compliance. And the treatment options are categorized into two, the operative and non-operative. We have so many non-operative methods, like we have discussed. The operative treatment is arthroscopy, and the efforts is cytokine expression after rasping the meniscal tear zone. That helped the meniscal healing, but it is an experimental stage, but it's a good evidence. And another thing is to put a interpositional free synovial autograft. This also helped, but done in rabbits, not in humans. And another thing is meniscal root tears. The Delphi consensus has proved that meniscal root has to be repaired, and they could not come to a conclusion on the asymptomatic tears. And some people have tried asymptomatic tears with exercise therapy. They also got very good result. And meniscal root tears, it's an established fact that if they are asymptomatic, if the patient is young, to prevent the further osteoarthritis, we have to repair them. And some people tried exercise program, they also got good result. And conservative treatment, if we structure the program and if we tailor-made the program, if we customize the program for some tears, it is a very good, it gives very good result. And meniscectomy sometimes is not good. Most of the times meniscectomy may not be helpful. That is why while doing a meniscectomy, we should be careful regarding the lesion and the type of the tear. If it is a degenerative meniscal posterior root tear and not repairable, then we can excise it. Otherwise, we should put all our efforts to keep the meniscus intact. And use of the orthobiologics. Because meniscus being an important structure, we can use our augments like BMAC or stem cells or PRP. It gives a very promising result. And to conclude, if the meniscus tear is less than 1 month, if the patient is young, you have to treat conservatively. If the patient is symptomatic, to check for osteoarthritis, you can go for X-rays. And after 3 months of treatment, if the symptomatic, you can go for MRI. If the MRI shows that meniscal tear has healed and if the treatment is success, you should not intervene, then you can go for meniscectomy, a partial or repair or whatever is required. But in conclusion, meniscus takes the entire load of the knee joint and it should be kept intact as much as possible with the possible technique you know, and you have to use orthobiologics to save the meniscus. Thank you.
Good talk, Dr. Satish. Next, the talks are going to be the ACL, getting the commonest reconstruction right. Our first speaker is Dr. G. Shashikant sir, graft choice in 2026, matching the graft to the patient, not to the surgeon's habit. We welcome you, sir. Please present your talk.
Yeah, thank you. Thank you, Team Tosacon. Thank you, Hari, for the invite. Yeah, it's very apt for us to proceed on from meniscus to ACL. I mean, as arthroscopy surgeons, we all know that meniscus is the most important structure which has been delivered in the talks by the previous speakers. And next we go on to ACL, which is probably the other important structure in the knee. And yeah, so my talk will be going to be on a very simple talk. It's going to be graft choices, which has always been a matter of discussion. I mean, by and large, as arthroscopy surgeons and with the type of training we have, I mean, hamstrings have been the workhorse for ACL reconstruction. And BTP was the gold standard to start with, but of late, hamstrings have taken over, and by and large, most of us use hamstrings. But there are instances where we have to change our graft choice. So at the end of the talk, if I can probably deliver that message, I think it will be good. So graft choices in ACL in 2026. So what is an ideal graft? What are the different graft options that are available? A review of literature and conclude is what I'm going to talk on. So an ideal graft, obviously all we know is one which probably recreates the natural graft. I mean, why do we need to know about ACL surgery? Because as we know, it's very common surgery done, and there are failure rates estimated between 10 to 15, and one of the common reasons is the graft choice. So, I mean, these are the different variables which we look for in ACL reconstruction to speak about the success. We know graft fixation and tunnel placement are very important, but graft selection also is an important thing. An ideal graft is something which probably mimics the natural grafts in every way by its structure, biomechanics, minimal donor site morbidity, and be cost effective. If some grafts satisfies all these criteria, then it's called an ideal graft, but unfortunately we don't have an ideal graft because most of them do have some shortcomings. So yeah, whenever we talk about ACL, we always talk about which graft for which patient. Obviously, these are some aspects which we need to probably keep in mind. And these are the different criteria which we look for. What is the age of the patient, whether the patient is skeletally mature or not, what is his pre-injury occupation level, what is his sporting activities we do, what are the donor side priorities he has, and has he got any previous surgery, or is it a primary or revision? So these are the things which we usually look around when we talk about the graft. And 10 basic questions I usually ask myself, or people should ask before going for an ACL, rather than just taking a hamstrings for every ACL. Look for the age of the patient, what is his, whether it's skeletally mature or not, what is the sporting activity he does, whether he has what is his, does he have any kneeling requirements as per his occupation, what are the patient's priorities. So this is what we should be looking for rather than just going for a hamstring every time. So the bottom line is the graft selection starts with the consultation time. Unless you take a good history and probably spend some time on all these things, we won't be able to make a decision on the type of graft which the patient needs. So yeah, I mean, why does graft choice matter? Because it gives good stability both in anteroposterior direction and rotational control, and obviously quicker return to work is something which people usually ask for. And the graft choice depends on a lot of factors. Most important thing is surgeon's experience. As I said, most of our training will be on hamstring harvesting, so most of us by and large by default choose hamstrings as the graft. Patient activity, prior surgery, patient preference also should be given a choice. So the different types of grafts which we use, as you all know, autografts and allografts as the main broad classification which we use. Going through individual grafts. So BTB has been the workhorse before for ACL reconstruction, but of late people have moved out of BTB. But even now BTB is a good graft in selected situations, especially in young patients with high demand activities who are wanting to return to sports a bit early. This is most important. The main advantage is, as you all know, because with the BTB there is a good bone-to-bone healing, and it has a good clinical record, and it's a standard gold standard for ACL reconstruction even now. But unfortunately people do have a big scar over the front of the knee, especially in people who have kneeling activities to do. This is more of a discomfort, and sometimes people, if they're very careless about taking the graft, people can have patellar fractures as well. And graft tunnel mismatch is one other side effect, or probably. So BTB harvest, it's standard harvesting incision in the front of the knee. People can do with the smaller incisions, moving with the retractions going proximally and distally, and we take about 2.5 centimeters of bone plug on either sides. Use a good technique to take it out while harvesting. So second one, as we said, is the workhorse is a hamstring autograft, which is a familiar graft for everyone. Most important thing is versatile, no anterior knee pain morbidity as we talked about. But the main drawbacks are because it comes in different diameters, especially in females. Usually the graft diameter is going to be the issue. Sometimes if you are not very careful, saphenous nerve injury, and long-term soft tissue graft usually cause tunnel widening because of the wind viper effect. So standard technique which we all use, transfer longitudinal incision, take out both the, either you use a semi-T or a gracilis depending upon the technique you use. If you are using an all-inside technique, and if you can get 8.5 mm diameter, you can use only the semi-T. And the third graft which we commonly used is a quadriceps tendon graft. Obviously, this is also becoming more popular because of its large cross-sectional area. And quadriceps tendon weakness is one side effect or probably the trade-off we need to, but it is becoming more like a regular graft. It can be used as a full thickness graft using the Quad Pro, which we can use, or you can use a partial thickness graft and roll it and use it as a regular graft. So this is also coming up, or people are using it more regularly. So the fourth graft which we commonly use is a peroneal longus graft. Obviously, weakness of eversion is one common drawback which people talk about, but there are no long-term studies to say that there is a weakness on eversion with the peroneus longus, predominantly used in revision scenarios, and I don't use it as a primary situation, but revision scenarios it's quite useful, and in multi-ligament situation. Next slide. So allografts which are not very commonly used, I'll probably skip through this, not very commonly used in India because we don't have many of allografts. Synthetic grafts are something which have come up. The common one which we talk about is the jewel graft, which is people are using it on its own or along with the natural grafts. It has its own benefits. But one common side effects with these artificial grafts is the synovitis which they can cause, so not commonly used. In skeletally mature patient, you have to be aware that the physis is aware and choose your technique and graft accordingly. So we have high risk ACL patients for which ACL graft may not be sufficient and probably you need to add additional stabilization as well. That is one thing which you always have to keep in mind. So you have to identify that high risk ACL patient with these things, high pivoting, sports, generalized laxity. So whenever you do an ACL, obviously if you probably leave the graft less than 8 millimeters, there is a risk of revision and all those things. So accelerated rehabilitation. So other talk will be on LET. I think Dr. Jayaprasad will cover this. I'm not going to talk much about it. So what does the current evidence say? Even in 2026, the RCT meta-analysis says quadriceps, hamstrings and BTB have comparably good clinical outcomes. There is no universal winner as far as the graft is concerned. Donor set morbidities usually differ. So yeah, use the graft according to the type of patient you are going to see. So the take home message I would say is obviously the strongest graft is not necessarily the best graft, and the best graft is the one which gives the patient the best balance of stability, function, donor set, limited donor set morbidity and future options. Thank you.
Very well presented, Dr. Shashikant sir, within short period of time. Now the talk is by Dr. T. Hari Prakash. The tunnel decides everything. Anatomic placement made simple without the jargon. You can present your talk, sir.
Yes. Good afternoon, everyone. Thank you so much, Tosa and Oasiscon, for giving us this opportunity to conduct this scientific session of the arthroscopy. I'm going to talk about the tunnel position after Dr. Shashikant sir has talking about the graphs. Let's see how well we can put that so that we don't have failures. So the most important thing is there are about approximately 8 lakhs to 10 lakhs ACL surgeries that happen in a year. Most of them happening in the US, followed by Europe and Australia. It's very common in young adults, we all know that, and the females has a higher rate of ACL rupture compared to their male counterparts. But the most important thing we need to understand is the failure rate is about 6 to 7%. That's about out of every 100 ACLs that we are doing, about 7% are failing. And the single most common factor that they have identified for the failure is technical or the surgical error. Second cause is the traumatic re-injury. So out of the surgical error, the most common reason is the tunnel malposition. In the tunnel, the femoral tunnel malposition is the most important thing. That is the reason for the revision ACL. The other causes being the recurrent trauma, which constitutes about 15 to 25%, and unaddressed instabilities like PLC or the meniscal root tears or the high tibial slope, and the biological failure is mainly because of infection and also poor graft integration or ligamentization. So timing of failure, if it is failing early within less than 3 months, it is mainly because of the infection. If it is a mid-term failure between about 3 to 12 months, it is because mainly again of the technical errors or premature return to the sport, and the late failures are mainly because of the new trauma. So let's see what are the learning objectives we can take from this talk. We are going to see the anatomy and biomechanics and how to put the tunnel in a right position, and what are the surgical techniques and complications and revision algorithms. So we all know initially it's the Weber brothers in their book they have published about the ACL, and they have told that the ACL has two bundles, anteromedial and the posterolateral bundle. We know the functions of it. The anteromedial tightens in flexion and the posterolateral always tightens in the extension. So the ACL footprint of the femur, it measures about 11 to 18 mm, and the tibial footprint measures about 14 to 20 mm. So that's about 113 millimeters square for the native ACL footprint of the femur and about 136 for the tibia. So what are the key anatomical landmarks while putting the tunnel? The lateral intercondylar ridge, or the residence ridge we always call. So it defines the anterior boundary of the femoral ACL footprint. And the lateral bifurcate ridge, it separates both the anteromedial and the posterolateral bundle footprints on the medial wall. When coming to the tibia, the landmarks are the anterior horn of the lateral meniscus and the medial tibial spine, and also the posterior cruciate ligament. These are the things that we use while putting the tunnels. It's about the biomechanics. We know the ACL gives about, it mainly acts as a resistant to the anterior tibial displacement at 30 degrees of flexion, and also it acts as a secondary restraint while limiting the internal rotation. And also pivot shift phenomena, the dynamic subluxation of the lateral tibioplateau about 20 to 30 degrees flexion under combined internal rotation and valgus stress is the pivot shift phenomena. It prevents that. So whenever we have an ACL tear, we check for all these things. So we'll see the femoral tunnel positioning now. According to the Bernard and Hertel grid assessment, when they have measured it on the 3D CT scan, they have decided, from the Blumensight line, it represents the superior border of the grid on 5 to 10 on the strict lateral X-ray or 3D CT. And they have classified from deep to shallow and also high to low. From the deep to shallow, the center we should be targeting around 24.8% to 28.5%. And high to low about 28.3 to 33%. But it is technically very difficult to calculate these numbers while doing the surgery. So let's see how we can get it easily. What happens if we put it more vertically? In the coronal plane, again a vertical graft almost purely parallel to the long axis of the femur, it causes loss of movement arm and excessive cartilage loads, eventually leading to the failure. So the other way of assessing is like, we do a transtibial drilling and anteromedial portal drilling. Nowadays, most of us, we do a anteromedial portal drilling only, but by doing with the transtibial, the tunnel would be very vertical and it can again cause to failure. So what are the problems? Vertical tunnel, it always leads to failure. So non-isometric position also, it can lead to failure, and also there is a risk of condylar injury and graft injury if it is not placed properly. So it is always better to put it through the anteromedial portal. And nowadays we are using the far anteromedial portal as well, which is usually even more anatomic while putting the femoral tunnel. So it is in line with the femoral tunnel, that's what we usually call. For the tibial tunnel positioning, so again, as I said, the main landmarks are the lateral meniscus posterior border and also PCL and in between the two tibial spines. So the direction again, in the sagittal, it should be about 42 to 48% anterior to the posterior, and in the coronal, it's about 46 to 48%. If the tibial guide set at 55 degrees to the long axis of tibia, it creates sufficient tunnel length. In the coronal line, the drilled starting halfway between the anterior tibial tubercle and the medial collateral ligament. So there is something called an outside-in drilling as well. The advantages is with the outside drilling, you can exactly put it at the point where you want to drill. But the disadvantage with this, you have to put an extra lateral skin incision. There is a risk of always a peroneal nerve. And comparative study they have done on all types of drilling, and they found out actually the outside in drilling is to be more accurate in terms of tunnel placement compared to the transtibial anteromedial types of drilling. Next, so what should be the modern ACL reconstruction should focus on? Anatomical footprint restoration, appropriate graft selection, secure fixation, and patient-specific rehabilitation, and risk-stratified augmentation when appropriate. So what happens when the malposition happens, the complications? So the graft wear. So continuous mechanical friction against the intercondylar roof leads to always the shredding of the graft. There can always be a cyclops lesion if it is placed anteriorly, and we have to excise the cyclops if there is a cyclops lesion. And there could, if from the femoral tunnel point of view, there can always be a femoral wall blowout, and from the tibial side, we can always have a tibial widening during, like for the reasons for that, it could be seepage of fluid into the tunnel, or it can be because of the inflammatory cytokine response. So we'll just go through the videos of how we do it. So first, we try to, if there is a complete ACL tear, we try to shave off the complete, debris there, and then we can use a RF as well to clear the, condyle, and we can use the farm, as described, we can use the far medial portal to identify the exact location of the ACL footprint. Then we can take out this, with the help of a scoop, we can completely denude the bone so that it will have good ligamentization. Then we can either use a zig or we can directly put it without the use of zig. We always prefer to use offset zig. Then with your 4 mm reamer, you completely drill through the condyle and identify the length of the condyle, which is usually around 35 to 38 mm, could be around 40 mm in males as well. Then we ream with the necessary reamer of your graft size, whether it could be 8 or 8.5, which is the minimum diameter that is required for a good ACL reconstruction. Then after reaming, we should completely clear out the debris to prevent the arthrofibrosis, or else they can lead to stiffness. On the tibial side, again, we can use two types of zig, either an elbow kind of an aimer or a round aimer. Here I am doing an all inside technique. So identifying my bony landmarks, I try to get exactly at the center of it. And I can do a retrograde drilling or an antegrowth drilling depending upon whether you're doing an all inside or screw fixation. So what should be the ideal tunnel position? It should always replicate the most isometric fibers within the native ACL. It be localized on the direct fibers of the ACL, and it should be equidistant from the bottom and top of the notch with a tunnel back wall that is 1 mm thick and eccentrically located high and deep within the footprint, and should be anatomic in that ACL graft within the native ACL origin, and also achieve a low tension flexion pattern in the ACL that replicates the tension flexion behavior of the native ACL. There are a couple of papers which says using a C-arm actually gets your tunnel position accurately 6 to 8 times better than without using the C-arm. Thank you.
Nice talk, Dr. Hari Prakash sir. Next talk is by Dr. Jayaprasad sir. Does every ACL need a lateral tenodesis? Separating the hype from the evidence. You can start, sir.
So good afternoon, everyone. I would like to thank Oasis and Tosa for inviting me, especially Dr. Hari and Funny. My topic is on does every ACL need a lateral extraarticular tenodesis? Is it a hype or any evidence is there? I am Dr. Jayaprasad. I am head of arthroscopy, sports medicine and robotic arthroplasty unit in Kamneni, LB Nagar, Hyderabad. It's not working. It's not working. So our aim in ACL reconstruction is to provide the anterior posterior stability as well as rotational stability. If you look at our ACL reconstruction procedure techniques, the conventional intra-articular procedure for ACL like anterior tibial transtibial technique or double bundle technique or anatomic single bundle technique, these doesn't really provide the rotational stability. Why we need the rotational stability? Because what are the important structures which gets injured at the time of ACL injury? So ACL is most vulnerable when the knee experiences the valgus load, internal rotation of the tibia and anterior tibial translation in near extension. So most of these mechanisms, non-contact mechanism or indirect contact mechanism or direct contact mechanism, in this the pivoting activity which makes the ACL and the ALC, anterolateral complex, so which is a very important component of the ACL and ALC injuries which are to be remembered when you are doing the ACL reconstruction. So what are the components? When ACL is deficient, you will have the anterior tibial translation loss or restraint loss. When ALC injury, there is loss of secondary restraint to the internal rotation. So what are the different components we have, we need to address when you are doing ACL reconstruction? This is anterior lateral ligament, one is Kaplan fibers, and iliotibial band and the capsule. These are the 4 or 5 structures which are important to stabilize the rotation of the knee joint. So which can be expressed as a pivot shift when you are doing the examination. ALL injury is the most common associated injury with the ACL. Most of the studies says that 80 to 90%, and most of these are the pivot, non-contact. So non-contact is around 75 to 80%. In that 80 to 90% the ALL injury. So you need to, so for every ACL is you need to suspect the ALL injury to not to have the failure of the ACL. So Kaplan fibers and ALL and the capsulo-osseous ITB, these are the most important components your the ALC. So what ALL does is the internal rotation, it restrains internal rotation at near extension, and the Kaplan fiber is very important and controls the internal rotation in the mid flexion. Both together gives the rotational stability in the complete range. So these are the procedure, Ellison, Lemare, McInish procedure. This gives this addresses the or recreates the function of the Kaplan fibers and the ALL. If you look at this paper exploring the high re-injury rate in younger patients undergoing the ACL injuries, ACL graft rupture is around 16 to as Hari told is 6 or 7%, but younger individuals is 16% in a 2 years post-op. Gender more in males. High risk patients is less than 18%, 18 years age. So this is one of the stability study done by the Alan Getgood, very recent in 2023 AJSM paper, shows there is a re-rupture reduction is a 4% or the 40% of reduction when you combine with the LET with the ACL. So this, not only reduction of the ACL failure, there is additional 40% reduction in overall satisfaction and high return to the sport in this patient who has the LET with the ACL. So this paper case history shows that ACL is not an isolated ACL. There will be 63% of the ALC complex will be there, especially the Kaplan fibers and the ALL. So again, this is the paper again, female soccer players, there is significant higher risk in second ACL injury compared to their athletic peers. So what are the benefits of ALL reconstructions? The clinical impacts are the reduced pivot shift, lowers the graft failure and prevents the residual instability, better functional outcomes and safer return to sports, enhance the graft survival. So decision for adding LET with evidence is when patient has a pivot shift positive, patient who has less than 25 years, pivoting cutting activity athletes and generalized ligamentous laxity or the hyperextension, pivot shift injury mechanism, and the patient who has a second fracture, lateral meniscal root tear, ramp lesions, and revision ACLs, they were important, and smaller graft, less than 8 mm, desired for early return to sport. So how it happened, the LET has come into oak is in the 1950s, this was a standalone procedure for the ACL. The pioneer was Limer, 1967. Then there were multiple modification, and there is a LET fallout in 1990 because of the anatomical ACL reconstruction. Then these are the different procedures. The most trusted technique is the modified Limer, because it is isometric point of the insertion on the femur, and it rerouted under the LCL acts like a sling. It gives a more rotational stability than the other procedures, most predictable LT procedure and widely used procedure. And so, as I told, it declined because people thought that is a non-anatomical mechanics and risk of over-tightening on the lateral compartment. So always the modern research revisited this one. If you look at this picture, in 1930s, the Empire State Building was built by the iron workers without any the safety measures. They climbed 850 feet and done the Empire State Building with in a less than 2 years of period. So if you look at the past, and these people has revisited why the ACL has failed. So there was a persistent shift after ACL, high risk athlete pivoting sports. They had the again re-tears, and the revision ACLs which was done again re-tears. So increased slopes, that is another factor which was had a re-tears, and young and hyperlax patients but has a re-tear. So that is the reason the people added the LET as evidence procedure, additional procedure. So this is a modified Limer plus one of my patient. We need to take this is a revision case. You need to take the 1 centimeter width, and it's an 8 to 10 centimeter of length of LET, keeping the attachment of Gudis-Tubal area, and then identifying the lateral epicondyle, and the settling sutures under the LCL, and amputating the proximal part of the ITB, and suturing on the proximal part, and reshuttling under the LET, and fixing on the isometric point on the lateral part of the femur, just posterior and superior part of the lateral epicondyle. So that is the end of my procedure. So take home message is it lowers the graft failure around 50% in high risk groups, especially in less than 25 years of age. Improved pivot shift control, better subjective stability and confidence, higher return to sports, essential adjuvant in revision surgeries. Thank you so much. So I would like to welcome Tosa 2027. Thank you.
It's a very nice presentation, sir. Thank you. I request Dr. Sridhar Gangavarapu sir to present why ACL reconstructions fail, reading the warning signs long before the re-tear.
Very good afternoon, everyone. And first of all, I would like to thank the Tosa and Oasiscon, and particularly Dr. Saifani and Hari for hosting such a wonderful arthroscopy session in this South Indian meeting. So I'm going to speak about why ACL reconstruction fails and what are the warning signs. So you should recognize before you let it fail. So if you see, mostly the success rate is profoundly increasing as such as a failure rate because lot of ACLs being done across the globe. So 75 to 97% of the satisfactory outcomes which are seen in the primary ACL has come down to only 76% if you are revising the ACL. And most of these primary ACLs which fail, 10 to 15% they undergo the revision surgery. So what defines as an ACL reconstruction? If a patient has a persistent instability or persistent pain or persistent stiffness, so any of these categories which are persistently present in these patients after the primary ACL reconstruction, so you take it granted as it's a failed ACL reconstruction. So by instability you can define it if the laxity is more than 6 mm anterior tibial translation with a pivot grade 2 or 3, or if the laxity in the coronal plane around more than 3 mm, or if KT 1000 displacement shows around more than 10 mm, you feel it's a failed ACL reconstruction. So what can be the etiological categories of these ACL failures? One can be instability, which can be an abnormal mechanical loads, non-anatomical tunnel placement, the earlier speaker has exuberantly told about that, missing some of the associated injuries or failure to fix it, the graft or proper selection of the graft. There can be a miscommunication to the patient or not doing proper physio, may lead to a stiffness, and some pre-existing patellofemoral arthritis or tibiofemoral arthritis which would have missed in this primary ACL causing persistent pain in the post-operative period. So if you see what are the causes of the ACL reconstruction failure as such, you have a panel of events which causes these failures, but most importantly it's the 30 to 40% of failures caused because of the technical errors. So that's what we are looking basically, because that is the technical aspects which the surgeon can take care and try to improve much better and try to avoid it in our future ACL reconstructions. And 40% of these patients have a traumatic tears which we could not avoid because it can be a re-tear because of the sports injury or a road traffic accidents. But what worries us is the biological failure. So around 10 to 11% of these patients have biological failures, the reasons of which we usually don't know or undetectable. That's what worries us. So where we keep on looking what could be the failure of these patients. And some of these patients have a combination of risk factors which is around 10 to 25%, and some may around 8 to 10%, the reason unknown in the post-operative period and may not be a suitable candidate to revise again. So when you are planning preoperatively in these patients, especially you need to have the complete data of the primary ACL reconstruction surgery, where it is done, what implants were used, what graft, and what is the reason for the failure. You have to thoroughly examine these patients to see any other associated injuries which are missed in the early primary ACL surgery. And imaging, so if you have any doubt, definitely it's mandatory to image by an MRI or a CT based imaging, and also have to consider the technical factors. So there is a Mars cohort study where they have found out in more than 460 revised patients that they have a lot of causes, as I said earlier, traumatic causes, technical causes, biological causes, which is leading to the failure. So if you see the recurrent instability, which is the most common mode of failure, the instability which in 6 months may be our technical error because of different factors. But usually if it is more than 6 months, it may be because of a re-injury or a re-tear, or there can be a chronic repeated micro-trauma which may be missing in the early phase. If you see what are the different causes, we can attribute to different 5 shades with that. So abnormal mechanical loads, non-anatomical femoral or tibial tunnel placement, misdiagnosed injuries in the index surgery, graft failures, or improper graft selection. So if we see the data here, the graft strength as such is only 30% in the reconstructed ACL surgeries compared to a native ACL at the end of 1 year study, and the graft resistance is only 50%. So even at end of 1 year, you don't get 100% of the graft strength compared to a native ACL, even if you what good reconstruction you have done. So in a non-anatomical tunnel placement, that's the most common technical error which is being evaluated as a cause for these primary ACL reconstruction failures, and 20 to 80% of these are failures if you take that, and in that again 2/3 is because of tunnel failure, so not doing a proper or ideal tunnel placement, and among these tunnels 2/3 is because of the femoral tunnel placement which is being placed wrong. So femoral tunnel errors, it can be anterior or posterior. So tibial can be anterior or posterior, this is already discussed. So this coronal plane errors where you can keep your tunnel placement and graft in a wrong position and what impact it can have is shown clearly. I am not explaining that. So about the single bundle and double bundle, so is the anatomy, does it matter? There are a lot of papers you have given that most of these methods are closely similar, but the double bundle do have a rotatory stability or a functional stability at long-term studies, but this causes much trouble if you are an younger surgeon or an arthroscopy surgeon at your starting of the career, because you have lot of issues if you are doing that, because you may be technically very much demanding. You need more tunnel placement, so more chances of making mistake, and you don't know what fascicles or the bundles which need to be tensioned in which part of the ROM, and there is always a risk of bony bridge fracture, and in case of narrow notches or small incisions, you need to abandon the procedure. And if you are revising this double bundle, it goes to be a much complicated procedure. So missing other concomitant injuries very common, more than 15% of these cases fail because you may miss some other concomitant injury. So if his MCL is missed, the chances of failure is around 30%. If posterolateral corner, it can go up to 15%. And if there is a multi-ligament injury with the PCL, you may need to do a stage procedure. So graft fixation itself is also a very important. Too little tension can cause a residual instability. If you are tensioning too much, it can increase the articular pressure and cause an osteoarthritis. So different graphs, how the failure rates is depicted here, and autograft to allograft, they have their own pros and cons, and allografts have the cost limitation. Infection rate is around 0.5 to 1%, which needs to be taken care. And always we should keep our mind in the ligamentization, which usually happens around 4 to 5 months, and where the high chances of failure, and you need to take care of the patient rehab in this period. So there can be a primary arthrofibrosis, a secondary arthrofibrosis, sometimes can be a cyclops lesion which needs to be managed, and there can be a patellofemoral pain which is neglected in the index surgery, and still the patient was done a BPT which leads to a failure, and sometimes the patients may have a concomitant bruises on the tibiofemoral aspect that can cause a postoperative tibiofemoral arthritis, and some of the residual meniscal tears or a meniscectomy can cause arthritis in the postoperative period, and that may lead to failure. And the revision surgeries as such is not as good as a primary surgery. The key to success is you need to identify what is the correct cause of the failure. Ideal anatomical footprint positioning is very important. Careful and proper management of the hardware is very much important, and the rehab should be individualized and customized for each patient. Thank you. Thank you so much.
Nice talk, sir. Dr. Sridhar, sir. Next, we are continuing the session.
Now it is an advanced knee arthroscopy. May I call upon Dr. Sridhar Paredupaka. He will talk on the knee that dislocated and relocated before arrival. Don't miss the artery.
Can you? Hello everyone. I thank at the outset, I would like to thank Tosa, I would like to thank Sai Fani sir, Hari sir for having me here. So the knee that dislocated and relocated. So in the context, I think we are talking about multiligamentous knee injuries and how to assess them, how to not miss a vascular insult when there is a knee dislocation, right? So all multiligamentous injuries, it is basically a knee that has come out and gone back in. And the emergency, when we see the patient, maybe the knee is relocated, but always have a suspicion that it is a relocation from a dislocation. The Schenck MLKI or a multiligamentous knee injury classification classifies into KD 1, 2, 3 and 4. Always remember a KD 3L subtype of a multiligamentous knee injury has a high propensity for a PLC and peroneal nerve injuries. So by definition, a multiligamentous knee injury is 2 out of the 4 major ligamentous complex. So if you take tibia fracture, femur fracture, neck injury, head injury, all orthopedic injuries per se, it is 0.02%. So that is how rare these multiligamentous knee injuries are, right? So most of them are knee dislocations that have relocated even before you could examine them. So once there is an AP view like that, the X-ray technician should be trained to alert the consultant, right? Even before you take a lateral view, the knee has to be reduced. So the X-ray technicians have to be trained to alert that particular consultant that he's seeing something very, very weird. So it has to be reduced even before you take a lateral view, because these are real emergencies. You cannot sit in the OP and see neck pain and back pain while patients like these with knee dislocations come to the emergency. So why these injuries are devastating? Because there's a lot of vascular insult propensity, lot of nerve injuries. There is still no consensus when to operate, when not to operate, what to repair, what to reconstruct, right? That's why this talk is of significant importance, right? So there's a high energy injuries, motor vehicle accident. We've seen big sports athletes who've underwent complex multiligamentous knee reconstructions and back in their game after all that hard work and rehab. But it also can happen in an ultra low velocity injury in a morbidly obese patient. A simple hyperextension injury can tear the PCL and the PLC, right? So why is this dislocation very important, right? Because patients with a documented knee dislocation can have worse PROMs, the patient reported outcome measures. They have a higher propensity and incidence of a vascular injury, which is 45%. And a KD3L, like we discussed, has a high incidence of a nerve injury. So in a short term, a knee dislocation with a multiligamentous knee injury, we are talking about nerve insult and a vessel insult. And in a long term, we are talking about persistent instability and a early degenerative joint. So the Schenck classification doesn't actually take in cartilage injury or a meniscal injury or a patellar tendon avulsion or a patellar tendon rupture. So it's still not complete, right? So for an acute multilegs, the suspicion has to be very, very high. Your ER doctor is very important. Make good friendship with him, because if he misses a subluxation or a dislocation or a knee dislocation which has got reduced even before he saw it, we are all in for a big drama. Because you tend to say the pulse is okay, the X-ray is okay, you put on a brace, send the patient back home, but the trouble brews overnight. Overnight what happens is the capsular trauma is there, the hemarthrosis will leak out of the joint into the compartment, it will cause compartment syndrome, sometimes there are intimal injuries. Although the pulse is normal, please try not to send back these patients and admit them for 24 hours and get comfortable with what we call as a ABI, which is ankle brachial pressure index. Right? So there are some entities called irreducible knee dislocations with buttonholing of the gastroc as well. But yes, acute vascular injury with a multilig, there is intimal damage, there is a possibility of a transection. We always put an X-fix, give it over to a vascular surgeon. Sometimes they operate in prone position, but these days a lot of vascular surgeons also operate in supine figure of 4 positions. Sometimes they put a graft, end-to-end repair. Right? Get your nurses comfortable with ABI. Get your DMOs comfortable with ABI. Ankle brachial pressure index is a simple systolic bed pressure ratio between the lower limb and the upper limb. If that is more than 0.9, still keep the patient admitted for 24 hours. Persistently measure it every 2 hours. And if it's more than 0.9 with good pulses, the patient is good to go after 24 hours. That is what should be the protocol in a knee dislocation, multi-lig knee dislocation. So nerve injuries, like we discussed, KD3L, more propensity to have a nerve injury, and the outcomes are usually bad, and most of them end up with a tendon transfer. So it's always worthwhile and wise to identify them early so that you can decompress them. Right? Because the next talk, Papa Rao sir is not here, I'm extending my talk into the management as well. Right? So the clinical assessment, you have lot of clinical tests, just get comfortable with 5 of the tests and keep doing them on every patient. Don't try and involve yourself with 13 or 14 or 15 tests and you will not be able to do them. Just pick up 5 tests for each ligament and keep doing them with every patient of yours. You'll be identifying most of the things, right? So this is my test that I do, right? PCL is the most important key ligament, right? First identify the PCL in multi-ligs, right? Is there a PCL tear or is it not there? Right? It's the key reconstruction that you begin your entire surgery with. That's how important it is. So there is a step off sign, there is a drawers, ACL, very simple, very easy. Latchmans and drawers. MCL, you have valgus stress in 0 degrees and 30 degrees. Why is this distinction important? Because if this knee is opening with valgus stress at 0 degrees, that means it is MCL plus something. It could be MCL plus capsule, it could be MCL plus ACL, it could be MCL plus PCL. It is always MCL plus something else if the knee is opening in valgus at 0 degrees. If it is opening at 30 degrees, it just could be MCL. So you should always think about POL in planning your reconstructions because it's a robust and important contributor to valgus stress. Optimal timing of surgery, all these patients, second week is the best time to go in because the capsular trauma has healed, the fluid extravasation is more controlled. Tourniquet time you should be watchful of the tourniquet time. You can repair certain structures on day 10, day 11, day 12, but you will fail to repair them when you repair them after third week or after fourth week. So this is one of the case, ACL, MCL and PCL as well. There is a valgus stress opening even at 0 degrees, but at 30 degrees it's a lot more. And there is also an anterior drawers and a posterior drawers positive. So it's an ACL, PCL and MCL. So I went in on day 12. The patient prehabbed so well that he was able to sit on the floor even before the surgery. So I did this is a stress radiograph and a C-arm image of how the knee is opening in valgus stress even at 0 degrees. You can see that there is a full MCL disruption, but when you enter these injuries on day 10, day 11, you can repair the MCL and you can augment it, of course. So this is a repair plus augmentation of MCL and an ACL and PCL. ACL is a reconstruction, PCL is a repair because you entered on day 10, there is a good chance that you can repair it, right? So this is what we achieved with the right, good stability, good range of motion, anti-drawers negative, posterior drawers negative, and good valgus stress as well. So it's a repair plus an augmentation, repair plus a reconstruction of MCL. As MCL, as you know, is a very thick, robust ligament, always repair should be supplemented. So this is the same case. Look at the arthroscopy picture, how the capsular trauma has disrupted the medial collateral and how the medial joint space is opening. You can expect the extravasation that can have. You can see tight calves post the surgery. Just to finish the surgery, you will be panicking, palpating the calf because the calf is very tight because the fluid has extravasated. Right? So big opening in the medial compartment before MCL has been repaired and ACL deficient knee. So this is after the MCL repair, same case, nice and pristine joint, it closed beautifully, it doesn't open anymore. And these patients also do quite well. This is just at 5 weeks, good nice endpoint there, not opening up at all. And because their muscle conditioning is so good, they all belong to old city of Hyderabad, Pahalwans of Hyderabad you can say. So they walk on 5th week without any crutch, without any support, without any assistive device because their muscle conditioning is so good. This should not be tried, let us say, with a 22-year-old chubby female. You cannot do that. They should have a good muscle conditioning if you want to rehab them little quick. Right, so you could talk about these cases because the next talk is not there. I'm just taking 2 more minutes liberty. So ACL plus PCL, you can see the sloppy ACL sign, very important sign. You just have to reconstruct the PCL and see if the ACL is nice, you can leave it. If you are not happy, you can always reconstruct. But in this case, I have reconstructed ACL as well because it's 125 kilos, 6 feet 4 inches. I don't want to rely on that particular ACL and I don't want to do one more surgery on him. The tourniquets are very difficult to place in 125 kilos, 6 feet 4 inch. The tables become small, the tourniquets become small. Right, you don't want to do one more surgery. You clear the notch, see the lateral opening here. So this is what happens in a ACL plus PCL and he was sitting on it for 5 to 6 months. So what happens is there is a lateral opening. Always look at PLC on the MRI and always after reconstructing the ACL and PCL, look at the lateral compartment again. Scope the lateral compartment and see if it's opening that much. Look at how clearly I can see popliteus. That can only happen if the lateral compartment is opening because of deficient ACL and PCL. Clear everything up. Peroneus longus will work as a PCL, hamstring can work as an ACL. Internal brace is something I use. Big mammoth of a guy, so I would like to augment with a fiber tape. And you get good stability on table. Posterior medial 2 portals I use for PCL and despite having ACL and PCL tear, I still use 2 portals. They get good stability. They do quite well. So this is one more guy, 120 kilos, 19 years of age, 1 year after knee dislocation, low pulse. he still was having less palpable dorsalis pedis, ATA and PTA. I've got a CT angio. 1 year post injury also he's got low pulse. He's got good perfusion, but he's got low pulse. Even that is a situation. If you are palpating this particular 19-year-old's pulse after the surgery, you'll be in a big mess, because you should know that he was having low pulse before surgery, and you've checked his perfusion with a CT angio before the surgery, because he presented to us 1 year post injury, right? Again, 125 kilos, 19-year-old, ACL and PCL. Always tourniquet can be your friend, tourniquet can be your enemy. So make sure you plan your surgery well, right? These are quite unstable. How can he walk on that, right? So he was walking on it for 1 year, and he was told that he had a vascular injury, but no reports of that. So ACL, PCL reconstruction, they do quite well. They recover quite well, and they have good stability. That is, they do well. They sit on the floor. They go back to all this in just 3 months. And you can imagine he's a tall, big guy. So there are various tests that you could do to assess the multi-ligs. Just keep 4 tests or 5 tests for each ligament. Keep repeating them again and again so that you're comfortable and you can identify that particular ligament damage. So despite having all these, I mean, I can go on, but one nice case that I would show, despite knowing all this, don't rely completely on clinical examination also, right? This is an obvious sag, posterior drawer is positive, PDT positive, posterior sag positive, quadriceps activation test positive. You will suspect it to be a PCL tear, but also ask for X-ray. This is the AP view. He has got a PCL reconstruction done. He has a malunited proximal tibia fracture with a reversed slope. A reversed slope will put a PCL at a biomechanical disadvantage, and that's why he's presenting as a PCL tear despite him having a normal PCL. So all you have to do is a anterior open wedge osteotomy, put the PCL that is existing at a mechanical advantage so that it starts working. It has been there, but it is not working because of a biomechanical disadvantage of a reverse tibial slope. So just increase the slope, put an iliac crest in the anterior open wedge, the slope becomes normal, PCL starts working, and you get a better stability, right? So despite knowing all these special tests also, you have to look at the radiology and correlate everything and then get in for a surgical intervention. So I would like to thank Hari sir and Saifani sir again for giving me the opportunity. Thank you very much.
Nice presentation, Dr. Siddharth. And today is a special day for you. And very happy birthday to you today.
Thank you, sir. Thank you, sir.
On behalf of the organizing team, Tosa Oasiscon Warangal, we wish a very happy birthday to you.
Thank you, sir. Thanks a lot, sir. Thanks a lot.
Thank you. Next, may I call upon Dr. Shivakumar, sir, who will talk on the PCL. Which ones quietly heal and which ones fool you into watching too long? Dr. Shivakumar.
Thanks to the Tosa and Oasis for giving me this opportunity, and thanks to Funny for giving me this challenging talk. The PCL, which one quietly heal and which one fools you? So let us see why PCL tears fool us. Because patient does not come with pain or swelling or instability. Most of the ACL tear patients come and tell us more pain, more swelling and instability. But whereas in PCL there is less pain, swelling and instability, and we fail to ask for the exact mechanism of injury. When patient comes and say he had a fall from the bike or some accident, we listen to that and we don't ask exactly what happened, whether the anterior aspect hit the road, whether he had a dashboard injury, and we don't ask that in our busy OPD day. And we most of the times in the routine OPD, if he comes 1 year or 6 months after the injury, we don't routinely examine because he don't say any instability. And so there we can get fooled by the PCL. And X-ray finding is sometimes invisible to the unsuspecting eye. If the PCL tear is not suspected clinically, X-ray may look absolutely normal. And MRI report also can be misleading in PCL tears. Sometimes they give partial tears, sometimes they say buckling, and sometimes they may give complete tear, but these are all misleading reports. So PCL can definitely fool us. So how not to get fooled by the PCL? Ask for detailed mechanism of the injury and always examine, always look for any scar or abrasion on the anterior aspect of the knee. For that we have to strip the patient from hip to the foot always. Most of the time patients comes wearing a jeans pant and we hesitate to ask them to remove. So always strip the patient from hip to the foot and look for the posterior sag, compare both the knees and always try to examine the posterior drawer. Just pushing the tibia posteriorly is enough. That can give the diagnosis. And always check for other ligaments. What not to miss? Always check for other ligaments like ACL or MCL, and dial test is the most important test for the PLC injuries, because most of the PCL injuries are associated with the PLC tears. And never miss the neurovascular examination. And if you routinely see this X-ray, we may think it is a normal X-ray, but train your eye not to miss this X-ray finding, which is a radiolucent line just at the 1 centimeter beneath the tibial spines. That is the PCL avulsion. So in the lateral view also not to miss the PCL avulsion. And MRI report may be misleading, so you have to learn to read the MRI. So only one sagittal section is enough to know whether the PCL is intact or completely torn. So the first image is the normal PCL and the second is buckling of the PCL. That means there is no PCL tear but there is an ACL tear. In ACL torn knee joint, the PCL is buckled. And the third one is partial PCL tear and fourth one is complete tear. And which ones quietly heal? Grade 1 and grade 2 tears and undisplaced PCL avulsions can heal quietly, but it requires proper bracing. Which brace? The brace should prevent posterior tibial translation and it should be wear 2 to 4 weeks. And ROM exercises initially should be performed in the prone position because to prevent the posterior sag of the tibia. And knee flexion may be limited to only 90 degrees for the 2 weeks, then progress to full motion. Partial weight bearing from the 2 weeks. And which ones need surgical intervention? Grade 3 symptomatic PCL tear, combined instabilities, posterior drawer more than 10 to 12 mm and chronic displaced PCL bony avulsions. And best time to intervene is from 3 to 6 weeks after the PCL injury because posterior capsule need to heal in this time, otherwise it will cause the fluid extravasation, and delaying PCL reconstruction too long can cause capsular scarring and persistent posterior subluxation. So the pre-op checklist should be patient should have full range of motion and confirm the neurovascular status, evaluate the associated ligament injuries, especially posterolateral corner injuries, and assess the limb alignment. Always take the scanogram in chronic injuries because most of the PCL deficient knees will have a varus malalignment. And the graft should be of adequate length, that is about 8 to 12 centimeter, and of adequate diameter at least 9 mm. And my choice is peroneus longus for the PCL. And single bundle versus double bundle, even though the double bundle is more anatomical, the single bundle is technically more easy, less morbid, cost effective and easier to revise. And the functional results are equal for both the single bundle and double bundle. And where to put the femoral tunnel in single bundle? If you see the image, there are 3 points, essential points here. One is the trochlear point, one is the medial arch point and one is the medial bifurcate prominence. And if you see the anterolateral bundle center point, it is 8 mm posterior to the anterior femoral cartilage. There you have to plan the center of the tunnel. And in single bundle tibial tunnel, the center of the tunnel is anterior to the bundle ridge. The yellow marking is bundle ridge. It should be anterior to the bundle ridge and slightly medial to the center of the footprint of the PCL. And the red mark shows the shiny white fibers of the posterior horn of the medial meniscus. You should not damage those shiny white fibers while drilling. And the fixation, the pull-out strength on the femoral side is great with the endo button rather than the interference screw, and pull-out strength on the tibia is more with the screw combined with the washer. And the position should allow you to put a posteromedial portal. So the medial side you should have enough space to put a posteromedial portal. And this is the technique. We keep the posteromedial portal, and I always keep a cannula so that my instruments are not, instruments can go easily. So the shaver is passed through the posteromedial cannula and the debridement is done on the tibial side. Then we can elevate the capsule from the anteromedial portal. The scope is in the central portal or anterolateral portal. Sometimes in the chronic cases we can encounter osteophytes. We may have to remove that. But remember, while using the shaver or burr, the suction should be kept low, and then we can tunnel the tibia. The jig should be placed at least 15 mm below the articular cartilage and little bit medial to the center of the PCL fossa, and then femoral tunnel 8 mm posterior to the anterior femoral cartilage. Then reaming with the 9 mm reamer up to a depth of 20 mm. Then that is just then passing the graft through both the tunnels. And what is the cost of missing PCL tears? If we miss the PCL tear, there can be accelerated patellofemoral wear, early medial compartmental OA, and secondary meniscal tears, and multi-ligament reconstruction failure. If you miss the PCL and if you do only ACL and MCL, your reconstruction will fail if there is a PCL tear and you did not address that. So the take home message, never miss a PCL tear. Thank you.
Thank you, sir. I welcome Dr. Sukesh Rao, sir. The talk is the posterolateral corner. The corner you ignore that directs the graft you just fixed.
Good evening, everyone. At the outset, I would like to thank the organizing committee of Tosacon for the warm invite. And I will also extend my thanks to Funny and Hari for the warm invitation. So my talk would focus today on the neglected corner, that is the posterolateral corner of the knee. See, basically it is called as the dark side of the knee because there is considerable paucity in the knowledge on how to approach and treat these problems. And it is also complicated by the fact that there are concomitant neurovascular injuries, meniscal injuries and cartilage injuries along with this problem. Now what is this posterolateral corner? To sum it up, basically it's a component of three primary stabilizing structures, that is the fibular collateral ligament or the lateral collateral ligament, the popliteus tendon and the popliteofibular ligament. There are other secondary stabilizers in the form of fabulofibular ligament, distal iliotibial band, proximal tibiofibular joint and the meniscotibial ligaments and the bicephemorous tendon. Now, I think the clinical examination and the initial evaluation has been described by Siddharth and the others. So I am not going to go into it. The essential thing is you should remember that there is a chance for nerve injury, arterial injury, and you should have a low threshold to evaluate them. Coming to the clinical test, I think no other component of a knee ligament injury warrants such a detailed clinical examination than a PLC injury, because it is very complicated. Often you miss the findings on the imaging. So it is essential that you retain your clinical evaluation value. So the first thing test that you can do is the varus stress test. It is done at 0 and 30 degrees. When it is positive at 30 degrees alone, that is a sign of insufficiency of the LCL. But when it is at both 0 and 30 degrees, you should always suspect the PLC corner, that is LCL, PCL. Again, the other test is the dial test. So you check for, it is done in prone position, you check for asymmetry of the rotation of the knee, of the ankle foot at 30 and 90 degrees. So whenever there is a combined PCL and LCL injury, that is a PLC injury, the affected side is rotated by more than 10 degrees. Then you have got the external rotation recurvatum test, wherein you make the patient lie supine, fix the thigh, and lift the the toe. So when you do that, when there is increase in the heel height compared to the opposite side and there is increase in tibial external rotation, it is suggestive of a combined ACL and PLC injury. Now having said that, radiology offers little value because most of these patients have other concomitant injuries. So some of the signs are having an absent popliteus tendon. The other indirect sign is having an onion skin on the MRI, which is suggestive of PLC bleeding or edema, and of course a torn LCL. The one most important investigation that is recommended is having stress X-rays done. So basically you obtain varus stress X-rays of both the knees on the OT table. When there is a side-to-side difference of 2.2 to 4 mm, that is suggestive of an isolated LCL tear. Whereas if it is more than 4 mm, that is suggestive of an PLC tear. And don't forget to assess alignment and slope, like what Siddharth showed in his case. Alignment and slope are most important thing, and the reverse slope will always affect the biomechanics of PCL. So you always have to assess that, don't forget to do that. And when you are assessing it, always try to correct it. Now regarding the timing on staging, it's a matter of debate, but the thing is most surgeons prefer to operate it before 3 weeks when the tissue is not scarred and when there is when you can identify anatomy properly. In fact, studies have shown that when you do this surgery within 3 weeks of injury, contrary to the conventional training, patients have shown better outcomes. Now, whether to do a repair or reconstruction, there are some studies that show that reconstruction is better compared to a repair, because this one study published in AJSM showed that there is a high failure rate with PLC reconstruction compared to repair. The other study shows that when you do a repair, there is greater friction loss, there is increased posterior sag. So in my practice, the repair is recommended only for acute avulsion injuries only. Coming to anatomic PLC reconstruction, the essential principle is you reconstruct all the 3 essential structures. One is the LCL, the popliteofibular ligament, and the popliteus tendon. So if you remember these 3 structures, that is how an anatomical PCL is done. For that you need 2 tissue grafts. One is to construct the LCL, the other is to reconstruct the popliteus tendon. So timing, always early surgery is better, especially within 2 weeks. This will allow proper tissue dissection, and also you can identify and dissect out your peroneal nerve easily. And usually the skin incision is a lateral hockey stick incision, which is usually centered between the fibular head and the Gerdy's tubercle. The nerve usually runs deep to the biceps tendon, so it is usually inferior to the biceps tendon, so you can easily dissect it out there. But whenever there is a concomitant biceps tendon rupture, you should always be careful. The next step is to localize the lateral collateral ligament and popliteus tendon landmarks by splitting the IT band. Basically, if you see, the FCL is proximal and posterior to the lateral epicondyle, and the popliteus is exactly 18.5 mm anterior to the LCL ligament. So if you can see, you can avoid, when you are doing it combined with ACL, you always try to aim your guide pin 35 degree anterior and proximally, so that you avoid the ACL tunnel, and for popliteus tendon, you always drill it with a parallel guide. For the fibular tunnel, you always start from the anterolateral aspect to the posteromedial aspect, and it's always from distal to proximal. For example, this is a fibula, so you always start from anterolateral to and your exit is posteromedial. So this will ensure that the tunnel is in the center of the fibular head and prevent fibular head blowout. Now in the Laprat technique, that's an anatomical PLC reconstruction technique, you should always drill the tibial tunnel. This is usually from anterior to posterior. It starts at the flat spot, just medial to the Gerdy's tubercle and exists posteriorly at the popliteus musculotendon junction. Now coming to the graft passage and fixation, the femoral fixation is done first, followed by the tibial, the fibular fixation. So you fix with interference screws on the femur, then followed by the passage of the grafts. You fix the fibular graft, the LCL graft in 20 degrees of flexion with the interference screw, and then pass the same graft along with the PLC with the popliteus graft through the tibia and fix it. So when you are fixing the LCL, the knee is at 20 degree. When you are fixing the popliteus and PFL ligament, the knee is at 60 degrees. There is one more technique, the easy technique, that is the arterial modification of the PLC. It is basically you drill one fibula and you make a H-shaped this thing, cross the grafts, and then you fix in the femur. Studies have shown that this technique is equivalent to the anatomic technique, and the outcomes are usually good when done in a single stage surgery, and when the other variables are there, they affect the outcomes. So like for example, whether there is a concomitant ACL reconstruction and whether and the slope. Rehab is very slow, usually takes 9 to 12 months, and it goes in phases. The initial 6 weeks you should be on non-weight bearing, and the bracing should be done in extension. Always delay the hamstring exercises for at least 9 months and avoid varus stress. Now these are the, to summarize, you have to have a thorough clinical examination, evaluate the neurovascular function, get stress x-rays, do an anatomical reconstruction wherever possible, and it is very important to understand the bony and soft tissue landmarks. Thank you.
Very nice presentation, Dr. Sukesh.
Now there will be a panel discussion on the multiligamentous knee from casualty to reconstruction. As a moderator, may I call upon Dr. Prahlad Singhvi and panelists, sir. R. Sundar Rajan sir, Jaya Prasad sir, Sukesh Rao sir, and V. Rajesh and Ranathir.
Request Dr. Sunit Hazra sir also to join the.
I think so. We are running out of time, so we'll just have a fast discussion. So we had a beautiful session before this on multilig. So we had Siddharth and Shivkumar sir and Sukesh presenting the intricacies of multiligament knee injuries. So sir, this is the X-ray. If you are able to see, this is the clinical picture. So Sunita. So he's a 20-year-old male, high velocity injury, road traffic accident, and this thing. Can we have some hind marks? Yeah. One here.
So I think in these sort of dislocations, we need to check the peripheral pulses also. We already heard the lecture in the few minutes back. So I think it's very important to check the pulses in the emergency. And if you see that there is, this looks like a posterior dislocation, and if the medial side of the knee is, a little prominent, then probably you need to relocate that as well as soon as possible.
So this is the X-ray, sir.
Yeah.
So it's, as you told, it is very important to assess the clinical and how early the patient comes to us. And Siddharth was very nicely told the importance of having good relations with the emergency department. So once this patient has come, so it is very important you feel the pulse. And so this patient had a compromised vascular status. Okay, but his neurovascular was okay, he did not had any neurodeficit, but he had a absent pulse. So what do you do now?
Sir, it mandates me for a CT angiogram.
So
You could do Doppler.
So
you could do other things.
would you straight away send the patient?
I
now
would
you-
reduce it.
Yeah,
I would
that
reduce
is
it
what,
first.
Yeah. So
But I would have a low threshold of a CT angio in a case where I had no pulse.
Yeah.
Upon first examination of the patient, if I couldn't feel the pulse,
Yeah.
I would definitely reduce him
Yeah.
and then start talking to him.
Yeah, so I
Before
think
talking
so.
to him, I
This
would
is
reduce it.
this is a very important point. So see, now we just gave a small sedation and we were able to reduce that patient on the X-ray table only. So now, as you told, so we just put a pulse ox. If you see, that is still the X-ray table. Okay.
Yes.
So that is the X-ray table, and now there is a waveform. So what will you do now?
I would admit him.
Yeah.
I would not send him home.
Okay.
Despite him having a pulse, despite him having a good waveform, I would ask my team to just get oriented with ABI, put him in the hospital for 24 hours, and then safely sending home after thoroughly investigating. In any time, if he loses ABI, if it's less than 0.9 or if it's dropping, I would get a CT angio. I would have a low threshold of getting a CT angio.
Jayaprasad sir.
Yeah, in these patients, there are pathology, what is the compression, vascular compression, intimal tear, or partial tears.
Yes.
These are the very important. Again, hematoma formation inside. So they may evolve in the 48 hours. If it is not evolving, it's okay. So my way of treating is 48 hours, I will see the vascularity. Every 2 hours, I will check it.
Sir, any role of CT angio at this stage?
If it is a founding pulse, it's okay.
But it is feeble, sir.
Anything with the feeble
Yeah.
pulse, we have to do a CT angio.
Yeah.
So as Jaya mentioned that they can have an intimal tear, they can have a partial tear, they can have a collaterals.
Yes, sir.
With that, you can survive with this link.
Yeah.
But it is very important to do the CT angio for especially when they have a feeble pulse.
Yeah.
Of course, you have to observe, as Siddharth said, you have to keep it for
Yeah.
48 hours or 72 hours. But it is important to document because these are the patients are very dangerous when you operate later on.
Yeah.
That the intimal tear can have a problem post-surgery.
Yes, sir.
So that is very important. So it is important to document also.
So as a panelist, everyone sir told it is very important to keep watch and definitely you should have modalities like CT angio. So there is no hesitation in taking a CT angio. So when you have the facility, get the CT angio done, and this is the CT angio. You can see there is a big thrombus. There is though there is a collaterals established, but there is a big thrombus 4 centimeters, which can create your misery. Okay, so be very careful, document, and as you told Siddharth during your presentation, slowly the capsular tear, the hematoma will seep in, and they go for a compartment syndrome. And this patient started going for a compartment syndrome, and we did immediate MRI because we had in-house MRI and all, so it was always advantage, and it was just a KD2 type of injury where the cruciates were affected. But the priority here would, again, as everyone was telling, the vascular. So we took a vascular consultation, and this is all like definition. And you also told about the high velocity, low velocity, and the ultra low velocity. So ultra low velocity, sometimes we can miss these injuries, and they may reduce themselves and come. So these intimal tears are the one which can really cause problem to you in identifying. You mentioned about this. So this is the algorithm which is very important. So if you have any patient, do a thorough neurovascular exam. Make sure that if there is a asymmetric pulse, you do a ankle brachial index is very important clinical diagnosis for you. And when there is no pulse, we have straight away, we can go for a vascular. But having the symmetric pulse also, we should very important, you keep monitoring the thing. So our vascular surgeon pitched in and he did a vascular repair here, and we had to stabilize with the fixators since he had no collaterals, so we did not do anything. Sir, at this stage, do you want to add anything, sir? Do you want to do any cruciate collateral ligaments when the vascular surgeon is doing anything?
Usually they will not allow you to do for
Yes,
at
sir.
least 4
Yes,
weeks to
sir.
6 weeks
Yes,
time.
sir.
And it's also for us also, the knee should become quiet.
Yeah.
Yes, already patient had a vascular injury. That means that's a very severe injury. All your posterior capsule might have gone, all with the oblique ligament, everything. So you are not going to reconstruct all the capsule and the oblique ligaments, everything. So you are going to reconstruct only the PCL, MCL. That is not enough to to support your knee. So the advantage of doing heaving that 4 to 6 weeks is that it allows the vascularity to get back. And second thing is allows all the capsules to heal well, so that when you mobilize the patient after 4 weeks to 6 weeks, then it is safe for you to do the second stage operation. Anybody has got a severe injury like this, so we have to go very slow mobilization. Some patients end up with some stiffness at the end.
Yes, sir.
With the 90 degrees, sometimes they get a very good stability. Even you don't need to operate in some of the vascular injury cases.
So this is the one thing, sir. So we have a beautiful paper by Dinsha Patiwala, but this is for an without vascular injury. So you can do it as a single stage at this stage. So as sir was telling, we removed the fixator at 4 weeks. We did gentle ROM for him under anesthesia, and then we put him on a rehab. So rehab is very important, and you put the patient on rehab, and once the patient gets complete, near complete range of movement, as I sometimes told that they may not even come for surgery, but they will be happy with that stiffness. But if at all they come to you with the instability, so we can always plan for the surgery. And again, as you told, we should take precaution because already he has undergone vascular repair. So the precautions will be very important. So, sir, I think so it is a straightforward, yeah.
Question
Siddharth.
is, can you apply a tourniquet, sir, in a patient who has underwent a vascular intervention, and we are planning a ligament reconstruction
It
subsequently?
won't allow you to put a tourniquet.
Let's say we
Yeah.
are doing it 3 months later.
Yeah.
Even then, no. You have tourniquet with you, that's why.
Sir?
Our vascular surgeon.
I do with the tourniquet
With-
only.
yeah. We
have to do an
It is-
ACL, PCL without
It doesn't
tourniquet.
matter because once you get the vascular repair, within a week or 10 days, your vascular, your vessel is going to heal very well. So after 4 weeks, 6 weeks, then you do rehab. By the time when you do operate, it's going to be 2 to 3 months time. I think it's going to be like
So,
normal.
so you can get your again vascular opinion done. So they will see your and
We had this with our vascular, in-house vascular surgeon. He is categorically denies doing a
Denies.
tourniquet. He says
Yeah.
when you do a tourniquet, the blood kind of flows down. It slows down. And
Revascularization,
that will
yeah.
lead to stasis and thrombosis. So he says absolutely no
so
tourniquet.
actually you can use a pump. In that situation, you can use a pump. You can avoid using tourniquet, and you can still do this. So initially we did without tourniquet, but now we are using tourniquet. We are able to convince our vascular surgeon. So I think so we have already discussed this. So this is the outcome, and this patient recently yesterday he came to the OP, and so we were able to do. So he's stable. It's almost 10 months. He's got complete range of movement. So this is again, sir, we'll rush because of again time. So this is one patient who had come to us with this kind of, because we do a lot of trauma also. So we fixed his non-union. He had basically a non-union of this fracture. So we fixed the fracture, but the patient was not happy. Sir, he is still having instability. So this is the instability he is having following the fixation of the femur. So now how to approach, sir? He has anteroposterior, he has tibial sag, he has grade 3 anteroposterior, he has varus instability. So what to do now? So there is a lot of implant here, and he has this instability.
So on clinical examination, what was your impression, sir?
So this is the clinical, I'll run it again. So this is tibial sag was there, there is anteroposterior instability, the Latchman was also there, and also varus instability is also there.
It's a challenging case, actually.
Yeah.
So you,
There is an instability.
Yeah.
you do a diagnostic arthroscopy.
Yeah.
You have to do a reconstruction.
Yes,
Of course,
sir.
you cannot able to do an MRI, anything like that. So
Yeah.
still, you have a very good medial side. There's nothing wrong in doing in a PCL reconstruction in this case. You have enough space is there. The only problem is that suppose if you think that you are going to do a lateral reconstruction because you have to put a big plate over there, there is the only problem.
Yes,
If
sir.
you had planned earlier, probably the plate would have been adjusted where you can avoid that anatomical landmark.
Yeah.
Otherwise, you have to wait for 3 to 4 months for your non-union to heal well.
Yeah.
Then you can remove the plate and address the both.
I think in this case, I think the PCL and MCL was main problem. The ACL might also be lax. In this case, I think the problem will be the ACL will be difficult.
Or
So
the
I
alternate is allow the fracture to
PCL
heal,
and
put
MCL
him on a
should not
hinge
be a
knee
problem
brace,
Yeah.
allow the fracture to heal, do a implant removal and do the ligaments reconstruction in the same
So
set.
at this, sir, as like we always have doubt whenever we have varus valgus instability, whether it is medial side, and so the stress X-ray plays very important role, sir. So you can always get a stress X-ray done, we had stress X-ray, but I'm not able to get it here for this case. Sir, so this patient had, again, like we all know that the challenges are to confirm the diagnosis because we are not able to do an MRI for this patient. So the stress X-rays plays very important role. So this is a paper by Laprade group and all. They have taken, they have stressed that in case whenever you are not able to do an MRI for multi-lig, you can always do a varus valgus stress views, anterior posterior stress views, and you can confirm your diagnosis of multi-ligament this thing. So this is our paper also, which is now just published in Oasiscon. And this case also we did a similar, you can do a scanogram and make sure that what is the instability. So this particular patient had a lax, though there were few fibers of ACL, PCL, they were very lax. So there was also some cartilage injury on the medial side, and otherwise it was okay. So if you see the drive-through sign on the lateral side, so the drive-through sign is there, so which again shows that there is PLC injury was there. So what we did was we did a ACL PCL reconstruction here. So we were lucky enough to take the tunnel more posterior. So we were able to, we did here the trick was put a bead pin and then we checked it in the C-arm where we exited out, and then we did a endo button reamer, and then we did this thing. So we were able to do here. So you can see there is endo button which is flipped behind the plate on the femoral side, and on the PCL also we were able to do. And this is like 8 months follow up now. He just came again. The fracture is also nicely healed, and the stability is also good.
Just a question, how were you able to do the femoral tunnel for the ACL in this case?
We see
so
again,
was there any special trick that you did a check, or did you do an outside in?
No, this patient I only treated for the non-union also. So while I was treating for non-union, if you see this lateral X-ray, I have not kept anything posteriorly, and the anterior screws also I have put small. So just keeping that in mind, that this should not come in my future tunnel, because we diagnosed it under anesthesia during that.
Maybe in this case, but what
yes, sir.
You showed the video,
yes, sir.
the ACL looks to be almost like okay.
Yeah.
Because anything with the PCLs, you have the lax ACL.
Yeah.
And anything with the femoral fracture, you know that it's, where injury usually happens PCL, not that ACL, because, the dashboard injury.
Yes, sir.
So mostly that's a PCL injury. So even if you do a PCL reconstruction alone, is more than enough for this
we
patient.
we retained that bundle, sir. It was like a bundle augmentation with what we did.
Plus, this plate also looks a proximal tibia plate rather than
Yes,
the
sir.
distal femur
Yes,
plate.
sir.
So
Yes,
the distal femur plate sits a little more anteriorly. So I think that would have been
So
made
this
your life much
is the opposite side distal proximal tibia plate, sir. So we have used proximal tibia plate. So this is the stability which he has got, and this patient is fracture is healed, and also he has got a good stability. He is back to work. This is again our paper which we stress about the osteoligamentous injury, and this paper we published in IJO, sir, where we analyzed around 500 cases of fractures around the knee joint, and where they had multi-ligament instability, how we can manage them, diagnose them. And this is the recent paper which is got published in Oasiscon, where we did a similar case. This is a case report, sir. Thank you. This is that case, the distal femur fracture. So we did a partial metal implant exit, and then we removed the if you see here, we removed the posterior screws all, so that we could accommodate our ACL tunnel, and then we subjected to rehab, and we did this thing, sir. Thank you, sir.
Thank you.
And I take this opportunity to welcome you all to Oasiscon 2027 to Madurai.
Thank you, sir. That was an excellent panel discussion. Pralad, sir, thank you. Please, I request the chairperson to sit down, sir. Please.
Yeah.
Panelists also, please sit down, sir. Sir, I request the chairpersons to please felicitate the panelists as well as moderator, Pralad, sir. Pralad sir happens to be
Thank you, Shravan.
my boss in Madurai. Babu. I also request the previous speaker, Jagan sir, please come on to the, and the previous speakers of the session, Sir Sridhar sir, and Hari Krishna sir. Sheshikant sir. I request Naren sir also to come to the, and Satish sir. VCR sir also to join. Okay. Sir, there will be a general body meeting of Oasis after this talk. Hence, we request the delegates to retain and session to be wind up. Is it? Chairperson? Chairperson. వాళ్ళనే ఉంటామట. I request Mithinachi sir, Sai Fani, Sundarajan sir, Sundarajan sir. ఇక్కడ చదవాలి. అయిపోతుంది 10 నిమిషాలు. Thank you, sirs. I now request for the next session. There will be a general body meeting, so
now I request Dr. Maheshwar to hasten up the procedure. There is still lot more, another session is there and general body should be followed. Do you think that at 8 o'clock general body will take place? Please. I'm just seeing, watching the. Please, hurry up.
to the next talk. I request the chairpersons, Maheshwar sir as well as Abhiram to next session. Now I request all the arthroscopy surgeons to felicitate. There is a small felicitation for Sundar Rajan sir. Felicitation. అయిపోయింది. ఓకే. I request Hari and Sai Fani to please felicitate our chairpersons. Okay, let's continue with the talks. Now,
Now the next speaker is Dr. B. Sai Fanichandra.
please speakers stick on to the time. If possible, finish it more early. బాస్ ఎవరైనా చూస్తా
Right. Yeah, so we'll slightly rush up. Thank you so much, Tosa and Tosacon organizing team of 2026 for giving this opportunity. So we'll rush into the talks. Sir. So we'll finish it off fast. So cartilage lesions in knee scopy. Someone change the slides. So there is a 60% incidence of contour lesions as per Widichowski's study in 2027 when any arthroscopy is done, and most of them, 90%, are under 4 centimeter square with a high grade under age of the 40. And the lesion is rarely the whole story. There is malalignment, meniscus loss, and instability drive. So we'll just rush into the cases and have a small discussion on it. It's a 29-year-old male with the pain in the knee and limp, which is in 6 months. There is no history of trauma again, painful range of motion, but there is no signs of ligamentous laxity. He has been roaming around for 6 months. So if you can see in the MRI here, there is only partial edema which can be seen along the medial femoral condyle, which was looking like a subchondral defect. So upon diagnostic arthroscopy, we found that there is a cartilage lesion along the medial femoral condyle, so which upon probing was looking to be a very unstable flap tear, which 9 mm, which was shown on the MRI, went on to become a big one, which is around 6 to 7 centimeter square. So that was a huge defect, and it was all fluffy, and it has been there for quite some time. So these are the incidental things which go really unnoticed and undiagnosed, and they tend to be really, taking the pain and keeping the patient away from most of the things. But then what happened was, once we removed all this cartilage, which was really loose, until we found an adherent cartilage, it was a huge lesion. So then we went on to remove that cartilage, went on to do a dry arthroscopy, and we did an autocart procedure with some subchondral drilling since it was a big patch. So once that subchondral drilling was done and the cartilage was pasted with some minced ACI procedure, which was done for this patient. Patient continued to do well, which was found out then and there, and we finished it. Now his MOCAT score at 6 months was 60, which kept improving. Now this is another case where he had an isolated chondral lesion plus a subchondral bone involvement as well, which can be seen as a cyst in the image on the right side. Cartogram was done, which also showed a single small cyst. For this, we have done an OATS and AutoCAT together. We have taken a cone where the subchondral bone was looking bad. If you can see there, it was a big defect there. We have removed that using a cone, and we have done OATS on the inferior side. And for the superior, since the subchondral bone was intact, we didn't want to disturb that much. So we just did a cartilage procedure. We did a very shallow micro drilling, and we went on to do a AutoCAT procedure over this. So it have a combination of hybrid fixation with OATS and AutoCAT on a single medial femoral condyle on the right side, and on the left side with single only minced autologous cartilage. Now if you look at these defects, there are focal areas of damage, avascular and poor self-healing. That Widuchowski's article analyzed 25,000 knees, which shows incidence in around 60%. And this Dutch consensus statement also shows the prerequisites, what we should be done to really save the joint, that is stable knee with normal alignment, any malalignment greater than 5 degrees at the expense of defect compartment, consider an additional osteotomy. There should not be any unstable knee. Aim for BMI less than 30, age less than 50, meniscus more than 50. Now, the Cartilage Society has 3 types of classifications. We all know that. Now, the prerequisite is to have alignment, stability, and meniscus. And the objective is to have a stable congruent joint depending on the size of the lesion, age, and location. So if you look at this classification by Goel sir, which was taken by him upon request, ICRS grade 0, 1, 2, conservative 3 and 4 depending on age and size of the lesion. We have OATS, ACI or ACI plus OATS both together. So these are the different types where we can do a cartilage repair or a cartilage replacement or a cartilage regeneration. So there are 3 R's, the triple R's of cartilage. So one is repair, where we do marrow stimulation, be it micro drilling or nano drilling, or microfracture with augmentation. Next is a mosaic plasticity, where we replace a bone to bone, subchondral bone to subchondral bone, and cartilage to cartilage. This is extremely good procedure, but the size of the lesion should be between certain size. Now it allows defect to be filled immediately, and the take-up is really good. Now ACI, they are into 4th generation now actually. The 3rd generation is the ones which we have done right now. And now we have these scaffolds, the natural, synthetic and hybrid, which can be used to really support the cartilage procedures. Now this article Matsuhita is the best article which we have, which compares so many procedures done together and which discuss in detail about these cartilage lesions and a detailed narrative as well. So simple digestion on the table, incidental lesions found at scope, assess the symptoms, size, ICRS, alignment, meniscus and lead, and ignore if it is a very low grade. Treat now immediately if with the following flow chart, less than 2, 2 to 4 or go more than 4. If it is in between with malalignment which has not been told, then stage it, explain the patient and come back. Small lesions, microfracturing helps, medium lesions, OATS helps, large lesions, ACI plus allo. Instability and alignment have to be addressed. Neuron-set scaffolds show promising results. OCLs are not to be ignored, and low demand can be treated with BMAC or PRP. Thank you so much. Thank you.
Thank you, Fani. I request Mithinachi sir to come. Topic is after first time patellar dislocation, who actually needs an MPFL reconstruction.
Akhrichna, Mithinachi.
So in view of time, I think I'll just summarize my talk. Basically, if you have a knee dislocation, first time knee dislocation, MPFL surgery, who are actually asked to have MPFL surgery, there are 4 to 5 criteria, very important criteria. The first criteria, very importantly, is the trochlear, de jure trochlear dysplasia. We all know de jure classification A, B, C, D. So if perchance, yeah, I got it. Yeah, thank you. So after the first time dislocation, patellar dislocation, who actually needs 35% actually dislocate again. So how do I change? Next slide. How do I change? So no, if it's a normal trochlear morphology, CDI index which is normal, TTTG distance less than 15 mm, skeletally mature patient, no osteochondral fragment and MRI, first episode, usually conservative management is better. If anything else, we go for early repair. So there are 4 types of de jure, as you can see here. Next slide. It's not going. Next. Oh yeah, sorry. So type A, usually you can leave it in a shallow trochlea. Type B, type C, type D, perhaps requirement for surgery will be there. These are the different morphological types of the de jure classification. And if you have the crossing sign or the double contour, obviously that shows a very high index for resurgery. Patella alta, the CDI index, if it is, the normal is 1.2, but if it is more, there is patella alta, there is high chance again that the MPFL surgery might be required with patellar alta revision. Next slide, it's not going. So that is the CDI index. If it is around 1.2 to 1.3, it's fine. If it is more, patella alta, go ahead with the surgical process. The TG distance, obviously, if it is more than 20 mm, that is a lateral pull of the patellar forces. And it's very important that if you have more than 20 mm, you go ahead with the repair. And osteochondral fragment, very important. If you have an osteochondral fragment, you have to go ahead with the surgical process. In younger patients, obviously, higher chance of redislocations are there, and there are high chances that these are the patients that require surgical treatment. So patellar tilt, contralateral instability, elevated BMI, generalized laxicity, family history, and MPFL tear pattern may be accessory ways of understanding how to go about. So if you see trochlear dysplasia, Caton discharge index, TTTG distance, age at first episode, and contralateral instability have a very low threshold if you have more than 3 factors. So first time dislocation, confirm the diagnosis. If you have loose body, immediately do a scope. Major risk factors present. If there are more than 2, then go ahead and decide and go for surgery. So take home message is APFL reconstruction is for the knee with anatomy that predicts failure, not for every first dislocation. Image everyone, risk stratify everyone, and operate on the ones that anatomy tells you. Thank you, Dr. Fani and Dr. Hari, for giving us. I welcome you all for our 10th Real Life Conference in Apollo, Secunderabad. Thank you so much.
Is a GPRK Rohit. He'll speak on osteotomy in the young knee. Rohit.
Good evening, everyone. Good evening, everyone. At the outset, I would like to thank the Tosa Oasiscon organizing committee and Dr. Hari Prakash sir and Dr. Saifani sir for this opportunity. I'm Dr. GPR Rohit, consultant arthroscopy sports surgeon at KIMS Minister Road. So this is today's topic, osteotomy in young knee, buying a patient 1 to 2 decades before replacement. So why buy time? Total knee arthroplasty done in less than 50 years age. The revision risk is 22 to 25%, especially more in males. The revision risk falls to 5% when the primary TK is done above 65 years. The median time to first revision is less than 5 when TK is done less than 60 years. Younger revision cohorts always report higher reoperation, re-revision, infection than the primary. Joint preservation is a deferral strategy. It's a not alternative to the eventual arthroplasty. Indications for arthroplasty: active, non-obese, less than 60, range of movement 15 to 90, no patellofemoral symptoms, genovarum or valgum with unicompartmental OA, osteochondral defect, osteonecrosis of medial femoral condyle, ACL, PCL and PLC deficient knees with concomitant correction, planned cartilage or meniscal repair or transplant. The contraindications: bicompartmental OA or symptomatic patellofemoral, inflammatory arthritis and inconsistent pain pattern, FFD more than 15, ROM less than 90, tibial subluxation more than 1 centimeter, excessive medial or lateral bone loss more than 3 mm, patella baja, irreparable meniscal tear, obese more than 30 BMI, smoker, peripheral vascular disease. Age 60 is only a relative indication. Evidence shows that HTO combined with cartilage or meniscus procedure, HTO with OATS, survivorship is 87% 10 years, 5% at 15 years, 77% at 19 years. Each 1 point raise in BMI, the failure rate increases by 1.6%. Microfracture with HTO, 79% return to sport, only 41% to the pre-injury level and 50% to reoperation by 6 years. HTO with medial meniscal allograft transplant, return to sport is 87% by 9 months. Return to work 100%. Outcomes are similar with isolated MAT. Isolated MAT survivorship 96% 1 year, 87% 5 years and 82% at 7 years. Planning essentials: first, localize the deformity, tibial or femoral or intra-articular. Don't force a tibial correction. For a femoral deformity, key angles, MPTA, LDFA, JCLA, HKA. Correction target should be the Fujisawa, 62% of the tibial width, guided by residual cartilage thickness. Valgus knee, a distal femoral osteotomy, similar principles, femoral sided correction. Consider double level if the correction should push MPTA beyond 94. The technique: diagnostic arthroscopy always first, confirm the status, then treat intra-articular pathology. Anteromedial approach: protect superficial MCL and posterior structures. Biplanar cut, transverse plus retrotubercular ascending at 110 degrees, provides greater AP or rotational stability. Protect the lateral hinge, stop 10 mm short to protect the lateral cortex. Put a K-wire that reduces the hinge fracture by 40% to 17. Fix the angle stable plate like a tomofix, which allows early weight bearing. Sorry. So this is a 45-year-old male with early OA with there was a medial compartmental OA with partial root tear. So HTO with root repair was done. So HTO and UK overlapping indications. UK tends to give slightly better functional scores, less pain and fewer complications in comparative meta-analysis. Complications: lateral hinge fracture, union rate is 97%, and DVT and peroneal nerve disc injury. Technical pearls: patient selection is the strongest predictor of success. Plan by angle on a full length standing film, not just wedge height. Respect lateral hinge stop 10 mm short, protective K-wire. Take home message: osteotomy is a deferral strategy. Buys only 10 to 15 years implant free interval in the well selected young active patient. Thank you.
Thank you.
Register for OTS. It's in 16th, 17th, 18th October. Avail the attractive offers which is there today and tomorrow at stall B23. Thank you.
Thank you, Dr. Rohit. May I call upon Dr. Raviteja Rudraraju? He'll speak on return to the sport. Dr. Raviteja.
Okay, so talking about the return to sport, I think firstly thank Sai and Hari for giving me this opportunity to present this topic, because during this process I also learned few things on how to evaluate patients. So as we know, we commonly say return to sport after 9 months, but Is the biology equal to function? And function, is it equal to performance? And is the performance equals to readiness? I think time is a milestone, but not a test. So we often say that people can get back to sport after 9 months, but actually that's not true, in the sense that we need to evaluate the patient well before we certify that these patients can get back to sport. So return to sport is a continuum. Is you so return to participation, then return to sport, and return to performance. Not all three are the same. I think it needs a methodological approach to certify a person to get back to sport. So what are we actually testing? We are looking at knee range of motion, effusion, stability. We are looking at strength, power, movement, psychology of the patient, and obviously the reactive performance of the patient. So now one single test answers all 6 criteria. So it's important to evaluate all those 6 criteria very thoroughly before you certify a patient. So first test is to see whether the knee is quiet or not, if he can extend the knee completely and there is any effusion or not. Secondly, looking at the quadricep strength, looking at isokinetic and dynamometry is very, very important. I think the traditional target is more than 90%, so I think we should target more than that. And is the athlete strong enough for the sport is something that we have to ask, and then only we have to certify. The next is a problem with limb asymmetry. So we have to look for the limb asymmetry, and we need to make sure that the limbs are asymmetric before we certify whether the absolute strength, relative strength, and the contralateral comparison is rightly done. The third one is the rate of force development. So it's very critical for patients who are into sprinting, cutting, acceleration, and jumping. So as you know, sports happen in milliseconds, so we need to make sure that they are doing it quickly and doing it with the right force. Then you know the hop testing. So we do single, triple, crossover, timed, and vertical hops. So we make sure that we are assessing the landing strategy, knee flexion, knee trunk control, balance, and confidence. So the hop paradox, the hop test paradox as we call it. So we have to look for controlled absorption, knee hip strategy, trunk position, and stable landing. So the fifth one is landing mechanics. We need to make sure that the athlete is able to absorb the force well when it comes to knee flexion, hip strategy, frontal plane control, trunk control, foot position, and stabilization. So as you see, the drop, jump, single leg standing, and rebound should all happen at one go. Next comes the deceleration. We should look for the right deceleration. Can he able to stop? Sprint, decelerate, stabilize. Again, sprint, decelerate, 45-degree cut, and then reactive deceleration. All these things have to be tested before you certify that this test is passed. Then you have the change of direction. So you need to make sure that all these parameters like pre-planned cut, visual stimulus, and all other parameters are well looked into before you certify the change of direction. Then you have got the fatigue test. So fatigue is a stress test for rehabilitation. You need to make sure that these are all looked for before you certify this. Then you have got the psychological readiness, whether the patient is out of fear of all these problems. And then you have got the sport-specific readiness. So to build a return to sport program, you need to have a quiet knee, stable knee, and then you need to check for all those tests that I have mentioned before. And as you see, to take home, you need to make sure that they are ready beyond 90%. Have a quiet knee, movement quality is good, deceleration is good, reactive ability is good, and then the sport-specific competence is good. Thank you so much.
Thank you, Dr. Ravi Teja. Now, may I call upon Dr. S.R. Sundararajan, sir? Sir will speak on post-ACLR complications.
Good evening, everyone. So I will finish it with one talk. So I will skip the ATFL. Probably many people may not be interested in the ATFL. So I'll give the common topic of red flags of post-ACL reconstruction. So we know there are a lot of red flags after the ACL reconstruction, but the most important red flags which you are worried about is the infection or arthrofibrosis and DVT. I think these three you have to keep in mind whenever you do ACL reconstruction. So these are going to be the nightmares after doing the operation. If you get these complications, a problem. So you have two types of infection when the patient comes to you within 2 weeks of time. So I call it an acute infection. Patient comes to you after 2 weeks, it's a chronic. In the acute, anybody comes with the pain, swelling, and fever, you have to be very careful that do all the investigations. Even there is not obvious aspiration, nothing comes. Do all the blood counts. If there is a suspicion, then do the aspiration. Then if the aspiration shows, you can do a diagnostic, like if it shows the positive culture, or it can be a purulent, we don't know. But sometimes it could be a turbid aspiration. The cell count is more than 20, or CRP is more than 150 in acute cases, more than 20 in sometimes more than 20, that is chronic cases. So anything you suspect, all those things, you have to be have a red flag. Don't hesitate to do the immediate debridement. It is very, very important. The washout, leave it, let it out, all the fluid or the whatever the material inside, then start an antibiotic therapy. Normally, at least 1 week of IV antibiotics followed by 5 weeks of oral antibiotic is recommended. So otherwise, even also every painful and otherwise suspicious cases, don't hesitate to do the washout. So when you do the graft retention, when you do the remove, in acute cases, whenever you have a turbulent fluid, it's not a purulent, the graft retention is possible. If there is a purulent, then don't hesitate to remove the graft, because this is the case which you can end up in a problem, because you may need to do the multiple surgeries, then you may end up in some bad complications. And when you do a culture, it's very important. I think you should know, at least you take a 3 to 5 intraoperative tissue samples. One is not sufficient. From different places you have to take it out. And at least one you have to send for a histopathological examination. That is recommended. And if you do an implant and graft, if you do an exit, then that also has to be sent for culture, bacterial, as well as the fungal. That is also cannot be ruled out. You can see this as 1 or 2 cases which I will show you, that is an underwent an ACL reconstruction elsewhere. 20 days injury, 20 days before, presented with the knee swelling and discharging pus. If you may take an X-ray, X-ray may not reveal anything. So anything suspicious, do an MRI scan. If the MRI shows the collection in the tunnel, if the CRP flow or ES are increased, then this is the patient, they should not visited, you should not put on antibiotic and send the patient or admit and put on antibiotic. You have to go to the theatre and do the surgery. Even after 20 days, sometimes you will have, by the time the graft will be macerated, very lax, it will not be, it cannot be retained, especially when I have a purulent material. You see that within 20 days, this graft is like this. So by retaining this graft, you are not going to achieve anything. So counsel the patient, you tell him that removing the graft is going to solve the problem. This is another patient, 35 years old. You can see that patient presented with a discharging problem from the graft side for 14 days. And there's the same scenario. So anything with, even if you leave it for 15 to 20 days with the antibiotics without doing a washout, that may jeopardize the graft. So it's important that do the day one. This I'm showing just one class example of a 27 years old. He's operated in Delhi for ACL reconstruction. He had a fever, but he was put on antibiotic for almost 2 weeks time with IV antibiotics. Then they did the debridement. Then they did the graft removal. But when the patient presented to us after 2 months, you can see the situation. The whole tibia has gone, complete osteomyelitis, and this patient ended up with removal of whole proximal tibia, finally with the hinge knee replacement. He is only at 21 years old. So it's important that all these infection patients, you have to be very, very careful that to be suspicious, do the intervention at the earliest. So how do you prevent this? So optimize the host, make sure that the patient is healthy. If the patient is a smoker, ask them to stop it if it's in a chronic situations. And all the surgical precautions, you have to take it out, and which I don't. And also, it's very important to practice with the vancomycin or soaked one. It is well proven now. It's a vancomycin soaked wrapping of the graft gives you the very good prevention of the infection. The next most complications which you are worried about, the arthropfibrosis. What is important here is that patient may lose extension, also lose the flexion. Losing a flexion, you can get it later, there is no issues. But if you're losing the extension, is a major problem, especially in athletic patients. So it's important for you to get the extension within the 4 weeks of time after the ACL reconstruction. So this patient presented to us with the extension loss. We can see that a lot of arthropfibrosis. Still, you can get an extension if you do a good arthrolysis. If you're in an early part of your career, please take your senior to do that. It is a time-taking surgery. You need an expertise to do that. So remove all the cyclopes and all the tissues over there. Do the small notchplasty to get back also you need to do a posterior capsular release so that you can get back the extension. So it is a little technically demanding, but you can get back that extension even the patient comes to you very late. So this is the post-arthrosis and post-capsular release. This is what you get it intraoperatively. You can get it at 5 degrees of hyperextension. So this is another patient. As a primary surgeon, when you do acute cases, please see the intermeniscal ligament before you do ACL reconstruction, because you may miss your ruptured ACL, which will fall back more anteriorly. That's why the cyclops lesion forms. and if you don't take care of that, the patient comes back to you with extension loss. So this is one of the case where these cyclops were missed. This patient presented with me with 2 years after the surgery. He was not able to play sports. So even after 2 years, which we could do the good arthrolysis, do the good posterior capsular release, we can see that pre-op and post-op extension. You can see that is the extension. So it's very important that we had to get that extension in 4 weeks' time. So that is very important. The DVT of all the high-risk patients, you know the heart of the high-risk patients. It is not uncommon. At the same time, you can have catastrophic problems. So it is important that any high-risk patients, you can put on anticoagulants. It is very, very important. Is one of the paper which you can see the routine screening of 260 patients, ultrasonography after 1 week of post-ACL, 21 patients, that is 8.1% showed DVT. But of course, they are all asymptomatic, but they can be asymptomatic. So it's very important that do the early mobilization. If possible, give the DVT pumps. Anticoagulant therapy in the high-risk patients will give you the solution. To conclude, don't ignore infection symptoms. If you do the immediate intervention, do the washout and save the graft. If it's a purulent, don't hesitate. Counsel the patient, remove the graft. And for any stiffness, try to get the extension at the earliest. Prevention is better than cure. So it's very important to address post-op rehab very meticulously. And all high-risk patients requires anticoagulation. Thank you very much.
Thank you, Sundarajan sir. And now may I call upon Dr. Virender Mudnoor. Will speak on femoroacetabular impingement, cam and pincer type lesions. And this is the last topic. After this, there is a general body meeting of Oasis.
Very good evening. I would like to thank the Tosacon organizers, Dr. Sai and Dr. Hari, for giving me this opportunity. I will quickly run you through the concept of hip impingement, how a cam and a pincer lesions will cause a groin pain and hip pain, and very oftenly missed, but in the last 10 to 15 years, we are recognizing these lesions more often because of the hip arthroscopy procedures and more published literature on hip arthroscopy. So what is FAI? It is a motion-related hip disorder where a premature and abnormal contact happens between your femoral head neck and the acetabular rim. It is one of the major causes of hip or groin pain in young and active athletes. The diagnosis increased because of increased hip arthroscopy procedures. Now, when we diagnose, it is very important that we'll have to follow the Warwick triad, where all the three symptoms, the clinical signs, and the radiological imaging, all three should be present to diagnose and offer a procedure. Isolated symptoms without any clinical signs and imaging, or isolated clinical signs without imaging, we are not supposed to offer the procedure. Who gets FI? There is an increased incidence among males compared to the females, which is about 35%, but patients with FAI converting to secondary OA of the hip is less, which is about 3.4%. The functional anatomy which is relevant to impingement is the normal asphericity or the concavity of the head neck junction, which is required to clear the femoral head from the acetabular region in flexion and interrotation is very important. The acetabular labrum is very important. It helps in deepening the socket. It helps in maintaining the fluid pressure inside the joint and also helps in load distribution. The acetabular version is very important. That will help the coverage of the femoral head. If it is an excessive retroversion, that would increase the coverage, causing a pincer lesion. The capsule and ligamentous stitches are also important for stability, which is very important to remember when we do hip arthroscopies to do a capsule closure. There are two common mechanisms for hip impingement. One is the cam lesion and other is the pincer lesion. The cam mechanism is an aspherical head neck junction where the concavity is lost and it becomes convex and leads to an impingement and a contralateral abrasion on the femoral side. Whereas the pincer mechanism is an acetabular overcoverage, which happens either because of a global overcoverage or an increased acetabular retroversion. That will lead to crushing of the labrum and leads to labral tears. It also leads to a contracoup cartilage injury on the posterior inferior aspect of the femoral head because of the liver of the acetabulum pushing the neck. Both the mechanisms largely cause chondral damage on the anterior superior part of the femoral head, specifically in flexion and interrotation. If you look at the cam lesion on an X-ray, it will look like a pistol grip deformity. We are supposed to get CT scans and identify where exactly it is, whether it is in the anterolateral head-neck junction, anterolateral neck, or an anterior neck and the anterior head-neck junction. You'll have to quantify the alpha angle, which is a normal about less than 55 degrees, but most symptomatic FAIs have an angle of about 74 degrees. The consequence of cam lesion is a chondral injury, which happens on the anterior superior aspect. It is a chondral delamination. The pincer lesion is either because of global overcoverage or an increased retroversion. So we are supposed to identify the pincer lesion by looking at the lateral center edge angle of the hip and look for the retroversion by crossover sign. Again, here the labral injury is more common than the actual chondral injury. If there is a chondral injury, it is on the posterior inferior aspect of the head. Clinically, both are, the mixed presentation is more common. The patient usually presents with a pain on deep in the groin for long hours of sitting, or when he tries to tie his shoes or comes out of a car. He usually tells, hooking his hand around the hip joint, makes a C where his fingers are anterior and the thumb posterior. That is a C sign which usually the patient will demonstrate when you ask him where exactly is the pain coming from. Physical examination, the fadir is the most important, the flexion, adduction and L rotation where you can elicit the pain. Faber, just to rule out the SI joint contribution, simple interrotation and 90 degrees of flexion will elicit the pain. So standard X-rays, the Dunn's view is very important in 45 degrees of flexion, about 20 degrees of abduction of the hip to measure the alpha angle. Alpha angle is angle between two lines, the center of the head and the center of the neck, and a line drawn from the center of the head to the abnormal sphericity of the head-neck junction. Again, we are supposed to measure the lateral central edge angle. Less than 20 would indicate a dysplasia. Normally is about 25 to 40. More than 40 indicates a retroversion. MRI will be definitely useful for a soft tissue to identify the labral tears and the chondral damage. CT can definitely tell us more about the site of the cam lesion. When we offer procedure, we are also supposed to note the arthritis. We should understand the Tony's grading. And in arthroscopy, we are also supposed to do the outer bridge classification of the chondral damage. Non-operative treatment should be the first line. We should give at least 3 months of non-operative treatment for the patient before we offer a hip arthroscopy procedure. Hip arthroscopy definitely has a better results, although it might not completely prevent development of secondary OA. So indication of surgery is always after proper conservative treatment. So arthroscopic cam correction, the goal is to restore the sphericity of the head. We should not overcorrect it or under-resect it. Overcorrection can lead to fractures, undercorrection can lead to recurrence of the symptoms. Pincer trimming. Pincer, you should always try to repair the labrum. You separate the labrum, debride the edge acetabular rim, and then repair either at the base of the labrum or just like the normal gleaner labrum we do, complete labrum can also be sutured with the anchors. Debridement would also give a good result if there is no good labral tissue to repair. Reconstruction in cases where we don't have, we can use tendons, the gracilis or the semites to do a labral reconstruction as well. Arthroscopic procedures will definitely give a good result, although it might not guarantee that there is the OA will be completely prevented. Complications, risk of infection is less than 1%. Traction neuropraxia is very common if you keep it for more than 2 hours of hip traction. Iatrogenic chondral injury is also common, and heterotopic ossification is also noted. So the key takeaways are, it is very important that we follow the Warwick's triad where the symptoms, signs and the radiological imaging, all three are there. After that only we offer surgery because a lot of symptomatic patient might not have a radiologically significant lesion. Both components should be advised when we do surgery, otherwise recurrence is common. So arthroscopy has a level 1 evidence that it gives a better results with debridement or even labral repair. Thank you.
Thank you, Dr. Virender. It's a good lecture. And hereby there is the end of the complete scientific session for today. And my call upon other speakers like Dr. Rohit and Rudraraj and Virender, please, we have the stage for the presentation.
Raviteja Rudraja, please come to.
Dr. Raviteja and Dr. Rohit.
Put your hands up.
Connected.
Hello. Hello. Attention. All the delegates who are present outside, please come into the hall. AGM of the OSC is going to start. Who are not the members of the OSCs or trade people who are in the hall, they can leave the hall. Only members of the OSCs are allowed to stay inside the hall. Yeah, all state members are members of the OSCs only. What I'm saying, any other trade members or something, students like that. Yes, sir, that's right, sir. All states members are OSCs members. Own trade members కానీ వెళ్ళొచ్చు. PG లేరు కదా, sir. PG is not allowed. PG is also not there. OS members means all states. Now, I request our OSS President Dr. P. Vijaychandra Reddy Garu onto the stage to conduct the General Body meeting. I request our Roshan Kumar BN, Secretary General OSS, please come onto the stage. I request the Dr. Manjunath, Treasurer OSS, please come onto the stage and occupy the chair. I hereby request the President OSS to conduct the meeting. Thank you.
Good evening. Since there is no quorum, I think we'll wait for 5 minutes and then start the GBM.
Yeah, I request the delegates please can come here, members. So that this block we can fill up. This block.
I request all the members I invite President-elect Dr. Sivakumar sir to come onto the dais. I request all the members to kindly sign in the attendance book which is being circulated. I already posted the agenda long back, sir.
Yeah. As per protocol, we have prorogued for about 5 minutes because lack of quorum. Now I call the meeting to order.
I will take up the obituaries and then we'll rise for the silent prayer after this. We lost Dr. Adinarayan Rao from Andhra Pradesh, Dr. L.V. Raghav Rao from Andhra Pradesh again. From Tamil Nadu, this year we lost Dr. P. Soundararajan, Professor Soundar Pandian, Dr. M. Parthasarathi, Dr. Kuttalingam, Dr. Francis Roy, Dr. Shaktivel, Dr. Arul Raj, Dr. Sendil Kumar, and Dr. Ajit Sinde from Tamil Nadu. From Kerala, we lost Professor George Itik from Calicut, Dr. Karthikeyan from Kottayam, and Dr. M.P. Matthew from Kottayam. So we'll rise for a minute. Sherry and Thomas also, sir? No, that was, but that was not sent to me by the secretary, sir. This is what I got latest. So let's rise for the... Thank you. Sir, welcome.
Yeah, good evening to all of you. This is my first official general body meeting after taking over as the president of Oasis. Once again, I thank all the members for reposing confidence in me to carry out the work or the responsibility as president for the next coming year. Welcoming you all. You know that the Oasis, how it was formed and why it was formed and what's the activities. Majority are all the senior members well connected with our Oasis activities. And for the last 1 year, 3 years, Dr. Roshan, Secretary General, I request you to applaud the work carried out because tomorrow will be the last day as Secretary General. Tomorrow, Dr. Naresh from OSAP will be taking over as Secretary General in the valedictory function of Oasis. And also as organizing chairman of this Oasiscon, I thank the members for accepting to club with the state conference, that is Tosa. So that's the reason why we coined the name Tosa Oasiscon. And any democratically, any suggestions, any clarifications, any doubts, any questions can be put so that we can go ahead with our activities for the future to come. And this year theme, as I already yesterday announced, that the revisit of orthopedics with bridging the technology with the fundamentals. So that is the, then I will come out and chalk out the programs with the suggestions of the member states. The only one point which I want to tell is that unless the member states actively involve in the Oasis, we don't progress. Because we have seen, we have crossed 25 years. Where are we? We have to introspect ourselves. Only when the president, secretary of the respective states actively involve, and it is our duty as Oasis office bearers how to see that they involve in our activities to be carried out. Then only we will be strengthened, whether in our 6 states or at all India level. We know what are our goals, how we should represent at IOA level also, our one of the responsibility of the Oasis. Please keep this in mind and let us all strive hard to see that Oasis flag will be seen in all the states in a much more, stronger way. And also my best wishes to my president-elect, and they will be conducting the next and they will appeal Tamil Nadu, in his words only, after this agenda completes. I request our Secretary General, Dr. Roshan, to go ahead with the agenda. Thank you.
Thank you, sir. As it's customary, I will be showing the office bearers of the Oasis. Yesterday I've already done this in the inauguration, so I'll quickly move these slides to save time. So this is our new incoming Vice President too, Dr. Anin Kuti. You all know him very well. Due to some personal reasons, he is unable to attend this conference. He has sent his regrets for that. So he will be inducted as Vice President 2 of Oasis this year. So minutes of the last EC meeting which we had yesterday have already circulated in the EC group. If you permit, I'll skip the slide. So secretary report also done yesterday in the inauguration. So the same slides are repeated today. Financial statements, Dr. Manjunath, I request the treasurer to just give a bird's eye view.
Good evening, dear members. So this is the financial report for the
TNOA President Dr. Sundarajan sir, Secretary Dr. Marimuthu, and